researcher and participants who have joined here for Simats Neurology International Education and Research Conference. This conference is a celebration of knowledge, collaboration and innovation. Sniper provides a platform where professionals from diverse health disciplines come together to share insights, foster partnership of build pathway for advancing neurological science. The theme for conference is healthy aging. As life expectancy increases, ensuring not just a longer life but a healthier and more independent one becomes our collective responsibility. Neurology and interprofessional research plays a vital role in supporting cognitive health, mobility, and overall well-being in aging population. Today, through thought-provoking discussion, scientific session, and interprofessional collaboration, we aim to explore innovative strategies and research-driven practices that contribute to healthier aging and improved quality of life. With this spirit of learning and collaboration, let us begin this enriching journey together. Once again, I welcome you all to the Sniper 2025. To begin this prestigious conference, on a grateful note, we now present the welcome dance performance by Ms. Maithili from Simats College of Physiotherapy. Let's welcome her with a big round of applause.
இந்த நீர்நிலம் தனில் அன்பு செய்திடும் படுக
Thank you for the wonderful dance performance, Ms. Maithili. It was truly a grateful and captivating. It is now my privilege to introduce our first distinguished speaker of the day, Dr. Brijesh Raman. Dr. Raman is a highly qualified neurologist, having completed both his MD in General Medicine and his DM in Neurology from the prestigious Madras Medical College. His extensive training is further exemplified by his specialty rotation in critical areas such as dementia, movement disorders, and headache clinics, making him expeditionally equipped to speak on the today's topic. He has also honed his expertise through specialized training in neuropathology from NIHAMS and has been active participant in numerous national conferences, presenting his work to the Indian Academy of Neurology with such a profound background in the various disorders that impacts an aging population. There is no one more fitting to open our scientific session. Ladies and gentlemen, please join me in extending very warm welcome to Dr. Brijesh Raman, who will now speak on aging disorder and its medical management. We welcome you, sir.
Very good morning to everyone gathered here. It gives me immense pleasure to be a part of this interprofessional conference themed Healthy Aging. Let's begin our talk. Our topic for the day today is about the aging disorders and its medical management. So, next slide. So we will begin our talk by starting with the understanding of the basic biology of aging. Aging is actually a progressive process which is associated with a slow decline in the structure and function, associated with impaired maintenance and repair systems, as well as increased susceptibility to disease and reduced reproductive capacity. Next slide, please. The phenotypic components in aging is surrounded by primary aging changes such as sarcopenia, which is nothing but the loss of lean body mass or muscle mass, along with graying of hair, oxidative stress, and increased peripheral resistance. Various aging-related diseases involves hypertension, dementia and neurodegenerative disorders, arthritis, as well as malignancies. Next slide. A cellular process of aging primarily based on the oxidative stress and free radical mediated injury. We all know that mitochondria is the powerhouse of the cell, which is concerned with oxidative phosphorylation, leading to generation of the free radicals, leading to the megamitochondria and various generation of free radicals. As well as there is important genetic role in the aging as suggested by the progressive shortening of the telomeres and epigenetic alteration of the genome leading to impaired genetic expression. Also, the basic cellular pathologies like impaired autophagy and the proteostasis leads to accumulation of the misfolded proteins and accelerates the process of aging. Next slide. Certain tissue-specific changes in the aging involves inflamed aging and immunosenescence, which is evaluated through the raised ESR and CRP as well as increased levels of cytokines like interleukin 6. Also, the vascular system bears the brunt of the oxidative stress, leading to enhanced atherosclerosis and arterial wall stiffening. Endocrine changes leading to reduced sex steroids and growth factors leads to progressive osteoporosis as well as sarcopenia. Next slide. So we pictorially summarize the three components in the aging. The first pie diagram summarizes the biological components of aging, which involves the genetic as well as various cellular processes discussed above. Also, it is linked with various non-communicable diseases such as the dementia, cancers, and sarcopenia, osteoporosis. The last graphical representation is for the exponential increase in the mortality following age more than 60 years. So, fittingly, next slide please. Next slide. So, fittingly, we will begin our discussion with few genetic progeroid syndromes. The classical one, which is the Werner syndrome, which is characterized by the mutation in the RECQ helicase, which is concerned with the DNA repair and replication. The disease of this particular gene leads to a premature atherosclerosis and cancers and death by around 50 years of age. Yet another syndrome is the Hutchinson-Gilford progeria syndrome, similarly presents with premature atherosclerosis and scleroderma-like changes. Next slide. So our goals or the principles in the geriatric healthcare revolves around the following key principles. First, we must understand that aging is not a disease, but is a physiological process which is concerned with decrease in the physiological reserve, the term called as homeostenosis. Also, the elderly are subject to have multiple comorbidities and which are of multifactorial in origin, thereby leading a comprehensive approach for the evaluation and the management. Also, there are several conditions which are underdiagnosed and underevaluated, such as the urinary incontinence, cognitive disturbances, elderly abuse and neglect, which needs simple screening to detect them. Next slide. So we have to understand that the functional ability and quality of the life is going to be the important key goal in the management rather than the absolute cure. Also, the effective geriatric care needs interprofessional collaboration among various disciplines. Also, we must understand that the geriatric care is largely provided outside the hospitals, especially in homes, as well as during transitions to healthcare. We also need to have an understanding on the ethical issues as well as end-of-life care, which are critical aspects in caring the geriatric population. Next slide. Coming to the topic proper, that is management of the various disorders in the elderly. We will begin with a discussion on the systemic hypertension, which is the most commonly prevalent non-communicable disease in our community. However, the targets for BP management in the elderly remains controversial. Various studies tell that it has to be based upon the risk-benefit analysis. The primary reduction of the systolic blood pressure not only prevents various blood pressure related complications, but it is also concerned with reduction in the white matter changes in the brain, which improves the cognitive function of the patient. Next slide. So various societies have given guidelines for the management of the blood pressure. So the well-known communities, the European Society of Cardiology, as well as the American College of Physicians, have arbitrarily fixed the cutoff of 150 to 160 in elderly compared to the 130/80 cutoff in the in young individuals less than 60 years of age. Next slide. So coming to this, we have to have little more careful management in the blood pressure. That is, we have to titrate aggressive BP control in individuals such as patients with coronary artery disease and non-valvular artery disease. So next slide. So diabetes is the next important disease which we encounter. The diabetes is nothing but a non-communicable disease which is highly prevalent in about 25% of the individuals in our community. Also, the individuals more than 80 years of age are vulnerable for hypoglycemia, and hence a patient-centered approach is required for the management of the hypertension. So we have to understand that the hypoglycemic episodes in elderly are mainly because of the irrelevant intake of food as well as irrelevant intake of medications as well as progressive renal failure in them. Hence, the hypoglycemic episodes can be controlled by having a target of HbA1c, which is the glycated hemoglobin, 3-month average of the glycated hemoglobin around 7.5 to 9%, rather than a strict control less than 7.5%. Also, the individuals must undergo screening for the chronic microvascular complications such as the neuropathies, nephropathies, and the retinopathies. So this tabular column summarizes the various drugs which are commonly used in the management of the diabetes. First, to begin with, the medications such as metformin is the gold standard and the first preferred drug, and has a significant benefit of avoiding hypoglycemia. However, they have limitations in patients with renal failure. The most commonly and recently introduced drugs, which are the SGLT2 inhibitors, which includes various empagliflozin, dapagliflozins, have the advantage of also preventing hypoglycemia as well as can be safely used in individuals with cardiovascular comorbidities. Again, the gold standard drug insulin must be used as a single dose basal bolus regimen as and when possible to minimize the hypoglycemia and also to prevent the pain or the difficulties in recurrent injections. Next slide. Next slide, please. So next, coming to the another common non-communicable disease, which is the hyperlipidemias. So the hyperlipidemias are, that is dyslipidemia. There is good evidence that introduction of statins, that is HMG-CoA reductase inhibitors, may be beneficial in people less than 75 years of age, thereby preventing them from various cardiovascular comorbidities. However, the use of statins more than 80 years of age is highly contributory or highly critical, and it is subjected to debate in literature. There is no evidence from randomized control trials to advocate the use of or beginning of the statins after the age of 80 years. Therefore, continuing statins in older individuals with end-stage illness does not make any clinical sense. Next slide. Next slide, please. So we have to be very careful in managing the complications of statins such as myositis and rhabdomyolysis, which can occur because of the reduced muscle mass in the elderly. So next slide. So osteoarthritis is nothing but the age-related degenerations seen in the bone, and which can be managed with a non-pharmacological interventions such as stretching, strengthening, massage, and therapeutic electrical stimulations. The topical NSAIDs are preferred for the management. However, acetaminophen, which is nothing but paracetamol, up to 1 gram 4 times a day can be well tolerated. However, when other NSAIDs are used, there is increased risk of GI bleed, and it is potentially not used. So, surgical interventions like total knee replacements in centers of expertise is preferred over the medical management in the management of the osteoarthritis. So coming to the next disease, which is anemia. So anemia is quite prevalent in the elderly, and all anemic elderly individuals must be evaluated for basic evaluations like complete blood count, peripheral smear, reticulocyte count, as well as serum iron levels. So serum ferritin can be an important marker in distinguishing the iron deficiency anemia along from the anemia of chronic disease. Next slide. So we have to have a note on the microcytic indexes to suggest for the occult blood loss which can occur due to GI malignancies. Also iron deficiency which must be attended to. Next slide, please. So we have to remember that their unexplained anemia of aging may be responsive to erythropoietin, which is a hormone which is responsible for the proliferation of the erythrocytic progenitors. And the threshold for red blood cell transfusions must be kept at the range of 8 milligram per DL when there is acute blood loss when compared to the 7 milligram threshold kept for the healthy adults. And in patients with acute cardiovascular comorbidities, the target may be as high as 9 milligram per deciliter. Next slide. So coming to the core geriatric syndromes, falls are one of the most commonly encountered syndromes in the elderly. The falls reflect the inability to remain upright due to an postural challenge in the elderly. So the various systems in the neuroaxis such as the neuromuscular system, sensory, vestibulocerebellar and cognitive systems are implicated in the falls. So impacts of fall include fear of falling, fractures and subdural hemorrhages which can be detrimental in the outcome of the patients. Any fall more than once over a period of 6 months need thorough evaluations. So this is a prototype for the evaluating falls. So first, any individual with a fall more than once in 6 months has to be evaluated detailed, and they must be checked for the history of falls, the drugs which are they using, gait and balance disturbances, cognitive changes, any changes in the visual acuity, their muscle strength, their heart rate and rhythm, postural hypotension, then environmental hazards must also be addressed too. These patients must be periodically reassessed as well. So the physical examination in such patients centers around the analysis of the various physical comorbidities as well as the cardiovascular system examination, neurological system examination, and also the analysis to the observation of the gait and postures. Next slide. So how will you approach or manage these patients? Any patients with arrhythmias contributing to falls must be treated with antiarrhythmic drugs, and also electrophysiological studies must be done, and radiofrequency aberrations of the aberrant tracts leading to arrhythmias must be done. And also, patients having postural hypotension can be treated with adequate hydration and the stockings, graded stockings, and drugs like midodrine and droxidopa. Also, certain other involvements in the form of the other systemic involvements must also be addressed too. Next slide. So coming to yet another important entity, which is the polypharmacy, that is using of more than 5 to 8 drugs in an individual leads to a lot of confusions as well as drug-related complications. Therefore, careful prescription audit or reconciliation must be done every time a patient visits the hospital or when he changes the caretakers. Next slide. A few important guidelines in geriatric prescription writing. First, we have to use only drugs when and needed. We must know the pharmacology and pharmacokinetics and dynamics of the drugs which are commonly used. Next slide. We have to be very much careful regarding the starting of the doses, which must be as low as possible to prevent drug interactions. Next slide. So de-prescription is one of the important aspects in the geriatric prescriptions. So we have to critically audit the prescription and try to withhold all the diuretics and hypotensive agents in patients having postural hypotension. We must prevent the over-reliance on the anti-anxiety and hypnotic drugs, and also try to reduce the long-term use of proton pump inhibitors like omeprazole, which can lead to increased risk for pneumonia, osteoporosis, and progressive dementias. Also, cholinesterase inhibitors and mementamine need not be used in long term for the major cognitive disorders. Next slide. So coming on to the cognitive impairment, which is most commonly encountered in about 40% of the hospitalized elderly patients, and we have to identify the predisposing and precipitating factors in them. The most validated measure for assessing the delirium is the confusion assessment method, which assesses the acute onset and fluctuating course of the illness. Next slide. So the management of delirium centers around identifying the underlying stressor, as well as as and when needed, we have to tolerate a low dose haloperidol can be used. However, benzodiazepines are not preferred. When used, must be used as a short-acting, low-dose drugs. So coming to the bladder disturbances, which are quite commonly seen in the elderly, they can be of approximately seen in 1 in 3 women or in about 20% of the men over the 65 years of age. The most common symptom is the overactive bladder, which presents with increased urgency, urinary frequency, and frequent nocturia. So incontinence can also be associated with various social isolation and depression, leading to a precipitation of various other hygiene-related and traumas. So next slide. So one of the important characteristics which we have to measure is a post-void residual volume, which can be measured with a simple ultrasound, and any volume more than 200 ml is always abnormal and needs to be evaluated. So coming to the pharmacological management, it is centered around the various receptors located in the bladder, which are the alpha adrenergic stimulation, alpha agonists, alpha blockers, anticholinergic and antimuscarinic drugs. Next slide. So the various incontinences can be managed primarily with the Kegel's exercises, as well as the alpha agonists, alpha blockers, and the intermittent self-catheterization can also be our principle in management. Next slide. So coming to the sleep disorders, which is quite commonly seen in the elderly due to the age-related disruption of the sleep architecture. The 4 common patterns of sleep disturbances seen include insomnia, sleep-related breathing disorder or obstructive sleep apneas, restless leg syndrome, periodic leg movement disorders. Next slide. So the insomnia is very common, and the individuals have tendency to reduction in the tendency to fall asleep, and seen in about 30% of the older individuals. This insomnia is associated with various depressions, anxiety, and ingestion of certain caffeinated beverages. Similarly, obstructive sleep apnea is seen in about 10% of the individuals with multiple medical comorbidities such as obesity and congestive heart failure. And restless leg syndrome is a commonly seen and is associated with iron deficiency anemias. Next slide. So the key important management in the insomnias includes sleep hygiene, which is nothing but maintaining an appropriate environment for facilitating sleep and avoiding caffeinated drinks, keeping a regular bed routine as well as the individual must be entitled to go to sleep only when felt sleepy and must not remain in bed for more than 20 minutes if he is having insomnia or reduced tendency to fall asleep. And they have to follow routine schedules and avoid naps in the afternoons. Next slide. Hereby, we conclude that the clinicians must be having a clear understanding on the aging biology in order to have better management and care for the elderly people. Moreover, there is an urgent need to develop strategies based on aging biology that delay aging as well as reduce the onset of age-related disorders, thereby increasing the healthy span of future generations. Thank you.
Thank you so much, sir. To continue our exploration of healthy aging, we now turn from medical management to pivot role of surgical intervention. It's my honor to introduce our next distinguished speaker, Dr. Satish Anand VS, sir. Dr. Satish is a highly accomplished neurosurgeon with credentials that speak to a truly global expertise. After his MBBS, he completed rigorous 6 years DNAB in neurosurgery. He honed his skill further, exercising as a fellow in minimally invasive and endoscopic spine surgery in South Korea. With over 7 years of experience, his practice is dedicated to managing the most complex brain and spine conditions. His special interests are particularly relevant to our aging population, including awake brain surgery, endoscopic procedures, and minimally invasive techniques that prioritize patient recovery. As a member of an enormous prestigious neurosurgical society and a contributor to the academic literature, is respected voice in his field. Please join me in giving a very warm welcome to Dr. Satish Anand, sir, who will now present on neuro investigation and surgical management in aging brain. Thank you.
Go back now. Check, check. Okay. It's not. Do you have a stick or something? Stick. Okay, I will change the slides. Okay. Yeah. Yeah, very good morning to one and all present here. So here you can see a slide showing it's an MRI brain. It's a T1 sequence, axial cuts. We can see a very fascinating image of Lord Vinayaga sitting right inside our brains. So actually, this is not pareidolia, it is an AI-generated image. So this highlights the complexity and symmetry of our human neuroanatomy and our perception. So I'm pleased to be here with you all on this very special day, and my talk is on aging brain and the scope of neuroimaging and neurosurgical management in brain aging. So please bear with me for the next 20 to 30 minutes. I'll try to make it interesting. So in this slide, we are able to see two brain specimens. So I think most of us will be able to guess which is the old brain and which is young brain. Which is old here? Anyone? So on your left side. So on your left side is the old one, and on your right side is the young brain. So we can easily find it out that the difference between the old and new, so old and young, based on, you can see the old brain, you can see the atrophy of the brain has shrunken, and you can see the young brain, you can see it is more fleshy. So the brain aging, it undergoes a distinct physical, chemical, functional changes that affect cognition and overall neural health. So, going further into core neurosurgical concepts, I'll first give you some insights about brain aging. It's not working. Next. So, as we all know that this is the era of rise in elderly people. So the rise of aging brain, the world is growing more and more older. So why this is because if you speak globally, we can see there's a lot of advancements in medicine, public health, okay, nutrition, and this has created increased global population and thereby increasing the life expectancy. It has tremendously increased in the over past 2 to 3 decades. Now it is more than 75% actually. So as we all know that the dementia and other neurodegenerative diseases are more than 5%. It's actually more than 5% in the elderly population, and thereby we can see the number of dementia patients has been doubled or tripled in the last few decades. So, next. So before going into the brain, we will go into the basics. So neurons. The neurons are post-mitotic cells. So what is meant by the post-mitotic cells? They are like super specialized cells. They are not normal cells. So like neurons, cardiac cells, and our skeletal muscle cells, they are super specialized cells. So these cells have permanently exited from the cell cycle. They don't divide further. Once for all, they are being fully developed. So why it has been made like that? So these post-mitotic cells provide very good functional and structural integrity for the brain. They are more potent cells. So when these cells over a period of time, as our age increases, as we grow older, so what happens is that there will be two things. The one is that RB deficiency. RB deficiency is nothing but a retinoblastoma protein deficiency. That will trigger this neuron to go into cell cycle. So they will replicate the DNA, they will be having increased proteins, all those things. And once they go into the cell cycle, they die. Okay. So, and other thing, when the adult neuron receives mitotic stress, when they go into this mitotic cycle, they ultimately die. Okay. This is the natural history of each and every neuron in our brain. So, so these neurons require regulation systems so that to keep up the level of neuronal activity that maintains our neuronal network. So this dysfunction happens because of this energy, the metabolism dysfunction happens, and this jeopardizes the system and it results in aging. Next. So what all changes we can see in brain aging? So there are 3 A's. One is atrophy, another one is alteration and accumulation. So this slide has been already discussed by our previous speaker. So I will go fast. So atrophy is nothing, go back please. So atrophy is nothing but the white matter and the gray matter atrophy that happens in our brain. Alteration is the alteration of neurotransmitters. Accumulation is nothing but the accumulation of the debris, that is the degraded proteins, abnormal pigments, and defective genes that will be accumulated. So you can see the various processes that leads to brain aging is oxidative damage, epigenetic alterations, telomeric attrition. Telomeric attrition is nothing but a shortening of telomere. Usually it happens in other cells, but in neurons also it is supposed to be happening. The telomeric attrition that leads to a lot of degenerative diseases. And the loss of proteostasis. What is proteostasis? It's nothing but protein hemostasis in our body. Then inflammation, mitochondrial dysfunction, nutrient sensing problem. This happens in old people with metabolic diseases. So they have nutrients, but body is not able to sense the nutrients. An altered cellular network, stem cell exhaustion, and neuronal senescence. These are the possible reasons for our aging. Next. And I need to emphasize on this point that not many people know about this. This is called, this is chronic positive energy balance. So what is this? It is a state where the energy intake exceeds the expenditure. So as a result, what will happen? We will have a lot of positive energy within our body. In one way, everyone feels that, yeah, we have a lot of positive energy, it is good. So actually it is not. It is good for only children, young people. Once we are adult, this is not good for us. So this actually creates neurodegenerative diseases. It accelerates brain aging, mitochondrial dysfunction, neurotoxic accumulation, and inflammation. It also impairs neuroplasticity. So this chronic positive energy balance is not good for us. We should be always on demand. Our energy should be always on demand. Next. So now we are going to the structural aging. So you can see the picture on your left. You can see the left side is normal and the right side is abnormal. We cannot say it as normal and abnormal. The left side is young, the right side is old. So our neuroscience PGs will be knowing. So you can see the ventricular enlargement. You can see on the left side, it's a normal ventricle. On the right side, you can see the ventricles have enlarged. And you can see the cortical thinning. Number 2. You can see on the left side, the gray matter is thick. On the right side is gray matter is thin. You can see the white matter volume loss, number 3. And you can see in number 4, the sulcus has widened and there is increased sulcal depth. And this is the corresponding MRI images showing the ventricular dilatation, sulcal widening and sulcal depth and volume loss. So these are the things that happen structurally: gray matter and white matter volume loss, cortical thinning, ventricular enlargement, sulcal widening, increased sulcal depth, loss of gyrification, demyelination in white matter, and neurodegeneration in gray matter. Next. So coming to the white matter. So these are the things that happens in our white matter. So first thing is that small vessel disease. This is very common. You can see there is a yellowish spot in the artery. And this very commonly happens, and usually this is asymptomatic. Usually we used to read a lot of MRI scans, the small vessel ischemic changes in the brain, and all the general public will get frightened by seeing the report. So you do not have to worry about this report. It's a normal aging process. And next one is that demyelination. It happens in elderly people, the loss of myelin sheath, the nerve fibers. And next is the microbleeds, the tiny spots. And these tiny spots will be seen in MRI as a white matter hyperintensities. That will show it in the next slides. And the number 4 is the leukaryosis. That happens close to the ventricles. You can see that is the bluish one is the ventricle. It's a periventricular, you can see the leukaryosis. And this is also normal finding you see in the aging process. Another one is the small lacunar infarcts. Okay, so these are the white matter changes that we see in our whole brain. Next. And now we are going to the neuroimaging. So neuroimaging is a basic modality of evaluation in brain aging. Okay, next. So the MRI has a lot of sequences. I will tell you some basic sequences that is relevant here. The first sequence is a T1 weighted MRI. In T1 weighted MRI, you can see the difference, contrast differences. You can see the gray matter looks gray and the white matter looks white. You can see the ventricles, there is like a butterfly inside. The ventricles look black. Okay, this T1 weighted images, we should be able to identify very good gray matter and white matter differences. So you can see the difference between the 20-year male and 60-year male, 20-year female and 60-year female. Next. Another sequence is at T2. In T2, we need to see the T2 flare sequence, that is fluid attenuated sequence. So in this sequence, we will be able to see what I told, that white matter hyperintensities. You see the periventricular areas, the white patches. So these are the white matter hyperintensities. The demyelination, small vessel ischemic changes, leukaryosis, everything will look white in T2 flare. Next. And this is very interesting. This is the diffusion tensor imaging, MR-DTI. So here we use this DTI in old people to look for the white matter integrity, how the fibers are aligned, how healthy the fibers are all. So here we use key metrics like fractional anisotropy and mean diffusivity. So there's nothing big in this. The fractional anisotropy is that the water molecules, how fast the water molecules move along the nerve fibers. That is the anisotropy. And mean diffusivity is nothing but how slow the water molecules move. So in aging brain, that people who have dementia and Alzheimer's disease, there will be increased mean diffusivity and reduced fractional anisotropy. These are the two basic things that we need to know. And you don't need to worry about these color codings and all. The green color is nothing but the fibers that are running anterior to posterior. The red is nothing but the fibers running left to right. And blue is nothing but the fibers running from top to bottom, superior to inferior fibers. Next. We are not able to see the image here. Back. One image is missing. It's okay, fine. So here we had an image like Alzheimer's disease patient. In the hippocampal area, we can see the reduced fractional anisotropy and mean diffusivity. Classically, we can see in the hippocampal area. And next is the functional MRI, fMRI. So fMRI uses a specific sequence that is the T2 weighted. In T2, we use gradient echo, GRE sequence. So in this GRE sequence, what it detects is that the area where there is good oxygenation in the brain. So here we used to ask the patient to lie down in the MRI gantry, and we used to make him to do specific tasks, ask certain questions. So based on that, we used to catch up these images. So this is very useful for the assessment of cognition. Okay, we used to do it for brain tumors, for planning the approaches and all. For in old people, to assess the cognition, we can do this fMRI. It gives some good idea about how the cognition is functioning. Next. Next slide. Okay. Now coming to PET. PET is positron emission tomography. You can see these three images. One is normal, one has mild cognition, another one is Alzheimer's. You can see three different kinds of colors, the blue, red, and green. So you can see in the first image, you have a lot of red. Second, it's almost equivocal. And in third, you can see a lot of blue. What is that? Is that the red is hypermetabolism. Perfusion is good. And in the blue, it's less perfusion. So in this way, we can detect how good is the brain. Next. So what we'll do is that in this PET, we used to infuse certain protein-specific tracer, and this tracer goes to certain areas where there is good uptake in the brain, and based on that, we'll be able to catch up certain pictures. So in Alzheimer's disease, what we do is that FDG PET, that is fluorodeoxyglucose PET CT. So we can see the reduced glucose metabolism areas. So there we used to inject this fluorodeoxyglucose and catch up images. You can see there is reduced perfusion in those places. Next. And this is one latest recent advances kind of thing. It's based on the amyloid deposition as a biological marker for Alzheimer's disease. So we can see that the amyloid is nothing but an abnormal protein that deposits in our human brain as we grow older. So based on this basis, so we can inject certain traces, radiolabeled ligand targeting the amyloid, and we can take the pictures. You can see here, in the normal, we have very less red. That is because there is very less amyloid deposition. You can see in Alzheimer's, you can see there is huge deposition of the amyloids. So this is the latest marker. In vivo, we are able to diagnose Alzheimer's. Before we used to do in the post-mortem, now we can do in vivo. Next. So this is a summary of all the neuroimaging. MRI. In MRI, we see atrophy of the medial temporal lobe in Alzheimer's and temporal neocortex specifically, and FDG PET, and SPECT. SPECT is nothing but the single photon emission computed tomography. SPECT and PET is more or less same, but in SPECT, the resolution is less. The advantage of SPECT is less radiation is used compared to PET. And in DTI, we can see the white matter integrity. In amyloid imaging, we can see the amyloid deposition in the cortex. So now coming to the Parkinson's disease, I can cover only few very interesting topics, that is very relevant topics in these 30 minutes. So now we can see the symptoms. We can classify into motor and non-motor symptoms. So in motor, as we all know, bradykinesia, vocal symptoms, rigidity, postural instability, tremors, gait difficulties, dystonia. And in non-motor, usually we won't see much, but actually it's very important. Non-motor, we see cognition, behavioral disturbances, depression, and the sense of smell. So this sense of smell is very important because before the development of motor symptoms, this develops earlier. And this will predict that this patient is going to get Parkinson's. So maybe 3 to 4 years before development of motor symptoms, they will have this loss of smell. Another one is sweating and melanoma. Sweating, either they can have hyperhidrosis and hypo also sometimes, and they are more prone for melanoma because the POC gene is linked to melanoma. And gastrointestinal issues, pains, so these are all the non-motor symptoms. Next. So these are the various etiological factors for Parkinson's disease. The first thing goes to lifestyle, environmental factors, and the second one is toxic and pollutant exposure. Usually we see in farmers, village population, where they use a lot of pesticides and fertilizers, and it's very, very important etiological factor for Parkinson's disease. Another one is genetic factors, and oxidative stress, mitochondrial dysfunction, and certain things are idiopathic, aging, neuroinflammation, and lysosomal dysfunction, gut microbiome, and metabolites, abnormal metabolites, and these everything put together causes Parkinson's disease. Next. So this is a bird called as swallow bird, and you can see the swallow's bird tail. Okay, this is a characteristic sign that we see in our MRI. You can see in the midbrain. You can see that two arrow marks. That is actually substantia nigra. You can see the substantia nigra. It resembles like a tail of this swallow bird, and this is called swallow tail sign. And usually it is present in normal population. It's present in every one of us, but it is absent in neurodegeneration, specifically in Parkinson's and Parkinson's plus, progressive supranuclear palsy and Parkinson's diseases. You see in 1B image, the tail is absent. Okay, this is a characteristic MRI finding that we can see in Parkinson's. Next. Next. Otherwise, most of the MRI brain will be normal in Parkinson's disease. Sorry, there is some technical glitch. Yeah. Next, yeah. So coming to the surgical intervention criteria, now we're going into the neurosurgery concepts. So I'll just give you some gist. So not every patient with Parkinson's will take him up for surgery. So there are some selection criteria that has been devised. Okay, the first one is CAPSID PD that has been introduced in 1999. Now that one is the latest DBS guidelines that was introduced in 2020. Next. So CAPSID PD is the core assessment program for surgical intervention in Parkinson's disease. So here we have certain parameters. One is UPDRS score, that is Unified Parkinson's Disease Rating Scale, neuropsychological and cognitive testing, and Montgomery and Asberg Depression Rating Scale, levodopa, apomorphine challenge test. So based on this test, we used to select the patients for surgical intervention. So here the major differences, why the modern DPS guidelines came is that the CAPSID PD is very strict. So out of 10 patients, you can say out of 100 patients, we can select only 1 or 2 patients for the DBS program. So it has become very strict and it excludes a lot of patients. So what happened is that, and people devised the modern DPS guidelines that includes more subset of patients. So here there's the major differences. You can see the levodopa challenge test. So if there is more than 33% improvement in UPDRS, will be taken up. But here, if it is equal or more than 30%, will be taken up for DBS program. Okay, next. So now we're going to the steps involved in deep brain stimulation. So deep brain stimulation is nothing but putting an electrode inside our brain in the specific targets, and this electrode will be stimulated by the IPG, that is implanted pulse generator. So this is actually, we can call it as a pacemaker of the brain. So it has been approved by FDA for essential tremors and Parkinson's disease since 1997. You can see the electrode that has been gone into the thalamus, and the wire, usually that wire goes and connects the pulse generator. That usually we will be keeping it in the anterior chest wall. Next. So what does it, how does it act? What is the actual mechanism? The actual mechanism is still not established, just certain theories are there. One is the modulation of abnormal neuronal oscillations, disruption of pathological circuit, and neurotransmitter release modulation. These are all the proposed theories that has been accepted for this DBS. Next. So targets, what are the targets we will select? So you can see, one is VIM, so ventral intermediate nucleus of thalamus, Another one is subthalamic nucleus, substantia nigra, GPI, that is globus pallidus interna. So these are the various target points that is usually selected for tremors and Parkinson's disease. So here in subthalamic nucleus, why we select this? For tremors, rigidity, and bradykinesia. So GPI we select for dyskinesias most of the time, and VIM for tremors. So in these electrodes, we can see it has two varieties. One is bipolar and monopolar. The monopolar has a maximum coverage area. Bipolar will be more specific. Next. So how do you put the leads into a brain? So that it is actually not a very skilled thing. We need a lot of homework. Actually, a lot of calculation actually. So you can see these frames. There are two types of frame. One is the Lexel frame, one is the BRW frame. So these frames will be fixed to the patient head. Patient will be awake. We will give some local anesthesia. And after injecting local anesthesia, we'll fix this frame to the patient's head and we'll take him up for the imaging. We can do either CT, and nowadays we do MRI because a lot of frames have become MRI compatible nowadays. So we'll take the patient and we'll do MRI and we'll be calculating the coordinates so that we reach the target just like a sniper. So once we reach the target, calculate the coordinates, we'll take him to OT. Even in, usually we don't do in general anesthesia, the patient will be awake, sometimes in awake sedation. Sometimes when the patient is not cooperative or anxiety or something, we give GA. So frame placement, target localization, electrode implantation, and intraoperative testing. This is very important. So here we have to calculate the amplitude of the current that we give. Usually we give 2 to 4 volts, depends on the patient's symptoms, and the pulse, in how much of pulse width we give, usually 60 to 120 seconds, microseconds, and the frequencies usually more than 100 hertz we give. So we have to calculate this amplitude, frequency, and the pulse, and we need to connect it to the IPG. So it's actually a very simple procedure, but target localization and testing is very important here. And benefits, there is a significant improvement in motor, reduced dyskinesias, and reduced need of medication. This is very important. You can see a lot of patients, they take 10 to 15 medications per day, and it will reduce to almost 1 to 2 medications. And improved quality of life. Next. So this is very, very important and very interesting also. This thing called as normal pressure hydrocephalus. As the name suggests, the pressure is normal. So even we used to know the hydrocephalus, there will be increased accumulation of CSF in the brain, the pressure will be more. But here in this, it is not like that. The pressure will be almost normal. It is called normal pressure hydrocephalus. It is a very, very interesting because it will reverse our brain age. So you can, even I've seen patients telling that my age has reduced less than 10 years younger I have become now after the surgery. They'll be very happy. Next. So it is a potentially a reversible cause of dementia, and it's the most common form of hydrocephalus in adults. So what is this clinical features? There is a well-known triad called Hakim and Adams triad. So in this triad we see wet, wacky, and wobbly. The wet is nothing but you will have urinary incontinence. Wacky is reduced attention span, that is dementia, and gait. You will have ataxic gait. It's more of apraxia. It's a broad-based, short-stepped gait. There's a very characteristic gait for NPH. So this is the triad. Once we see the triad in these patients, we will subject him for certain tests before doing for surgery. Next. So pathophysiology, hypodermic flow across the cerebral aqueduct, increased pulse pressure. It is not increased production of CSF, it is increased pulse pressure, reduced reabsorption of CSF, and reduced cerebral blood flow. These are all the pathology physiology that is involved in NPH. Next. And this is a very interesting slide. You can see the gait pattern of NPH and the gait, normal gait, and Parkinson's gait. You can see the differences. People you often confused from Parkinson's gait and NPH gait. The both are different. It looks similar but different. You can see the foot. It's a wide-based gait. Parkinson's gait will be the wide-based gait. Though it has a short stance and short stepping gait, it has a wide-based gait. But in Parkinson's, it is not a wide-based. It's a narrow-based gait. Okay, next. Next slide. So we will subject him for MRI. In MRI, what we need to find it out is that MRI CSF flow study. The CSF flow study is nothing but we need to see how much of CSF is flowing on. You can see the arrow mark. That is the cerebral aqueduct. So in that cerebral aqueduct, how much is the CSF is flowing? So we need to see the parameters like the flow rate and stroke volume. If the flow rate is more than 24.5 or the stroke volume is more than 0.5 ml per cycle, then the patient will benefit from surgery. Otherwise, patient is not going to benefit. This is a very important imaging that we need to do before taking up for surgery. Next. These are the other morphological changes that we see. One is the Evans index. It's nothing but calculating the frontal horn diameter with the maximum biparietal diameter. And if it is more than 0.3, then there is hydrocephalus. Another one is callosal angle. The callosal angle, if it is less than 90 degree, then it is characteristic. And there will be a disproportionate subarachnoid space. You can see the Sylvian fissure on the either side. You can see the left side it is bigger and the right side it is smaller. This disproportionate subarachnoid space atrophy, it also signifies NPH. Next. Yeah. So another one is, next we'll go for invasive diagnostic test. What is that? Is that we will do lumbar puncture. So usually the site of lumbar puncture will be L34 or L45 spinal subarachnoid space. So in this lumbar puncture, either we can do two types of tests. One is the tap test, another one is continuous drainage. In tap test, what we used to do is that we will put the LP needle, we will drain out the CSF. Usually it's 30 to 70 ml of CSF will be drained out. And this can be repeated in consecutive days or a single sitting is also fine. And some people, they used to do continuous lumbar drainage for 2 to 7 days. On average, they used to do it for 5 days. And in these two tests, what we do is that we used to check the gait, pre-test and post-test. Okay, so I will show you a video now. Next. So this is one of our patient. And in this patient, this is the first video taken before doing a tap test. You can see his gait, you see, the wide-based gait, short stepping, wide-based. This was a pre-test. Okay, and this is the post-test. You see, he is walking without support. And this patient is a candidate for shunt or the CSF diversion. Next. Next slide. Yeah. Coming to the ventricular peritoneal shunt. Ventricular peritoneal shunt is nothing but placing a ventricular catheter into the ventricles and diverting the CSF right into the peritoneum. And the tube will be tunneled inside the subcutaneous plane. It won't be visible outside. Next. So the shunt systems, we have different types of shunt systems in the market. The one thing is the cheaper system that has a fixed shunt. We have medium pressure, low pressure, and high pressure shunt. Another one is that programmable shunt. So cost difference is huge. This is like 5,000 means that is 1.2 lakhs, but is worth. So what is the difference is that here we cannot adjust the pressure. Once the shunt has been placed inside the patient's head, it is done. We cannot change the pressure at any time. But there, in that programmable shunt, we can change the pressure whenever we need based on patient's clinical features. Okay. So this is the programmer. So after placing the shunt, when the patient clinical symptoms are going down, so based on the imaging, we will see we need to increase the pressure or decrease the pressure. So we can ask the patient to come to OPD and keep this electromagnetic device exactly over the reservoir where the shunt has been placed, and we can adjust. It's like a dial. It has a pressure settings like 30 to 180. So whichever pressure we want, we can set it. It's just 10 seconds procedure. See, this is a very simple thing, and it is very beneficial for the patients. And this is a comic chart that comprises everything about NPH. You can see here the hydrocephalus. The patient has a magnetic gait, urinary incontinence, dementia. We will do the lumbar tap test. After the tap test, if it is positive, we can do the shunt. After shunt, patient becomes normal. Okay? Next. So, and this is another procedure called endoscopic third ventriculostomy. So, this is generally done for other causes of hydrocephalus like obstructive hydrocephalosis. But in NPH, it's very less commonly done because the benefit is less compared to shunt, but in cases where we are not able to put the shunt, we do this procedure. This procedure is nothing but putting an endoscope. This is endoscope. We are putting directly into the ventricle. We are going into the third ventricular floor and opening the floor of the third ventricle so that we are diverting the CSF that is inside the ventricles to the subarachnoid space. Next. So this is a picture that we see. The water, a black hole is that foramen of Monro. And this is the lateral ventricle. Once you go into the foramen of Monro, we can see this one. This is the floor of the third ventricle. The two white thing is the mammillary bodies, and the transparent membrane is the floor of the third ventricle. So our job is to open the floor of the third ventricle. I'll show you a video. Next. So this is the video showing the endoscopic view of the lateral ventricle. Play. Not able to play? So I think it's not able to play. So here you can see this is the lateral ventricle. The hole is the foramen of Monro. It's the choroid plexus. We go into the floor of the foramen of Monro and we'll open the floor of the third ventricle using a catheter. So this is also very beneficial procedure for other causes of hydrocephalus and less commonly done in normal pressure hydrocephalus. Next. So we are concluding now. So brain aging is inevitable. Almost everyone's brain is going to age at one point of time. So this brain aging, it can be tackled. When there is abnormal brain aging, we can be tackled by advances in neurosurgical techniques and interventions, and it gives possibilities for improving function and quality of life. And finally, what we need to understand is that our goal is not to add years to life, but to add life to years. Thank you.
Thank you so much, sir, for your valuable insights.
and Palliative Care Department of Savitha College of Physiotherapy, Simats. We captured the vibrant campus life that makes Savitha so special. Beyond academics, student life here has been filled with meaningful experiences.
மனிதே வெளியேவா, மனிதன் என்ற சொல்லுக்குள்ளே அடங்காதே பெண்ணே, உயரம் உனதேதான், அவன்தான் உயரம் தெரியாது, நீ நிமிர்ந்தேவா பெண்ணே, மனிதே வெளியேவா, மனிதே மனிதே
சொல்லும் சதத்தான் நான் கேட்கும் வர நாமாவும் மாய பறவைகளே.
May I invite everyone present here to stand and join me in welcoming our honorable delegates, respected Chancellor Sir, Vice Chancellor Sir and the Registrar.
அரங்கம் அதிரட்டுமே, விசில் பறக்கட்டுமே, now கரங்கள் வசரட்டுமே, தேக்கோ வழக்கு மொத்தமே now. குழந்தை சிரிப்புள்ள பேசுதா, இமயம் மல்ல போல மாசுதா, மனச பறிக்கிற கிரேசுதா, ஜெனசி ஒன்ன பத்தி பேசுதா. குக்கு குக்குலி பவா ஹவுசே, என்னைக்கும் குறையாத மவுசே.
To officially commence the inaugural proceedings of this conference and to celebrate the vibrant spirit of collaboration, it's now my pleasure to invite you to enjoy a gracious welcome dance, a performance dedicated to welcoming each of you and blessing this gathering. Please put your hands together for talented Vaishnavi Devi to perform the welcome dance.
வணங்கியே வரவேற்போம் வருகவே, செந்தமிழில் கவி பாடி உளமாற வரவேற்போம்.
வருகவே வருகவே வணங்கி பாடுகின்றேன் வருகவே 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 வணங்கி பாடுகின்றேன் வருகவே. அழகு தமிழ் கொண்டு உம்மை வரவேற்றோம், இனிய முகம் கொண்டு உம்மை வரவேற்றோம். அழகு தமிழ் கொண்டு உம்மை வரவேற்றோம், இனிய முகம் கொண்டு உம்மை வரவேற்றோம். வருகவே வருகவே வணங்கி பாடுகின்றேன் வருகவே 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 வணங்கி பாடுகின்றேன் வருகவே. பாட்டு பாடி இங்கு வாழ்த்துவோம். சங்கத்தமிழ் பூங்காவிலே சந்தம் தரும் பூவெடுத்து கவிச்சாரம் சூட்டி உமை வணங்குவோம். 8 தொகை சேர்த்தெடுத்து செந்தமிழின் சொல்லெடுத்து 10 பாட்டு பாடி இங்கு வாழ்த்துவோம். சங்கத்தமிழ் பூங்காவிலே சந்தம் தரும் பூவெடுத்து கவிச்சாரம் சூட்டி உமை வணங்குவோம். அவையோரே வாழியவென்று சபையேறி வாழ்த்திட வந்தோம். சனிதனிதா பதா பம பம ககம பசனிதனிதா பத பம பம கரி. வருகவே வருகவே வணங்கி பாடுகின்றேன். வருகவே 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 வணங்கி பாடுகின்றேன். வருகவே.
Thank you for the wonderful performance, Ms. Vaishnavi Devi. I request respected Vice Chancellor Sir, Registrar Ma'am, Principal of all colleges to join us on the stage. Please, ma'am. To continue with our inaugural ceremonies, we will now begin by paying our respect to our motherland and our rich cultural heritage. Ladies and gentlemen, kindly rise up for Tamil Thai Vaalthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற
Thank you. Please be seated. The commencement of our gathering today is marked by cherished tradition. The lighting of the lamp, this ritual, steeped in profound symbolism, represent our ascent from ignorance to knowledge, from the confusion to clarity, inviting, illuminating wisdom into our mindsets. We are absolutely honored to invite to kindly flame on the enlightenment and official inaugurate our event. As the lamp is lit, may its radiance touch each one of you, kindling in you the immortal flame of knowledge and understanding. The glowing beacon significance or resolves to disciples darkness and spread light. Our sincere gratitude to all for setting the tone and energy for the rest of the day. As the lamp continues to burn brightly, let it serve as a constant reminder of our individual and collective commitment to acquire and share knowledge, and to illuminate the path of those we interact them. So, with the language of light speaking equivalence in our event, let's set our journey. The foundation of successful event is laid by a warm, inspiring welcome. It's now my privilege to invite Associate Professor Dr. Vignesh Sir to come forward and deliver the welcome address.
A pleasant and a vibrant morning to one and all gathered over here. On this meaningful day, it is very pleasant to see lots of colors from various parts of the countries representing the field of physiotherapy, occupational therapy, allied health sciences, and nursing. So it is my privilege to welcome everyone on this dais and this auditorium. I take immense pleasure to welcome our Vice Chancellor, Dr. Ashwani Kumar Sir, for gracing this occasion. And I also welcome our Registrar Ma'am, Dr. Shija Varghese Ma'am, for pleasantly accepting our invite and coming to honor this session. And I welcome the principals of Savita College of Physiotherapy, Dr. Pratap Sir. And I also welcome Savita College of Occupational Therapy, Dr. Arun Sir. And I also welcome Savita College of Nursing, Dr. Vijayalakshmi Ma'am. And I also welcome Principal Savita College of Allied Health Sciences, Dr. Lavanya Ma'am, and SIBMS, and the faculty members of these colleges. And I also welcome the resource person for taking their immense time and spending their valuable knowledge, Dr. Brijesh Renin Sir, Dr. Satish Anand Sir, Dr. Vijay Shri Ma'am, Dr. Chiranjeevi Sir, Dr. Anupriya Ramesh, Dr. Asma Parveen Ma'am, Dr. Punita Ma'am, Dr. Raj Kumar Krishnan Vasanti, who is joining us online, and Dr. Kumaresan Abad Sagayam Sir, Dr. Balachandra Sir, Dr. Vijay Lakshmi Ma'am, Dr. Rajeshwari Ma'am, Dr. Arun Sir, Dr. Lavanya Ma'am again, and the moderator of the evening panel discussion, Dr. Pratap Sir. I welcome everyone once again. And I also welcome the principals of principals and faculty members of UCA College of Physiotherapy, Jaya College of Physiotherapy, Vagdevi College of Physiotherapy, Tirumala College of Physiotherapy, Meenakshi College of Physiotherapy, and all the College of Physiotherapies who have been representing for this event on this meaningful day. And I also welcome all the participants who have gathered over here for this knowledge gaining session on throughout the day. And I also welcome the Neuro Department faculty members and the SCPT, HODs and the faculty members. And I also welcome all the participants and the volunteers for this grand event. Thank you. Good day.
Thank you, sir. It's my pleasure to invite lecturer Dr. Dhanushya ma'am to the stage to present the event report.
Welcome you all for Sniper 25. The Department of Neuroscience, Simats College of Physiotherapy successfully organized the international conference Sniper 25, Simats Neurology, Interprofessional Education and Research on 6 September 2025. In collaboration with Simats College of Basic Medical Science, Simats College of Nursing, Simats College of Allied Health Science, Simats Medical College, and Simats College of Occupational Therapy. The conference serves as a global platform for academic exchange, research dissemination, and international collaboration in the field of neurology and rehabilitation science. The scientific program features 9 sessions delivered by the eminent speakers Dr. Brinjesh Raman, Dr. Satish Anand, Ms. Vijayashree N., Dr. Siranjeevi, Dr. Anupriya Ramesh, Dr. Asma Parvin, Dr. Punita, Dr. Rajkumar K., and Dr. Kumaresan A. Their sessions will provide valuable insights into the neuro-rehabilitation, clinical practice, and innovation in the healthcare. The panel discussion further enriches the academic exchange through interdisciplinary dialogue. The conference includes paper and poster presentation with more than 300 scientific contributions recognizing outstanding research, academic excellence through prize distribution. The event witnesses vibrant participants from across the institution, from faculty, researchers, and students, thereby creating opportunities for networking and collaboration at the international level. With a total of 1,100 participants, Sniper 25 marks a significant milestone for the Department of Neuroscience, reflecting SCPT's commitment to fostering academic excellence, interprofessional learning, and innovation in the neurological science. So once again, welcome you all for the Sniper 25.
Thank you, ma'am. We kindly request Professor Dr. Pradap Sugandra Babu sir, Principal, HOD of Neuroscience, Simats College of Physiotherapy, to please come forward to honor respected Vice Chancellor Professor Dr. Ashwani Kumar sir. And we kindly request Professor Vignesh sir to honor respected Registrar Ma'am, Professor Dr. Sija Vagis Ma'am. And I kindly request our Vice Chancellor, Professor Dr. Ashwani Kumar sir, to honor our keynote speakers. I kindly request Dr. Brijesh Raman to join us on stage. And I kindly request Dr. Satish Anand sir to join us on stage. And I kindly request Dr. Vijayashree to join us on stage. And I request Dr. Siranjeevi sir to join us on stage. And I kindly request Dr. Anupriya Ramesh to join us on stage. And I kindly request our registered ma'am, Professor Dr. Sija Verghese ma'am, to honor our keynote speakers. I kindly request Dr. Punita ma'am to join us on stage. And I kindly request Dr. Asma Praveen to join us on stage. And I kindly request Dr. Kumaresan sir to join us on stage. I kindly request Dr. Balachandra sir to join us on stage. I kindly request Dr. Vijayalakshmi ma'am to join us on stage. I kindly request Dr. Rajeshwari ma'am to join us on stage. And I kindly request Dr. Arun Kumar sir to join us on stage. And I kindly request Dr. Lavanya Pratap ma'am to join us on stage. And I kindly request Dr. Pratap Sugandra Babu sir, our principal, to join us on stage. Thank you, ma'am. Thank you, sir. We now proceed to the next segment of our inaugural ceremony. It is my distinct privilege to invite to the podium a leader whose contribution have profoundly shaped academic excellence to our institution. We are truly honored to welcome Professor Dr. Sija S. Verghese ma'am, a distinguished academician. She completed her BDS and MDS in the Pedodontics from the prestigious Government Dental College in Trivandrum. With over 30 years of dedicated teaching and research experience, her journey is marked by immense contribution to Savitha Dental College through academics innovation, medical student development, and pioneering research guidance. Her prolific output includes over 100 published papers, several patents, and well-deserved Best Teacher Award. Having served Dean of Savitha Dental College and now serving our Registrar Academic of Savitha Institute of Medical Technical Science, her leadership continues to inspire all us. Ladies and gentlemen, please join me exciting very warm, respectful welcome to our Professor Dr. Sija S. Verghese ma'am, who will now address the gathering.
A very good morning, respected Vice Chancellors and all the principals, all the keynote speakers, faculty members, delegates, and my dear students. I'm very much honored and privileged to stand before you, such a vibrant student group here. Very happy that all of you are very, very enthusiastic. First of all, I congratulate the team, that is Department of Neuroscience, in collaboration with all the other allied health colleges to conduct such a wonderful international conference. This theme of the conference, that is, what is it called? Healthy aging. So actually when I saw that topic, it is like, okay, that is, aging is, you can't avoid it. Whoever born in this world, it has to get aged, even though we don't like to be aged. But as people like us, when we are standing, it is a topic for us actually. It is, and the major issue which we are worried about aging is the health of an aged individual. So in this context, this topic is very, very relevant to everyone, especially people like us. So, and definitely I know that to have a healthy life in an aged condition, there will definitely, it is an interprofessional approach is needed. So now when you look at the medical field, we have grown a lot, and naturally growth will result in lot of specialization. Everybody is looking only at their specialty. And as a patient, when you go to a doctor, it is like you are traveling between, or you are hunting or shunted between different specialist. As a whole, nobody is able to do the treatment for you. So in this context, I think this type of interprofessional approach in in certain conditions, especially for an aged individual, that is it is the need of the hour. And I know that all of you have presented papers. Definitely the research in this aspect, as well as the keynote lectures in the aspect, will help each one of you to be a good doctor or a good clinician to treat this aged individual. And I wish all the success for this program. And I also congratulate all the students who are going to get prizes for your presentation. And once again, thank you for inviting me. All the best.
Thank you, ma'am. It's now my unparalleled honor to introduce and invite the guiding force of the institution, a visionary leader who accomplished resonate on both the national and global stage. We are privileged to have with us Professor Dr. Ashwini Kumar, our Honorable Vice Chancellor. A distinguished medical entomologist and PhD gold medalist, Professor Dr. Ashwini Kumar has dedicated over 38 years to pioneering research in vector-borne disease. He is the former director of ICMR Vector Control Research Center, Puducherry, and an adjunct professor at Gorton University, USA. Professor Kumar has led over 200 national and international research projects, guided 17 PhD scholars, and authored 221 research articles, 5 patents, and 4 books. Globally recognized, he serves an advisor to the World Health Organization and is an international expert on vector control tools for malaria elimination, including authoring a WHO handbook translated into 11 languages. A recipient of 14 prestigious awards, including the Outstanding Young Person of the World and Lifetime Achievement Award from the Society of Vector Ecology, USA. His work has significantly shaped public health. Please join me in welcoming Professor Dr. Ashwini Kumar, sir, to share this insight with us.
Good morning. Thank you for introducing me to the audience. Our Honorable Registrar Madam, Dr. Shija Varghese, our principals on the stage, and our secretary, organizing secretary on the stage, our associate professor, the experts in the audience, faculty members, the invited guests, and also the delegates who have come from all over the country, and our own students, ladies and gentlemen. First of all, I want to really thank and congratulate the very thought of organizing this conference, which concerns our society, our nation, and all of us. We may be young, but we have elderly people at home at different milestone in their life. Madam was mentioning that those who are born have to get old one day, and we all go through that cycle. Traditionally, our Indian society has been a joint family system used to be there. And so many members of the family will look after the elderly, taking care of their needs. They will never feel lonely. And what we have seen over the last 30, 40 years is that we are entering into a nuclear family system. And as our economy is growing, and now from the nuclear system, we are seeing that in families, the children are studying elsewhere in the country or abroad, and parents are at home. So virtually, now we are unto ourselves. And India still is a young country of 1.48 billion people. We have a big population, and we are moving towards geriatric population more and more. We are adding every year lakhs of people because our population is ever growing. The age expectancy, life expectancy is increasing. As a result of that, we have elderly people, large number of elderly people to look after. Now, in the different strata of the society, the needs are different. And elderly people, many of them require physical support. Many of them have mental health issues, particularly dementia, forgetfulness, Alzheimer's is another disease. Parkinson is another disease. Hands will shake. They are not even able to hold spoon or glass, and somebody has to feed them physically. And then there are people who cannot, if they have strokes, they have partial paralysis of one side. So they have to be really taken care of. And in my home, my mother died at the age of 83 with cancer. And she had to be looked after in the palliative stage. And someone has to be with such a person in order to make that person feel that she's being looked after. It's not all about the care, it is also about psychology. They need their own people around them when they actually need them the most. Anyway, my mother passed away. My father is currently 94. And for the last 25 years, he had stroke 25 years back. But we are maintaining him in a very healthy state still. And currently he is being looked after in my brother's home. I am here. He is in Goa. My brother's home is in Goa too. And he is looking after my father and his needs. And he has a 24 hours attendant. But he is doing very fine. Just because he is given nutritious diet. Whenever he needs medication, medication is given on time. My brother's family is always looking after him. Now, this is very, very important. For the psychology of elderly and all that. And his memory is very good. So, given the care, this condition will be different from different person to person. And now we know that in our country there are old age homes being created, and people are voluntarily enrolling themselves that after the age of 65 or 70, we will go and stay there. Why? Because these old age homes are run by NGOs, or there are also paid homes. There are different levels of these old age homes, but they are given medical care, they are given health and hygiene, they are given healthy food, there are peers around them with whom they can talk and they can play cards or do activities, right? So they have actually a very good life there. So if good facilities are provided, and doctors are available on call who look after their mental health, physical health, naturally the old age is not a burden. Old age becomes again age one can enjoy. So bringing all these specialties together, where nursing care, where physiotherapy, where occupational therapy, where neurology, all these specialties actually provide that care together. So because of that, I feel that this is a very good thought that you have brought together specialists, the experts, to deal with these issues in depth in the form of lectures, special lectures, and also your own contribution. And my appeal to all the students here is that please look after your parents. Please give them reasons to smile. They have done whatever they could for you and they are doing it for you. But when your turn comes to take care of them, please don't abandon them. Please take care of them, look after them, talk to them. Nowadays, old people have no one to talk to. And sometimes when you talk to them, they feel very happy. Even if you spend 5 minutes, they feel relieved. So please make sure that your elderly in the family, whether your uncles or your grandfather or your grandmother, you really take care of them, sit with them, talk to them. They will narrate you very good stories from their past. And it's very nice to know what they have gone through and what you have gone through. That world was totally different. Maybe 3 generations back, things were totally different. And now we are in a rat race and lifestyle has changed and all that. Then you can relate. Please take care of elderly. And thank you very much for organizing this conference, Dr. Pratap and all the principals. And I request all of you to get the maximum out of this exercise, benefit it from all the expert lectures, and then go empowered and serve the community, serve your parents, serve your friends and their families. Thank you so much.
Thank you so much, sir. I request Professor Dr. Pratap Sugandra Babu sir, Principal HOD of Neuroscience, Simats of College of Physiotherapy, to honor our organizing secretary, Dr. Vignesh Srinivasan sir. And I request Dr. Lavanya Pratap ma'am, Principal of Allied Health Science, HOD, SIBMS, Simats, to honor the organizing team. Dr. Kishore Mayadas sir, to join us on stage, Dr. Priyadashini ma'am, Dr. Dhanishya ma'am, Dr. Satyashiva sir, Dr. Sandana Lakshmi ma'am, Dr. Vanita ma'am. And I request Professor Dr. Arun Kumar Sir, Principal of Occupational Therapy, Simats, and Dr. Professor Vijay Lakshmi Ma'am, Principal of Nursing, Simats, to honor the organizing team. Thank you. Please be seated. Now it's time for the most exciting event of the day, the prize distribution ceremony. Let's celebrate all of the past participants for their hard work and dedication. Whether winning or not, everyone deserves a big round of applause. Without further ado, we are going to start the ceremony.
Warm good morning to all. It's my great pleasure to announce the winner of scientific session. Before that, I would like to extend my heartfelt congratulations to all the 300 participants for their remarkable contribution and 75 winners for their outstanding achievement. Let me start announcing the winners. Track 1, UG paper presentation, Abhishek A, first prize. There is a tie in the second prize. Priyanka Bai, Simats College of Physiotherapy. Dongri Sai Charan, Vaikdevi College of Physiotherapy. Track 2, UG paper presentation. First prize goes to Rajan S, Simats College of Physiotherapy. There is a tie in the second prize. Sri Devi from Simats College of Physiotherapy and Kari Bhavya from Vagdevi College of Physiotherapy. Sorry, Devi Sri from Simats College of Physiotherapy and Vagdevi College of Physiotherapy, Kari Bhavya. Track 3, UG poster presentation. There is a tie in the first prize. Vinod Darshini from Sri Krishna College of Physiotherapy and Jayavarshini from Sri Balaji Vidyapat. And there is a tie in the second prize. Yuvashri from Simats College of Physiotherapy and Monisha from Simats College of Physiotherapy. Track 4, UG poster presentation. First prize goes to KP Nirmala from Simats College of Physiotherapy. And second prize goes to Archana Sri from Simats College of Physiotherapy. Track 5, UG poster presentation, Isaac Rubin Raj from Simats Institute of Basic Medical Science. And there is a tie in the second prize, Rishita Pateri from Tirumala College of Physiotherapy and Nafila Jasmine from Simats College of Physiotherapy. Track 6, UG poster presentation, Srihan from Simats Institute of Basic Medical Science and Hemil Nirav Oza from Simats Institute of Basic Medical Science. And second prize goes to Shruti Murlidharan from Simats College of Physiotherapy. Track 7, UG poster presentation. First prize goes to Tanisha from Simats College of Physiotherapy and second prize goes to Shakina, Simats Institute of Basic Medical Science. Track 8, UG poster presentation. First prize goes to CV Rishivardhan from Simats College of Physiotherapy and there is a tie in a second prize, Rajan S and Rufus Jnanaraj Samuel from Simats College of Physiotherapy. PG, track 9, PG paper presentation. First prize goes to Mohammad Salahuddin MA from Sri Balaji Vidyapat University. And there is second prize goes to Akshaya S from Simats College of Physiotherapy. And third prize goes to Badmaja Sri Balaji Vidyapat College, Chennai. In track 9, there is a tie in a third prize, Hari Pratap from Sri Balaji Vidyapat, Pondicherry. Track 10, PG paper presentation. First prize goes to Jayapriya from Simats College of Physiotherapy. And there is also a tie in a first prize, A. Kamaleshwari from Chettinadu College of Physiotherapy. Second prize goes to Adeline Prithri from Simats College of Physiotherapy. There is a tie in the third prize, Ishwar Kumar from Simats College of Physiotherapy and Keerthana M from Simats College of Physiotherapy. Track 11, UG poster presentation. First prize goes to Manoj M from Simats College of Physiotherapy. And second prize goes to S. Maitri from Simats College of Physiotherapy. There is a tie in the third prize. Mohammad Abu Bakr Siddiq from Jaya College of Physiotherapy. And Monisha from Simats College of Physiotherapy. Track 12, PG poster presentation. First prize goes to Yashni Vijaya from Simats College of Physiotherapy. And second prize goes to Harish Raj from Simats College of Physiotherapy. And third prize goes to Mohana Sundaram from Simats College of Physiotherapy. Track 13, faculty paper presentation. First prize goes to Tirupati Arjunan, Dr. Tirupati Arjunan sir. And there is a tie in the first prize, Dr. Asma Praveen from Sabita College of Physiotherapy. Research Scholar poster presentation. First prize goes to Dr. S. Kavita from School of Sri Balaji Vidyapat University. Research Scholar paper presentation. First prize goes to Dhanasekaran, LJ Institute of Physiotherapy. And there is a tie in the second prize, Selvam M from SRM College of Physiotherapy. And Dr. Darti Himans Pansala from SPB Physiotherapy College. Paper presentation, Dr. Surya Prakash from Lakshmi Physiotherapy and Rehabilitation Clinic. Track 14, Aravind B. PG poster presentation. First prize goes to Aravind B. PG poster presentation, Savita College of Physiotherapy. Second prize goes to Harika, Simats College of Physiotherapy. Maitri Jain from Simats College of Physiotherapy. Following tracks will be announced by Dr. Vanita Madam.
Poster presentation, track 15 to 22 runners by Simats Institute of Basic Medical Sciences, Abhinaya RS, Balamurali Krishna, Claire Thomas, Divya Sri, Harini H, Jerusha, Kripa Mariam, Niranjana, Joel Cruz, Jyotirmay, Sonia, and Vaishnavi Devi RS. Go, go, go. Let me announce the winners now. Adina Sam, Simats Institute of Basic Medical Sciences, Basil Raji, Reshma, Harini D, Haripriya S, Janavi, Litanya Sri, Mohita, Nivedita, Raja Madhumita, Rose Joe, Rose Jo, Vedeshwari, Syed Ali Fatima, Amrit. Thank you. As we prepare to conclude the inaugural session of this conference, it is time to formally express our sincere gratitude to all those who contribute to making this morning success. It is now my honor to invite Professor Dr. Pratap Sugandra Babu Sir, our Principal and Head of the Department of Neurosciences, to deliver the vote of thanks for the inaugural session. Please join me in welcoming him with a warm round of applause.
Good morning, and I take this opportunity as a privilege and pride to thank each and every one of you on the stage, of the stage, for registering for this conference as a delegate, accepting us for the conference as a resource persons, and also it's my foremost respect to thank, I pay my respects to thank our Honorable Vice Chancellor, Ashwini Kumar Sir, for accepting our invite. Immediately when I approached for the conference to invite, Sir said, always I'll be attending all your functions. So like that, this one will also be there will be my presence. So thank you, sir. Thanks for coming here and giving the words of wisdom so that our students are blessed today. And also, Registrar ma'am, thank you ma'am for accepting our invite and being with us today. And all the principals, Allied Health Sciences, Nursing, Occupational Therapy, for when I proposed this conference, initially we started it as a departmental session or a CME. When as a theme emerged as healthy aging, and the theme itself needed a multidisciplinary approach or interprofessional approach. So as we discussed with all the principals, everyone gave their happy consent for making this event from CME to conference. I thank every one of the principals here in the stage for making this event more grand and for cooperation, for your kind cooperation and for your kind support. Thank you each and every one of you. And also the resource persons, all here already Dr. Vignesh listed, and I don't want to name each and every one of you. And I wholeheartedly thank each and every one of the resource persons here for accepting our invitation and being a part of today's session to enlighten our students with knowledge you possess. Thank you each and every one of you for being here with us today from various places, from various parts of India, and also from international speakers. They will be joining in the afternoon session through the Zoom meet, and this one is also telecasted in Spider, our webinar, as our YouTube channel. And I thank the organizing team, Dr. Vignesh, organizing secretary, and all the neuro department faculty members for making this conference a huge success. Thank you each and every one of you, the volunteers, the support staff, and all the members, the registrants from various parts of the country. Thank you, each and one, every one of you. Without all you students, this will not happen. Thank you. Thank you once again. Thank you.
Thank you so much, sir. To formally conclude the inaugural session of this conference, we will now stand together in a moment of unity and respect. I request everyone to please rise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. You may be seated. The inaugural session has now concluded. We invite all delegates to proceed for the refreshment break, and we go at 11 a.m. for the next session. Friends, please settle down fast. We are ready to continue. Friends, please settle down fast. We are ready to continue. Hope you all had a refreshing break. We now request everyone to please settle back inside the hall as we are ready to continue with the next set of sessions. Good afternoon and welcome back everyone. As we move on into our scientific session, we shift our focus to a cornerstone of healthy aging nutrition. It is my pleasure to introduce our next speaker, Mrs. N. Vijayashree, Head of Chief Dietitian at MGM Healthcare and MGM Cancer Institute, Chennai. With over 18 years of specialized clinical experience, she is highly respected expert in critical care nutrition, metabolic syndrome, and nobly geriatric nutrition. Her expeditional contribution to the field have been recognized with a prestigious award, including Dr. MGR Health Campaign Award in July 2024. She is also life member and executive committee member of IAPN India and authored numerous publications and research papers. We are truly fortunate to have her with us today to share the invaluable insight. Please join me in exciting a very warm welcome to Ms. N. Vijayashree, who will now speak on nutrition requirements in the elderly change with age. Welcome, ma'am.
Good afternoon. Okay, as you are all sitting down, so I just start this session with a small warning. As this, the theme of this program is all about healthy aging. Those who are at the age of 60s at present are the best, luckiest and the healthiest. How many of you agree? Because you all have your,
Guys,
parents,
please maintain decorum.
grandparents. Okay? So, because they had good environment, they had better food, they had better physical activity, and less of technology, less of advanced machineries. So that is the reason you see more, older people come to hospital after 50, 60 years. The next generation, that's of all the speakers here, are little lucky. So we played outdoor, we walked, kilometers I went to college, schools, and nothing. But I am worried about the generation sitting in this hall. When I started my career in the year 2008 at Madras Medical Mission, I see only 60 above patients in all cardiovascular disease wards. They come for bypass surgery, angioplasty, etc., etc. And it is very easy to manage them also because they listen to us. Whatever restriction we say, very dedicatedly they listen. As years gone now at MGM Healthcare, I see more of 20s, 30s, and 40s coming up with the, heart failure, heart attack, coming for heart transplantation, coming for bypass surgery, and almost all type of chronic diseases. So, I think probably even the definition should be changed about aging. Aging, people say age is just number, right? That is for old people who are geriatric at present. Okay? So for this entire conference is not only for you people to learn and take care of the elderly, and also take care of your own self so that you will have a healthy aging in future. So I think now you all settled down. I will start my lecture because I think time is already running out. We are running late. So what I'm going to do, teach you today is about aging facts and figures and age-related changes physically, and the link between nutrition and muscle growth and nutritional consideration for healthy aging. So this is what the first few things. I think since this program is started early, and many of my previous speakers also would have spoke about how aging happens and what are the changes. I will try to make it very short, just kind of introduction. Okay, this is by WHO. They say by 2030, 1 in 6 people in the world will be aged 60 years or over. So we see more and more of geriatric population. So at this time, the share of population aged 60 years and over will increase from 1 billion to 1.4 billions. So by 2050, the world's population of people aged 60 years will be 2.1 billion. So, and this, you see, it is increasing. So this is evident. By this slide, you can see how, the geriatric population is increasing because the average age nowadays is increased. Agree? Okay? I think you are still settling down. People at the top, can you settle down please, because you are disturbing those who are interested to listen. Okay, let's move on to the aging related changes in their clinical significance. Okay, there is, thank you. There is physical changes. You see, you watch, if you're spending more time with the family members, you see suddenly your grandma or grandmother, who are very healthy, normal, suddenly you see their calf muscle goes very badly. They become very thinner and thinner, more skinnier, right? Okay? So that is the most worrying point of aging, okay? Losing muscle. bone weakening, because muscle is weakening, muscle loss is happening, the bones gets weakened, and skin thinning, which we all see, and cognitive changes in the mental health. They forget things, they keep repeating same things. So these things we see in our home itself, right? And there are more and more health problems. You know, so it's a curve. Life is a curve, right? We start from infant to adolescent, you know, adult, and then older age. So the curve goes down. So when the curve goes up, all you gain muscle, growth is there, you will have a good skin, and it remains in your adulthood, and after that it is slowly goes down. So there is all chances of getting more and more health problem because of the aging of the cells in the body. Okay. So this is the you know, changes in the musculoskeletal changes happens in aging. The number of persons aged 80 years or older is expected to triple between 20 to 2050, which we have already seen in the first slide. And there will be more and more people with malnutrition, especially sarcopenia. How many of you know what is sarcopenia is? Sarcopenia? Okay. Sarcopenia is nothing. It's a loss of muscle mass and function. Okay, both muscle mass and muscle function. So that condition is called sarcopenia. So in the hospitals, we see many critical ill patients are healthy. Their weight will be sometimes even overweight also, obese also. But when you check the muscle mass and the muscle functioning, it will be lesser. So those people are called sarcopenic, you know, people. So that is called sarcopenia. So learn this sarcopenia because you see, you take all the researchers and the future, you know, practice around malnutrition and sarcopenia. Okay? And also there is this slide. You can change it. So this slide was what I was talking about. You know, you see your mother very healthy, you know, suddenly calf muscle changes. So you can see at the age of 25, 30, how, you know, the muscle that in pink color is the muscle. And at age goes on, the pink color is lesser, the white is more, right? So this is what happens with the muscle mass. Can you change the next slide? Okay, so the mechanism that concur to the development of sarcopenia is malnutrition, that is any nutrition deficiency, physical inactivity. So see, always the nutrition and the physical activity goes and on together. So there are so many people come to us, they want only diet plan to lose weight. So if I am a qualified dietitian, I will not encourage that. Do you know what is the trending diet today? Because I know trending things every one of you know. Sugar? No. You are not updated. You people are not updated. So it is anti-inflammatory diet. You know how it become very popular? Can anyone tell? Because actress Vidya Balan, I think many of you are, you know, physiotherapy department. So actress Vidya Balan said in an interview in the Instagram that I followed an anti-inflammatory diet and I lost weight. And also said, I was doing so much of physical activity, dieting and all those things, nothing worked. Now I'm not doing any workout. So I got very, you know, all of us got blood boiling after listening to that. But public, people of India listened to her after that I see at least one patient in a day asking about anti-inflammatory diet. And these kind of celebrity interviews promotes, wrong pattern in the diet. Because lifestyle modification is not only diet, it is also physical therapy and other psychological health, everything involves. So all together, if you follow only, you will get a permanent solution for your health problem. Whether it is overweight or if you have any health issues like diabetes, it's all lifestyle modification. Not only diet, not only physical activity or mental health. All three together works well, rather than thinking of single aspect of lifestyle modification. No, please, previous slide. No, next slide. Yeah. Previous slide, please. Who is operating? Yeah, the previous slide. Yeah, thank you. So, hormonal changes, there are a lot of hormonal changes happening. Inflammation means when you lose muscle, there'll be more, the body is having fat only. Fat can inflammate faster. So that's the reason. So you have knee pain at the younger age also. I am working in a hospital. I see 40 patients in a day. It takes 3 to 4 hours. I have to stand, walk, move around. I don't feel any discomfort. But my internship students, who is in the 22, 23 age, comes with me. After 4, 5 patients, she started dancing, doing all this leg paining. Okay? So, because of your poor muscle strength and muscle mass, you are not maintaining it. You may eat good protein food, but you may not doing sufficient physical activity for your muscles. So please be aware of all these things. Okay? So that's the reason the younger people are getting more and more knee joint pain, leg pain, all those things. Okay? Of course, apart from that, there is vitamin D deficiency, calcium deficiency is also there. Okay? And increased catabolism and anabolic resistance, microcyte loss. So you see loss of alpha motor neurons. All this, brings sarcopenia at the older age. Can you change? And there will be more and more hospitalized patient, geriatric patient falling into sarcopenia. Next slide, please. So you can see, okay, this is the curve I was talking about. Early life, everything is increasing. Then it is stays for some time, early adulthood. Then everything comes down. So do you think, even at the older age, you can have a very fit health body, can walk, you can do, all type of job without any difficulties? Next slide. Yeah, this is the hospitalized, worse than the normal, people who are at home. So healthy young adult, 20 days of inactivity, okay, there is a muscle loss. And in an elderly person, 10 days of bed rest causes 2 kgs loss of lean muscle. And 3 days of hospitalization causes 1 kg muscle loss. So you can see they are eating same thing. Even your parents also, parents or grandparents eating a normal food. Everything is same. All of a sudden they lose muscle. So what it indicates? Next slide. Okay, so because of this lean body muscle loss, if you lose 10%, there is a decreased immunity, more chances of getting infection. 20% lean body muscle loss cause decreased wound healing, increased muscle weakness, increased risk of infection. And if 30%, even to sit They feel discomfort, they cannot sit for longer time. There will be pressure ulcer, especially in the hospitalization, pneumonia, and lack of healing if they have any infection or wound. Then if they have 40% increased risk of death, if 40% lean muscle is lost means can cause death because of pneumonia. So this is what happens, and end of the day, we all want quality of life, right? What is quality of life? You are living at the age of 80 without moving here and there, sitting one place. You speak to your grandparents, they will tell you what is quality of life is. That is not quality of life. Even at the age of 60, 70, doing their own work on their own is what called quality of life. Whatever they want to do, they should able to do. That is quality of life, not living till 80, 90 years. Next slide. Okay, these are some of the other changes, especially the gastrointestinal system changes happens. So they will have dry mouth, they'll have reduced taste buds, they lose their tooth. So, and the mastification, the chewing. Is there any SLPs here? Speech language therapist. Okay, so the hospital and the future healthcare demands more SLPs. So they are also now part of the multidisciplinary team. Okay, so then in the upper GI tract, the decreased esophageal motility, the reduced lower esophageal sphincter competence, all this causes less intake. So all this makes them difficult to eat food, bite food, swallow food, digest the nutrients. So if you see elderly people, they say, I don't want dal, sambar venda, parupu venda. Why they say? They say gas is forming, right? Okay, because of these changes, they are not able to digest even simple food which they were eating for years. And liver, so reduced liver mass, decreased hepatic blood flow, and increased diameter of biliary ducts can impair the metabolism. Protein, all nutrients is getting metabolized in the liver. That goes down, okay? And the lower gastrointestinal, all of them have constipation, even if they have little heavy food, oily foods, all of a sudden, they'll have diarrhea, right? So that is also, present. Next slide. Okay, these are the changes happens in the central nervous system. Since I think many of you all belongs to the neuroscience department, I'm not really going into detail and also considering the time. So can you move on to the next slide? So also skin related changes in the elderly is happening. So can end up in increased risk of infection in the skin, dehydration, hypothermia, and cancer also have higher chances, decreased sensation, increased neuropathic pain, increased risk of peripheral ulcer, increased fracture, and all these bone related problems can also happen in the elderly people. Next slide. So let's move on to the main topic actually. Next slide please. The nutritional consideration. So 5 warning signs of malnutrition in elderly. So you start with your own family. Observe these things are present. Lack of appetite, they'll lose interest in the food. Long-term weakness, okay? They always want to take rest. They don't want to move. Often the hands and the limbs getting colder. They feel that it'll be in Chennai, very less complained about feeling cold, but still they feel chillness, tiredness, annoyance. Even for simple thing you say, they'll get very annoyed. So, and there is a weight loss. So these are the signs of malnutrition. They should be treated immediately. Next slide. So what are the common deficiency and symptoms in the elderly? One is vitamin D, D3 and calcium. I will not say elderly, even today we have a master health checkup. Every day there will be 50, 60 young adult, who are working for corporate companies are doing vitamin D test. I'll tell you 90% of them are vitamin D deficient. Sad to, tell you, in a country like India and in a city like Chennai, where the sun is beating down, vitamin D deficiency is higher. And I'll bet you, if you check all your vitamin D, half of you will have a vitamin D deficiency. The reason is, we are not exposing our skin to the sun, right? Under the roof all the time, AC like this most of the time. So you are becoming a victim of vitamin D deficiency. So whenever you get off, whenever you get a leave, even weekly once, please spend little time, 20 to 40 minutes between 11 o'clock to 2 o'clock under the sun. Okay? You will get little vitamin D, which is sufficient for a week. There are food rich in vitamin D, but it is not sufficient. And if you see elderly people with the vitamin D level of less than 15, please encourage them to go with the supplement. Because the moment you say supplement, our elderly people get very scared. Right? So vitamin D supplement and iron supplement, when needed, should be taken. Otherwise, that can lead to more future health issues. Okay? Then vitamin K, which can affect the blood coagulation and bone health. B6 and B12, Alzheimer's disease, you all know, right? Very common. Dementia, all because of vitamin B6 and B12. Most of our elderly people are vegetarians. Even if they are non-vegetarian, they don't consume vegetarian like us. Sorry, non-vegetarian like the present generation. The present generation can have midnight biryani. See? Oh, the time is over. Okay? So, the elderly, I thought like something happening. Okay? Okay. So, midnight biryani, 3 a.m. biryani, that and all, they will not work with the elderly people. Even weekly once non-veg also, you can see they eat very little thing. So non-vegetarian foods are rich in vitamin B6 and B12. There is zinc and iron deficiency, which is closely connected with the immune system, infection and anemia. Then protein, carbohydrate and fat, which is a, next slide, macronutrients, very important, because currently we are moving more and more of fat diet. We don't want to take carbohydrate. We don't want to take fat. So that and all really not going to help you. Okay? So there are since a lot of neuroscience people, swallowing difficulty is very common among elderly people. So the consistency of food which you give matters. Okay? If you keep giving salad to the 80-year-old, you will fail. Okay? You make some effort to make it small pieces, you may get some success. But if you, make it little softer, hand mash it and give, there will be more success. So these things are very, very important to check. The moisture content of the food should be maintained. Otherwise, dry food, none of the older people will eat. So next slide. Okay, these are the 6 essential nutrients needed for the elderly people. Carbohydrate, protein, fat, which is the macronutrients needed in huge amount, like in grams. Vitamin and minerals, micronutrients, because they needed in micrograms. Next slide, please. Okay, all macronutrients contributes to the energy. You don't eat, rice, you expect sitting here and concentrating will not happen. Because the brain needs glucose for energy purposes. So make sure that you eat little carbohydrate every day morning so that the entire day of listening and working skill improves. And fat, as age grows, fat restriction should be followed because the fat gives 9 calories for 1 gram. So it gives higher calorie. They need less fat calories. So, and they have risk of cardiovascular disease, heart disease. So we have to reduce the fat. And protein, of course, I no need to tell because the youngsters knows protein better than the elderly people. So protein is very, very important, especially when it comes to sarcopenia and malnutrition. So the next slide, please. Okay. So the action of, using carbohydrate and fat to give energy, protein sparing effect of, some people will take more and more of protein and will not take carbohydrate and this. So what happens, the more and more protein you take will not go into your muscle. It will be wasted in converting into energy. So the protein, whichever the body required, that will be, taken. Rest will be used for energy purpose only. So remember that. That is the reason, based on your requirement, you have to consume protein, not in excess. Next slide, please. So this is what the message. Replace the, unhealthy food with the healthy food. Balancing. What is balanced food? Can you move next slide? So this is the plate given by the ICMR because whenever there is a doubt and when you want to know about any diet, we all go and Google it, right? Please don't Google it. There is something called ICMR Indian guidelines for nutrition requirement. Okay, it's a very beautiful PDF which they have given, released in the 2025. Each and every age group, each and every nutrients is explained as per the Indian recommendation. Okay, so the plate should be like this. There will be more, half of your plate should be fruits and vegetable, and there should be protein, 1/3, and there should be 1/3 of cereals. So it shows, instead of eating 4 idli and a chutney, you should eat 2 idli, 1 cup of sambar and curd, and 1 cup of vegetables. That's the change you have to make, and this is even for the elderly, because the elderly only makes this mistake. They just want idli. Even if you don't give side dish also, they are okay. They just go with the, some podi or, something. They don't want to have too many food. So try to make one dish which has everything in it. Okay? Next slide. And a milk is very important. These are the basic food groups. Including all these food groups in your diet is called balanced diet. If you miss out any one of this, you will end up in any one nutrient deficiency. Next slide, please. Sorry, I am taking 2 minutes more. So I am almost finished. Okay, protein food. One tip for elderly people, when they consume pulses, they feel gastritis, but sprouting and fermentation of dals improves the digestibility and absorptivity of the protein. So give them sprouted, soak all the dals 12 hours before you cook sambar or dal, whatever it is. That improves the digestibility. Next slide. Okay, this is again ICMR recommendation for oil. They always recommend combination of oil. You can see some coconut oil or rice bran. This combination is better for heart health. So you can guide the elderly people. Next slide. And iron deficiency is very common. The pictures whatever the nuts, non-vegetarian foods, milk and milk products and green leafy vegetable has good amount of iron. Not only iron, next slide. Vitamin D also rich in milk and milk product, nuts and non-vegetarian foods. And of course, as I said earlier, sun exposure is very important. Next slide. So it is very important. These are the thing causes indigestion, diarrhea, all type of GI related problem in elderly, not only in elderly overall, but especially in elderly. So they should avoid. Next slide. So this is again given by the ICMR, what they should consume. This is the calorie and protein requirement and how to split it. You can get it online when you Google it. So this particular PDF, I want all of you to read, learn many things for Indians. Next slide. It's for women, elderly women. So what they should consume. The next slide, please. So micronutrients, as I said earlier, vitamin B12, vitamin D, B6 are widely present in fish, egg, green leafy vegetable, milk and milk products. So if you include these things daily in a daily diet, they will get it enough of micronutrients. Next slide, please. Yeah, next slide. I already explained. Next slide. Okay, the 5 steps to improve digestion: maintain a healthy diet, don't eat unnecessary fried foods, avoid foods that triggers heartburn and reflection, very spicy, oily foods. Considering probiotic. Probiotic, when you ferment or sprout, you will get probiotics. Sprouts, curd, and anything made with the curd are good source of probiotic. Medication can cause GI thing, and being active, doing some exercise, solves this GI problems. So next slide. So these are the things we have to avoid and these to be included. So next slide, please. Next slide, supplement. This slide talk about supplement. So including supplement is should be part of your treatment in elderly patient, but unnecessarily giving supplements is not good. You have to check whether they are meeting their requirement. If they are not meeting, give supplement. If they are meeting, you just continue with the oral diet which they are eating. So to summarize, aging is normal, but with a good exercise, mental health, and of course good nutrition, aging can be handled very easily. You see many examples, older people doing, living healthy. You can see, you see, in social media, many videos, 70s, people do exercise more than what we can do. And there is, even if they eat good food, there is chances of sarcopenia and loss of muscle mass and function. So physical activity along with a high protein diet is very essential. And those food which is triggering their gastrointestinal function should be avoided in elderly people. So the texture of the food should be considered and supplement if necessary. Next slide. Yeah, I know some of them are ready to clap. So some of the option for a healthy snacks, instead of taking samosas and fried items. Last slide. Yes. So these are the healthy snacks you can suggest for elderly people, which gives a lower calorie and a higher protein and easy to digest also. I think with this, I am completing my presentation. Thank you very much for inviting. I thank the organizer for giving me this opportunity. Thank you.
Thank you so much, ma'am, for your insights. We now turn to a vital perspective on our theme, how to truly add life to our years. It is my honor to introduce our next speaker, Dr. Chiranjeevi Jannu sir,
Professor and Vice Principal of Devi College of Physiotherapy. With 15 years of teaching and research experience, Dr. Chiranjeevi sir holds a PhD in physiotherapy and specializes in neurorehabilitation and diabetic neuropathy. His work is widely recognized, earning him numerous awards, including the Nobel Professor Award and the Young Scientist Award. As an active researcher, he has published 12 papers in index journals, guides PhD scholars, and serves as a thesis reviewer for several universities. Please join me in welcoming Dr. Chiranjeevi Jannu sir, who will now share his insights on adding life to years, a holistic view on the science behind healthy aging. Thank you.
Thank you so much. My voice will be a little bit bass, so please try to spare me. Good afternoon, everyone. Good afternoon, everyone. Happy Advanced Physiotherapy Day to all the physios sitting over here. When a student joins in a college, what do we call them? When a student joins in a college in the first year, what do you call them? Fresher, junior? Next year? Next year? That's what the other side of a coin when you talk about aging. Okay, infant, child, youngsters, adults, finally aging. So instead of calling them as aging, I say that, why don't we call them as the seniors? Government is also saying them as, recognize them as senior citizens of our country. So let's use the nomenclature as seniors. So welcome to all the upcoming seniors sitting over here. So first I would like to thank our beloved principal, Pratap sir. Because of him, I'm standing here. 2016 I was sitting in that corner. 19 probably received an award from the same university. And 25 standing here to talk. Thank you. Let's start our thing. Next slide, please. And majority of the talks were being done by eminent personalities since morning. The neurophysician, neurosurgeon, and ma'am also gave very good information about aging. So I'm not going to into the details of it, just to brush up all those, it will be like a sum up of it. So when we talk about it, aging is a progressive accumulation of changes with time that are associated with the responsibilities for the ever-increasing susceptibility to disease and death, which accompanies the advancing age. That means as we are aging, the problems ratio is also going to be increased. And these time-related changes are attributed to the aging process. The nature of the aging process has been the subject of considerable speculation. Accumulating evidence now indicates that the sum of the deleterious free radicals reactions going on continuously throughout the cell and tissues constitutes the aging process or is a major contributor to it. That means our body changes are also going to be changed basing on our dietary factors, what ma'am told, and basing on our activities. And though you won't do any activities also, still there are a lot of changes in our body. Next slide, please. So, according to WHO, by 2050, the percentage of aging people, that means over 60, will rise from 12 to 22% globally, and 35% of those will suffer from mobility issues. That's the reason why physiotherapist plays a vital role. Remember this, my dear friends. So, a loss in mobility can affect many aspects of your lifestyle. For example, paying for the cabs, transportation. See, if you are in a proper age and when your health is proper, you can make things in your independently. But when you don't have a proper exercise, when your body is not in a position to support, your expenses for the traveling from even from one corner to other corner is going to be increased. That's the reason why exercise is very important. And there is a commonly held belief that the reduction in mobility as you age is unavoidable. Of course, first year students will definitely go to second year. A 40 years person should definitely reach to 50 years. That means you cannot reverse it. But only thing is, you can increase your mobility by exercises. That's what the main theme of our today's program. Next slide, please. So becoming old is a gradual process, but for few people it comes a little bit earlier, for few people it will be a little bit later. So earlier is when you are around 30 or 40 years, if you're not maintaining your body properly, automatically you're going to become an older. For example, let's take a nice bike, your favorite bike, put it to your side for a couple of days, and after that when you start working on it, or when you start using your bike, it will not support you because it loses its the flexibility or the movement of it. The same thing happens even in our body also. That's the reason why movement is very important. So there are a lot of medical advances in our country, in the world, which have enabled more people to survive into prolonged retirement and which causes longevity of a body. But still, whatever there is advancements, our body is our own property. Don't destroy the property by simply sitting idle. Next slide, please. The role of physiotherapists in the health education should include education of the elderly fitment also. See, instead of simply reading about the geriatrics, even our education system should incorporate how to treat the people, how to talk to the people. All these are very important aspects which has to be included in the education system. So let's see a few things. Next slide, please. When we talk about, next slide. When we talk about the aging body, there are two main things which will play a vital role. One is physiological, another one is environmental. Next slide. When we talk about physiological, longevity is a demonstrable genetically inherited tendency in some families. In vitro experiments, cell divisions are self-limiting. Cells from the mucosa of young children, they multiplies into many divisions than those in elderly people. The maximum appearances to be approximately 50 divisions under laboratory conditions, indicating the limited capacity of the body to repair and replace its tissues independently. Likewise, genetically inherited or prenatal defects comprise chances of long life. Next slide. When talk about the genetic template, this error leads to decreasing accurate cell reproduction and eventual differentiation of tissues with consequent impairment of function of specialized organs. As inefficiently it multiplies, secondary effects of slow detoxification and removal of metabolic byproducts reduce the nutrition. All this happens because when we don't exercise our body, all these things can play a vital role. So exercising is very important. And there is generalized age-related increase in the proportion of white fibrous tissue, which is one of the least differentiated body tissues. Next one. When we talk about the environmental conditions, here it speaks about the injuries, the traumas, the pollutants which happens in or around of our circumstance in the environment. And until man has learned to control his environment, the tame predators, and to ensure food supply and adequate protection from the elements, aging was an unknown phenomenon because man started learning how to protect himself. So till that, there are a lot of disparities in the earlier days. The maximum natural lifespan is probably about 100 years, but now it has been changed from 65 to 80 years, which started declining in the activity level of a body. So factors are yet unknown, but it may influence the patterns and rates of aging of future generations. The various systems of a body undergoes changes, and the significance of these may affect the physiotherapist to be discussed. That means he has to discuss about the aging process with the interdisciplinary team, with all the people. Thereby he can give a proper management or rehabilitation to a patient, because one person cannot do anything, many things. So physiotherapist's role is only to do some exercises to the patient. Nutritionist will give what sort of food to be taken. And we talk about the nursing care. Physiotherapist, it's not a physiotherapist's role, it's a nursing people role. So all the departments has to be intermingled together, like the divine thought of our beloved principal Pratap sir. If all can join together, we can provide a proper rehab program to the patient. Next slide, please. Let's talk about the muscular system. As we age, there are few people who would urge that a 90-year-old will become more weaker than a 20 years old. What happens? There are two changes happens in our body. One is biological changes, other one is lifestyle changes. Next one. So when you look at the first reason, the biological changes, it's a natural part of aging, but as we are aging, there are two theories or many theories which speaks about it. The main factor is, ma'am told about sarcopenia, so I'm not going to the details of it, but the reason for sarcopenia is, what one? It's a protein problem. So one of the biggest causes is that the body becomes less efficient of absorbing amino acids called as leucine. So protein plays a crucial role in muscle binding and muscle maintenance. Protein is made up of amino acids, and the three of the most important amino acids are leucine, isoleucine, and valine. So these are very important for an individual body to maintain the proper muscle mass. Next one. So studies have reported that our body is less able to absorb the leucine, because when you talk about the people of 20 years and 60 years of age, both will eat about the same amount. But the absorption rate of leucine is going to be reduced in our body. That's the reason why the muscles becomes weak and they become more pliable. And if you look to our younger people, aged people, our grandparents in our homes, they'll be having the floppy bodies or the loose bodies and the loose skin, because loss of absorption of protein in their body, particularly the leucine. Next slide, please. And the second cause, it could be because of the lifestyle changes. So it should be either use it or lose it. So it should be mentally is a true exercise as anything. As we age, many of us becomes less independent because we always have been habituated for dependency. So as you age, you will always be on dependence. So independence is always important for every individual. And this can lead to a weakening of a muscle as they aren't required as often during the day. This creates a vicious cycle where your lack of movement weakens your core. So movement is very, very important. Don't sit idle for hours together. Stand, have a walk, and then sit. That's what's the most major thing what I suggest you. So if your core muscles are weak, obviously your mobility is going to be strong or weak? Weak, that's what. Next one. So let's talk about the locomotor system, nothing but our musculoskeletal system. The bone starts to lose the calcium after the age of 25 years. The rate depending on the amount and vigorous of habitual exercises, dietary intake, increase of women after the menopause due to hormonal change. That means the bones becomes weak after menopausal stage. A 30% demineralization may take place before changes are detectable radiological. That means before you go for a radiograph and find out, still we can identify what's happening in our body. So when you feel weak, that means something is going to happen in our body. Remember this. Next one. After a fracture, when you talk about a normal bone healing mechanism, it will not take much time. But when you talk about an aged person, the healing mechanism will always be in a lengthy process. That means it keeps on expanding, it keeps on increasing. The reason is what? No fitness in their body. That's what. And elderly men are often surprised, even ashamed at their own lack of strength and may fail to admit weakness. Tact is needed when muscle testing. This is what the physiotherapist should always remember. So when you're talking to elderly people, they don't admit what's happening in their body. But we should have a very good consciousness how to talk to them, how to bring them into your track, and how to assess their muscles and for the proper rehabilitation program. Next one, please. Cardiorespiratory system. The respiratory system becomes less flexible. Kyphosis due to osteoporosis of the thoracic spine and ossification of the costochondral cartilages reduces mechanical efficiency. This leads to hardening of the bronchi and bronchioles, which increases the airway resistance, and at the microscopic level, less of elastin reduces alveolar extensibility. This leads to decreasing total surface areas of a lung. That means the oxygen intake is going to be reduced because the hardening of these structures. So when your lung expansion is not going to happen, when it's not going to be maintained, obviously the demand of oxygen will be high, but you cannot fulfill it. Diminished vital capacity leads to hypostatic lung changes, increasing susceptibility to pneumonia. So these changes mimic obstructive airway disease even where there is no loss of lung parenchyma because of decreased thoracic cage mobility. Next slide, please. So ciliary motility slows, the cough reflex becomes sluggish. Coughing becomes less powerful with reduction of intercostal muscle bulk, and the relative usefulness of postal drainage increases compared with the other methods of assisting expectoration. That means postal drainage is very important in order to increase the lung function. For physiotherapists, cardiac changes are more relevant with regard to excess capacity, blood pressure, particularly the systolic pressure, which increases with age because of raised peripheral resistance due to sclerotic changes which are happening in the arteries and arterial valves. So all this happens because of decreased mobility. Next slide, please. And when we talk about the heart muscle, the response to the increased muscle workload by hypertrophy, but thickening of the myocardium does not produce an increase in stroke volume. It's just hardening. So it's not going to increase the stroke volume. Indeed, cardiac reserve decreases and exercise tolerance in the elderly is best monitored by pulse rate. Not allowing an increase of more than 20 or 30 beats per minute from resting rate or less where there is cardiac pathology or signs of distress. This is all because of decreased cardiac mobility. Next. Atherosclerosis is also common in these people, although generally considered a disease rather than a natural aging process because of its variable incidence in the population and its stepwise progression. It is also affected by smoking and diet. Related to diet, ma'am spoke, and coming to smoking, dear friends, it looks more passion for us, but indeed it's going to hurt our heart and lungs. So smoking is not good. And even it's been written on the pack stating that don't smoke. Smoking is injurious to health. Many of our youngsters will buy only single piece, stating that it's been written on the pack. So don't do that. Whatever you do, it's going to hurt your body and your family also. Be careful. Next slide, please. And coming to the neurological function, The morphology of brain cells begins to change in the 20s with the successive decrease in numbers throughout the decades, and reproduction in brain weight associated with decreased cerebral blood flow. As we age, the blood flow of the brain is going to be decreased and the weight is also going to be decreased. In the absence of specific pathology, it does not necessarily reach critical thresholds even in old age, but a general slowing of mental function is expected in the elderly people. There is a conflict evidence about the effect of aging on nerve conduction velocity, but slowing at neurosynaptic junctions and loss of dendrites at end plates may affect the speed or presence of the reflexes in these people. This becomes particularly significant when it starts to affect balance by slowing writing reflexes to the anti-gravity muscles. Next slide. When we talk about the sensory system, there are 4 sensory systems in our body: telereceptors, exteroceptors, proprioceptors, and interoceptors. Let's talk about the telereceptors. Next slide. The sight. The more sensitive systems of a body. So when we talk about the gluteus maximus muscle, for example, one motor nerve fiber can innervate around 200 muscle fibers. But whereas when we talk about the eye, it will go in one contact. That's the reason why when there is any problem based on the aging, the vision is going to be affected. And when we talk about the hearing, degeneration of hair cells receptors and loss of neurons in the cochlea will reduce the sensitivity to higher frequencies soon after childhood. This leads to deafness in many older people. This is what the main problem with them. Next, talk about the exteroceptors and the 3 things: touch, pain, and temperature. When we talk about the touch, the sense of touch is not diminished, though in the presence of one stimulus, a greater threshold is required for the next stimulus. And talk about the pain, in this the silent pain will be in the people. As they age, the deep pain such as ischemic pain is diminished, hence the high incidence of silent myocardial infarcts among the elderly people are pretty common. That's the reason why elderly people, when they go to washroom, suddenly they'll collapse. And when they're doing some activities, all the people says, till now he was fine, but suddenly he got collapsed. The reason is silent attacks are being common in these people, painless problems. Cannot talk about the temperature. Diminution of temperature discrimination is of importance in testing skin sensation. So physiotherapists, when we are dealing with the electrical modalities, particularly the heating modalities, be sure you're checking the sensation of a patient before treating them. Next one. Talking about the proprioceptors, proprioception declines with age and can have major results in producing unsteadiness, especially if visual function is also impaired and cannot compensate. Blind or partially sighted old people are particularly at risk according to the severity and extent of the loss. If a walking aid is needed, then increasing large base is preferable even at the expense of maneuverability. That means instead of giving a stick, go for a quadruped. And instead of, when you're giving a frame, make sure the uprights are more straight and more wide. And coming to the interoceptors, the visceral and internal appreciation of temperatures like pain, pressure, and chemical changes will also diminish in these people. Vagueness in self-reporting, diagnosing becomes particularly difficult when the symptoms themselves may be vague, as in case of spinal stenosis. Next slide. When we talk about the autonomic function, both the sympathetic and parasympathetic nervous systems shows evidence of degeneration. So with reduced efficiency in vasoconstriction and probable hypothalamic deficit, the aged are especially prone to the effects of cold, capable of appreciating neither temperature loss nor of the normal physiological responses to it. Normal febrile response to the infected is lowered, so as when the temperature is being reduced in these people, raised heart rate is much more reliable indicator of the body defense mechanisms which has to be recruited. However, the elderly are more liable for hyperthermia because of reduced sweating, because sweating is going to be lost, the sweat pores will be closed in these people, so that leads to hyperthermia, the temperature keeps on increasing in them. So these factors influence the planning of treatment programs to include adequate monitoring, that means to cool off the body after the activity. That's the reason why we need to have cooling period after every exercise for the patient. Next slide, please. When we talk about the metabolic changes, the major clinical consequence of changes in renal hepatic function in the elderly is the effect on drug metabolism and excretion. Although not necessarily directly the physiotherapist's concern, all staff in close contact with the patients taking medication should note any untoward signs or changes in the patient's state after alterations in prescription and report them to the physician. That means one person cannot make his own decisions. So when a physiotherapist is treating, when there are any changes he found in the patient, he need to talk to the interdisciplinary team to make a proper prescription for the patient, and before this, physician advice is very important. Next slide, please. Talking about the mental function, the most widespread normal effect of mental functions is short-term memory loss. And survival skills learned in the early years tend to remain relatively intact into the extreme age. So people like, recognition of harmful stimuli, appropriate response to the thirst and hunger, food recognition, they'll stay with them. But the problem is, but from middle age onwards, people commonly complain of not able to recall that. Suddenly when they look to people, they'll say that I know you, but they cannot tell our names. They will find this, the sequence of statements or the sentences. Even they'll find the forgetfulness is pretty common in these people because of aging. So there are more four factors for the mental function. Elderly people with physical illness. So what happens? Properly, these patients should not be classed as psychiatric. They are not psychiatric. As they're aging, they're forgetting. So acute confusional states are very often have physical causes like a sudden onset of mental symptoms preceding or accompanying onset of physical manifestations. For example, bronchopneumonia sufferer who first presents wandering out of doors in night clothes. See, a person suffering bronchopneumonia, he'll just come out stating that he forgets what dress he's wearing. Because of his aging factor, to come out to have a proper air, a proper ventilation, just come out. But he forgets what he wore. This is all because of his aging process, but don't term them as psychiatric patients when they are wandering outside. This is only because of aging. Next slide, please. And the long-standing patients who have been mentally ill throughout their lives. So these patients will be found both in hospital and even in the community also. So in the past, patients whose severe mental disturbance related to behavior which society found has been unacceptable were virtually banished or to mental asylums. So these are huge long-stay institutions. Yeah, coming for the third one, the elderly functional ill people. Next slide, please. Elderly with the senile mental disease. When talk about the Alzheimer's disease and all, today morning our neurophysician has described all this. So let's move on to the next slide. What the role of a physiotherapist has to do. So when the physiotherapist is talking to the patients regularly, he'll be in contact with them. So to have a proper information from the patient. So instead of talking to him, talk to his attendant or to his relative who is being in close contact with the patient, make a proper chat with the patient, and you'll have a synopsis about the patient's condition. Basing on the synopsis, you try to treat the patient or call the interdisciplinary team members also in order to have a proper medication for the patient. Next slide. And during the treatments, next one. So during the treatment sessions, people keeps on telling many things. But when talk about the patient point of view, he will always think in one point, what will be his priorities. So address the priorities of a patient to have a proper management of him. Next slide. Next one. Next, please. Next one. Yeah. So when talk about the patient, the most painful thing he'll try to present either in the first or at the last. The most worrying thing for the patient will be at the first or last. And what the patient thinks, he always thinks that the physiotherapist want to listen to his concerns. So listen to the patient properly and address all his requests. And to conclude my talk, to very clearly, in the morning session, our register member was telling, all the teams should join together in order to have a proper rehabilitation. And our register vice chancellor was telling that, talk to your elderly people to have a healthier life for them. So these two are very good, valuable messages which they gave in their talk. So dear friends, try to have the same thing, put things in your mind, because one man cannot make a big show because you need to have a very big team. Even for us today's people sitting over here, there was a huge team behind the screen. Though Pratap sir was standing in front and all the principals joined their hands together to make this success, but there was a person working behind the screen. The same way, for one person to be more rehabilitated, to be more healthier, to have a healthy lifestyle, all the departments has to join together to create a healthy life for the patient. Then only we will be successful, not I be successful. When we have a chance of stating that we, things will be in a proper way. When you feel I, it will not be in a proper way. So always talk to your interdisciplinary team members for a proper rehabilitation of a patient. Thereby the patient will be fine and we will be fine. When the society is proper, then our pockets will be full. So be careful and have a healthy lifestyle and respect your seniors, respect your profession. Thank you so much.
Thank you, sir, for your valuable thoughts. We now move to a topic of critical importance of our aging population, preventing falls. It's my pleasure to introduce our next speaker, Dr. Anupriya Ramesh, widely known as a physio-educator. With a unique blend of clinical expertise and a passion for education, she has trained over 6,000 physiotherapy students across India and abroad. helping many achieve distincts and gold medals. Her innovative approach extends to hosting a podcast show to raise physiotherapy awareness. A recipient of Physio Influencer Award and Young Achiever Award, she specializes in biomechanics and neurological physiotherapy. Please join me in giving a warm welcome to Dr. Anupriya Ramesh ma'am as she presents on Assessment to Action, a guide preventing falls in the elderly. Thank you, ma'am.
Good afternoon, everyone. Hi. It's already lunchtime, right? So you are feeling how many slides I would have put, isn't it? Yes? So don't worry, it's just 10 slides, so I'll finish it fast. So hope you are not hungry. You are hungry. So okay, we'll finish it fast. Okay? So once again, good afternoon everyone, and thank you so much for the opportunity to Savita College, particularly Dhanushya ma'am. And let's just start. So the first, can we just go to the slides? So before that, you all know, right, what is the topic today? It's aging, healthy aging, isn't it? So I know that not only physios, there are so many allied health people are here. So we all have a part, not only in aging, in many human being life cycle. So sit up. Okay. So now, when it comes to aging, my topic is about assessment and action. So let's say, how many of you have treated or seen geriatric people? I'm talking about not seen, like in terms of patient-wise. How many of you seen geriatric patients? How many of you seen geriatric patients in your OPD? Yeah, okay. So how many of you treated geriatric persons? Next slide, please. So now I want everyone to look at this. Can you see the case? So the name is Araga Sundaram. For those who doesn't know what is meant by Araga, that means it's pretty, okay? So it's Araga Sundaram, 72 years old, walked into the clinic, strong, independent, and only a little unsteady. So if I did not assess him properly at that time, and 3 months later he came back after a hip fracture from a fall. So my question, do you think, can we prevented this? Yes. How? By assessing him, right? So if a person, particularly geriatric person, comes in, they might come with a different problem. Let's say they have a knee pain, they might have a shoulder pain or something. But if we think that their balance is not good, they have a higher risk of fall, then we should assess it and start guiding them so that they'll prevent many problems because of fall. There are hip fracture, AVN, much more reasons. Okay? So to avoid that, you need to know what kind of assessment to make. The next one, please. So, as Sir spoke earlier, there are so many factors in aging. It will happen in our body. As you guys can see, the whole picture, it starts from strength, balance, gait, mobility, vision, sensory, cognition, and medications, cardiovascular status, and much more thing. So we are going to do one by one. Okay? So let's just start with cognition. So if someone, what is meant by cognition, guys? Cognition, higher mental function, brain function, isn't it? So if someone's brain function isn't that good, then there is a higher chance they'll have a fall. That means brain is the one which controls our body, isn't it? So we have to look on that one. So if someone is unsteady, that doesn't mean they have one particular reason to do it. Always understand, assessment is multifactorial. We can't make one judgment by understanding, okay, my patient have this because they have this muscle weakness. It might be because of their mental issues, it might be because of many other things as well. So you have to always assess a patient with whole picture, not just for one particular reason. Okay? And we have to assess the muscle strength. Can we go to the next one? Okay. So for the muscle strength, the test is 5 times sit to stand. It was not present properly. So we are going to check your ability of lower limb strength now. Okay? Ready? If we do it earlier, I'll finish it before the bell rings and you can go to lunch. Ready? Yeah, it's up to you now. It's not in me. So already 3 slides are up, 7 more. I'll finish it if you do it. Okay? So 5 times sit to stand test we are going to perform. So let me, wait. I know you are enthusiastic to go to lunch, but let me just finish. So when it comes to 5 times sit to stand, it's about you have to place your arms across the chest. That is rule number 1. Let me just first say, I'm so happy to see that you're all enthusiastic, but let me just finish it. So arms across the chest first. And secondly, when you stand up and sit down, right? So that time, your back shouldn't touch the chair. Okay? Your back shouldn't touch the chair. And your thighs also should not support entirely on the seat. So it should be tuck like that. Okay? Ready? Wait. Ready? Everyone settle down fast. Keep your bags aside to make sure that you are not hindering anything. Sit down. When I say the count of 3 to 1, we'll do it. Now please sit down. So just make sure you have space. Guys, listen. Just make sure you have space. 5 times you are going to do. Okay? So so it's not about minutes. It should be like seconds. You should finish the entire thing. The people who can do it in a very less number of seconds, that means they have a good amount of lower limb strength, dynamic balance and XYZ of things. Shall we? Let me explain one more time. Arms across the chest. Second one, when you are standing and sitting down, your back should not touch the seat. Am I clear? Ready? On the count of 5 times you have to do. Sit and stand 5 times. Ready? On the count of 3. No, wait. When I say 1, stand up. Ready? Ready? 3, 2, 1. Start. Faster. Cool. Many of you haven't even sat on the chair. So I'm just taking it not as a count, okay? Many of you haven't sat on the chair. So if a person can able to do this with a less amount of time, that means they have a good amount of lower limb muscle strength, okay? As well as they have a good amount of balance. So if a patient in a geriatric group comes to you, by using this one test, you can assess muscle strength as well as balance of your patient. Understood? So what do you think they will do when they do the test? They will try to take the support of the chair or something. Right? If they feel unsteady, they'll try to take the support of the chair. They don't willing to do the arms across the chest. If these are the things they are showing up, that indicates they don't have a good muscle strength, or else it could be the balance. Then you have to go deeper down into the assessment to make sure what is the problem. Okay? So this is the first one. Next slide, please. Okay. So the next one, the gait functional mobility assessment. So here we will do something called as tuck test. Okay? How many of you watch Robo movie Endiran? How many of you watch Robo Endiran movie? In all languages it have been released, so I'm making sure you have watched it, right? So if you see in that one part, the villain scientist will come to Chitti and ask Chitti like, stand up, go, take the knife, kill Vasigaran, isn't it? So it's similar like the same thing which is called as tuck test, timed up and go test. I'm not asking you to perform, guys, okay? I'm not ready to do that, okay? So we are not doing it, but just understand that tuck test is something you have to make a hallway or somewhere there is a space and your patients should sit in a chair. Okay? So the test starts from your patient should sit in a chair and they should stand up and walk for 3 meters and turn and back to the sitting position. Okay? So it also should happen in seconds, not in minutes. All the balance tests should happen in seconds. If they are taking more time, that indicates there is some problem. Okay? Ma'am, then you might ask, then why you haven't added single leg balance test? Isn't also very easy, right? One leg they will stand. But the thing is, you have to understand what test is more important. In single leg balance test can be affected if the patient is having some problem in the hip musculatures as well. If the muscles are not good, then they were not able to do it. That doesn't mean they don't have a balance. So that is why, to make sure you are assessing the patient with high level of validated and reliability test to make sure that you are getting the progress as soon as possible. Okay? So this one, as you guys can see, it is for gait, balance and functional mobility. So you don't have to check the patient by using, okay, gait I will check this one test. For mobility I will do this one test. For functional assessment I will do this one test. Try to make sure you are using a test where you can able to see the result and doing multiple things. Okay? The next one please. The next one for balance, the very gold standard scale, which is Berg balance scale. Right? So we have always have the balance. How many types of balance is there? Only static and dynamic. Static, dynamic, reactive, anticipatory. So there are 4 types of balance we have. Okay? So, but when you are thinking that your patient really have a balance issue, you should check all these types. Okay? Assessment always takes days to finish. Don't think your patient comes in, 20 minutes assessment done, like you can start the treatment. No. The assessment is ongoing based on your patient's symptoms and the patient's signs. So as of now, when the day 1 they are coming in, you don't have to check static, balance, dynamic, all these things because they'll get bored, isn't it? So that's why. So in this, by using the scale, so the good number of scale is 0 to 56. If they are more than 40, that means their risk is very low. As the grade reduces, the risk is more high. The next one, please. Okay. The next one, dual task assessment. Okay? So there is a test in balance also, which is called as walkie-talkie test. Do you guys know what is meant by walkie-talkie? Walkie-talkie, isn't it? Back then, it's seen in movies. Nowadays, we can see even in wedding planners having a walkie-talkie to make sure they're passing the information. So what is the use of walkie-talkie? They can call, right? They can use the phone. Then what is the purpose of walkie-talkie? Have you seen in movies, particularly Singham movie, it has been released in all languages. The name might different, I'm not sure. So in Singham movie, if you see, if there is a villain running, they'll use the walkie-talkie to, like the villain is going in this particular road, this car is approaching like that. So what is the function of walkie-talkie? They can run, they can walk, at the same time they can talk. Right? So many of you are actually doing dual task assessment, like checking your phone, at the same time checking me also. Right? Some of you are not doing dual task, most of you were doing it. Right? So dual task assessment means 2 things they have to do it together. Walk, count, walk it and sing a song. When your patient is not able to do it. I had a patient of stroke where if I say 1 task, she can do it. But if I say 2 tasks, talk with me at the same time, like garland making. She's an older woman. So guys, the assessment will vary based on your patient preference also. I can't give a Rubik cube to my geriatric patient and say that solve it. Right? So what need? My patient know garland making. So I gave her to do the garland making. At the same time, I was asking her questions. So performing dual tasks. So which will also help us to understand their cognition level as well as their ability. So the next one. The next one, tandem gait and stance. So tandem gait, I hope you all know, but for those who doesn't know, you are going to perform now, okay? So not the gait part, I know you will run away, so we are going to only do the stance part. So what is tandem stance? 1 leg in the front, 1 leg at the back, the heel to toe. Ready? Shall we? Up. People who were only doing 1 task, like using your phone, might not listen to what I was saying, but people who have listened to this, you are going to perform tandem stance. 1 leg in the front, 1 leg at the back, and arms across the chest. And we are going to count for a few seconds and see how many of you maintaining the balance. Don't lean on your friends. Ready? Stand up. Ready? Arm across your chest. 1 leg front, 1 leg back. It should be like this, like a model pose. Ready? Yeah? Done? 1 leg front, 1 leg back. Thank you. Yeah, cool. Please sit down. Thank you so much. Thank you. So as many of you are steady, that means you have a really good balance. There is a very less chance you have a fall. Okay? Next one, please. Okay. So all these content were taken from this particular author. So, guys, I'm done, almost done. 2 more slides. 2 more slides. So, whenever you are assessing your patient, particularly a geriatric patient, have a higher risk of getting multiple other things, not only with the particular thing they came for. Your patient came with OA knee pain, shoulder pain, any problem it could be, but always understand your patient age group. If your patient is geriatric, there is a higher chance they have a fall. They might end up in losing their balance, or these are the potential factors you should think of. So whenever you are assessing your patient, oh, my patient came with shoulder pain, ma'am, but they are also unsteady. But my problem is not with their unsteadiness. I'm going to only treat the shoulder. That is not our role. We have to assess the whole patient in order to understand. So to assess the whole patient, in terms of fall prevention, you can do this test which I said to understand quickly whether your patient have a higher risk of fall or not, higher risk of losing their balance or not, whether they have a good lower limb strength or not. Okay? Am I clear? Everyone? Yeah? Thank you. Next one, please. Okay. So this is something I follow and it worked good for me. So I know I was not in this auditorium, but I was student once. So when we come to this kind of functions, right, trust me, it starts with lot of enthusiasm. Oh my God, we are doing a function, no class, nothing, right? But at the function starts, we start to ache for break time. When the break will happen. Once the break done, as you guys are sitting, we start to look for lunch time. Right? And once the lunch is done, we start to look for when the entire event will gonna be ending. Am I right? That's how it is, isn't it? But always understand the point of conducting these kind of events so that you guys get to network with other physios or other faculties, other people. You can broaden your thoughts by looking at a resource persons, a different niche, different category, isn't it? So, the purpose of the event you should understand. At the same time you can enjoy, but the purpose of the event you should understand. Okay? If you are not doing it, let's say you can enjoy as you guys are enjoying. If you are enjoying, once you guys graduate, once that part of the life comes in, you start to wonder what I did in college. Right? Because you are doing chit chat and not listening. So this is what you've done in college. This is what I done in my college as well. Okay, I'm not going to say no, I was taking all the notes and all. But as a person, now I'm saying you, learn the skill. Not only academics, learn to have the skill in your particular niche, because skill can only give the wealth. Wealth is money. Wealth can only give the respect. So if you have a skill, the respect and money falls in. Okay? So to have the skill, start to network with people, try to understand the different things. You came for a one-day event, so when you go out, you should know at least 1 or 2 things which you never learned before. Okay? So that is the core. You should have a basic value. No one is expecting you to remember all the things what you saw today. At least 2 to 3 new things which you learned. Am I clear? So post-lunch, any session, listen what the topic is. Listen what they are trying to say. You don't have to understand the entire thing. Okay? Try to get a new skill. Are we good? Yeah? Thank you so much, everyone. Have a wonderful day. Thank you so much, ma'am. Thank you so much. Thank you. Thank you so much, ma'am. Ladies and gentlemen, it's now time for a lunch. To avoid crowding, we will be sending delegates in batches.
The lunch is served on to the right side of the auditorium, non-vegetarian. First, I request only the right side, the people onto this.
Hello. Good afternoon and welcome back everyone. I kindly request everyone to get settled down. I hope you all enjoyed the lunch and had some fruitful conversations. Okay. We now resume our scientific sessions. Our next presentation delves into a powerful role of rehabilitation in promoting vitality and function in later life. We are honored to welcome Dr. Asma Parveen, Senior Assistant Professor at the Abhinav Bindra Sport Medicine and Research Institute. A dedicated specialist in neurophysiotherapy and a PhD scholar, Dr. Parveen ma'am brings both extensive clinical experience and profound academic insight. Her research focuses on innovative rehabilitation techniques, including treadmill training for stroke recovery, and she has published multiple papers in peer-reviewed journals. An accomplished speaker and award-winning presenter, she has received first prize for her work at state and national conferences, reflecting her commitment to advancing neurorehabilitation. Please join me in extending a warm welcome to Dr. Asma Parveen ma'am as she presents on the connection, rehabilitation as a tool for healthy aging. Thank you. Pointer.
Good afternoon, everyone. Myself, Dr. Asma Parveen. I have come from the land of Jagannath, Odisha. My topic for today is the connection between the rehabilitation tool for healthy aging. So I'm going to talk about the balanced rehabilitation in simple. So change the slide. Slide change. So when we talk about balance, balance is nothing but the ability to maintain the tone of gravity with the base of support. So balance is nothing but we have two kinds of balance. One is static and one is dynamic balance. And then when we talk about more about balance, it is reactive or anticipatory balance. So we will be talking about the management for the same, for the static balance, dynamic balance, reactive and anticipatory balance. Can we change the slide? Can we change the slide? So whenever we talk about balance impairments, the prevalence where the older adults like age between 60 to 69, they report the balance about 46%, whereas the prevalence falls from 28% per year. So whenever we are talking about the balance, we need to know that the balance impairment system or the balance system. So balance is always associated with the three things. One is vision, one is proprioception, and this proprioception, vision and vestibular system is associated in turn with the cerebellum and cerebrum. So whenever we talk about the balance, we need to remember that it is the integrated system between the sensory motor. So sensory and motor systems are associated with the balance impairment. Whenever there is a balance impairment, what happens? It is always associated with gait impairment, strength impairment. To know about the gait and strength impairment, we have have to know about the various management available. Can we change the slide? So balance program components. So I'm going to talk about all these balance. One is static balance, one is dynamic balance, one is reactive, and one is balance during functional activity, which we also called as dual tasking. Can we change the slide? So first, what is the static balance? Whenever we talk about static balance is nothing but when you are in a constant environment, the base of support is not changed. So static balance refers to the constant base of support. So what all exercise which we can perform on static balance? It is signaling stand, tandem standing, toe or heel standing, turning or looking, but so all this exercise needs to be performed without changing the base of support. Next slide. So dynamic balance control. Dynamic balance refers to where your base of support is changed, and when we change the base of support, so what all exercise can be performed? It can be sitting on a therapeutic ball, tandem walking, or we can have bouncing on a trampoline. These all exercise can be included for the static and dynamic. So these are very simple, which we already know what is a static and what is a dynamic. What comes into picture is a reactive and the anticipatory. So reactive balance is something where the known stimulus, when we doesn't know the stimulus, whenever somebody push me, I don't know the stimulus. So what happened, this we can apply as a perturbation. So what happened with the elderly people, whenever they fall, so they don't come back to the righting reaction. The righting reaction is absent on them. So there comes the reactive and the anticipatory. So what can be trained to those patients? Can we change the slide? So these are some pictures of the static and the dynamic. So static are the first A, B, C, D, E, F, and the dynamic are for the trampoline, or you can use some Bosu ball or some mats, so which can be used for the static and dynamic balance. Next. So here comes the main part where actually the risk of fall assessment should be done, the reactive or the anticipatory part. Now there's a very minimal difference between a reactive and the anticipatory. Reactive is an unknown stimulus, whereas anticipatory is a known stimulus. Like a football player is standing in a stance. So he already know a ball is going to come and he's maintaining that position. But whereas in reactive, he doesn't know what is going to come. So if somebody is pushing me, I'm going to fall forward. But this is absent in the elderly or the geriatric patient. That's why training the patient or geriatric population with the perturbation anticipatory reactions are very, very important. So you can give perturbation in every direction, sideways, anterior, posterior. Okay, next. So there are some exercises which I have written for the for standing, sitting and the walking. Can we go to next slide? So you can see the exercise can be divided into basic, moderate and advanced level. So if I'll give you one example on the sitting. So on sitting what you can do is, you can have a group, because in geriatric we do group exercises. So in a group you can pass these balls. So one ball will be passed to the other. This is the basic. So what we can do, go for the moderate level, you can add either one motor task or a cognitive task. So in a motor task, what you can add is, while going with the, or while giving the ball, you can add one bending component. Okay. And in the cognitive task, in moderate level, you need to remember either it is a cognitive part or a motor part. But in advanced level, now you have to add both the things, cognitive part also and your motor part also. In cognitive part, what we can do is, we can add numbers. We can give 1, 2, 3, 4 and we ask the patient or geriatric population to tell us. So you can add both the things. So that can be done on sitting, standing and walking also. Next slide. So this is same for the standing. So in standing, what can we do? We can give a tandem standing. Along with the tandem standing, we can ask the patient to lunge forward, and then we can give some cognitive task as you can take your patient to either on basic, moderate or advanced level. Next, we can go to next. So this is for the walking. Walking, the best kind of walking, there is something called as slalom walking. Slalom walking is something where you put the mats. These Bosu mats are there, the balls are there. So what you can do, you can put 2-3 mats like this Bosu balls, and you can ask the patient to walk on that. And when the patient is walking, you can add some lunges on it. While walking, he had to do lunges, or while walking, he had to do some kind of cognitive task. Now remember, the cognitive task had to be done by the patient preference, that the patient has to be able to perform. Cognitive tasks shouldn't be done like you are asking the patient to tell the timetable of 90. So he doesn't know anything about. And you are asking and telling the patient doesn't know or doesn't have this cognitive tasking. Okay, so whenever we add any kind of cognitive task, we called it as dual tasking. So when a motor component as well as a cognitive component is been added. Next slide. These are some evidence-based program where n number of researchers has been done, where they have given this treatment for the geriatric population. The commonest one what we had is Otago exercise program. So the Otago exercise program was given by the New Zealand Foundation, where they have done for fall prevention, and in this fall prevention they have basically talked about the strength and balance. So they have given 17 exercises. In this 17 exercise they train the people for 12 to 14-15 weeks, and they take the usually the populations are 60 years to 80 years population they treat, and the exercise were done either one-to-one or in a group form. Can we go to next slide? So this Otago program, so they have 12 balance exercises and 5 strength-based exercises. Can we go to next slide? So these are the exercise. So these are very basic exercise which we do day to day, and we know all these exercise. So they have made this program, complete fall prevention program, in which they also added a warm-up and a cool-down exercises. You can see strength training, they have only done knee flexors, knee extension, hip adductor, ankle plantar flexors, very easy exercise. There is nothing much new in it. And whereas in balance, you see they have done toe walking, heel walking, all these simple exercise, because they are going for the 60 years of age. So the exercise has been kept very, very simple, along with the warm-up and a cool-down. Next slide. So the next gen or the next generation of exercises is your Tai Chi. Tai Chi can be done on land-based also and water-based also. Tai Chi are nothing but slow, purposeful movement, where what they do is they ask the patient to go for the slower and slower movement and feel the body where it is going through. So in this, Tai Chi is a very low impact and minimal stress exercise. That's why there is research going on with the Tai Chi. Tai Chi was done for relaxation. Tai Chi is done for balance problems in geriatric population, and it is quite famous. And Tai Chi has been done with many research, and they have said that one of the best exercise for balance rehabilitation is Tai Chi. Next slide. Then this is something new, which is called it as stepping on program. So stepping on program, actually what it does is it works for the strength, and it works for the stepping strategy is been used, and this stepping strategy is been used for the fall prevention. Whenever the patient is having this reactive problem or reactive balance issues, they go for the stepping on program. And a research has been done where they have seen that with the stepping on program, 31% of patient has been has been, what happened is that they have reported that their fall prevention has been minimized with this step-on program. So this step-on program actually is a group exercises. It cannot be done one-to-one. It has to be a group of people, 10 to 12 people, where they teach this step-on program. Step-on program, they works with the strength of the lower extremity. Next. Next is FAME, fall management exercises. In fall management exercise, they take care all together. They take of the strength, they take of the bone health, they take the endurance, the flexibility, the gait, the floor walking, everything they take into picture, and they give a fall management. Means they assess with one-to-one. This is completely one-to-one session has been given to patient. They completely assess the patient. They check for the osteoporosis. They check for the vestibular component. They check everything, and then they make a tailor-made protocol. FAME is completely tailor-made according to the geriatric population. It cannot be done group exercises. Next. Next. Last is matter of balance. So matter of balance works with the strength and cognition part. So it is associated that strength is associated with the fall prevention balance problem. So it is only works with the balance and the cognition part. So it is standing marches. What all exercise included? Side lying lifts, sit to stand, heel toe walking. So you can see these are very simple exercises. They just have given the name where they were working. They're working on the cognitive part and the strength part. Next slide. So how can we progress? If we are doing this exercise, progression is very, very important, right? So how can we progress in geriatric population? So you have to work on 5 things whenever we are wanted to progress. First is stance. Stance, what all stance can be we have? We can have narrow stance, and then we go for wider stance. Then we can go for tandem stancing. As you wanted to progress from basic to moderate and advanced level, you have to see the stance level. Then the support, the surface which we had. So what kind of a surface? So when we are taking for the balance program, the first is our constant support surface, which is the hard surface. Then we can go for firm surface, then we can go for Bosu ball, then we can change the surface, or then we can go for the uneven surfaces. The next is our vision. So all the balance exercise we all know it is done with open eyes, and then we progresses to closed eyes. Okay. Then last is the task complexity. How can we improve the task, or how can we go from basic level to the advanced level? So you can go for, first is single task. Means when you are asking your geriatric person that please do tandem. So once he has done the tandem, now you have to ask the patient to go, when you want to increase the level, so you will ask with the tandem you go for lunges. Right, and then when you wanted to do a dual tasking, so what you are going to ask your patient with the lunges, can you count from 10 to 1, right? So these all things you can do. Next slide. Yeah, I'm done. Next slide. So dosimetry, I have made this slide, dosimetry, how much dosage will be fit for our geriatric population. So first is warm up. So dosimetry, it should be approximately 40 minutes, not more than 30 to 40 minutes of exercise. It should include your warm up, it should include your cool down, it should also includes the exercises which you wanted to give. Next slide. So this is 8, so all the program, let it be Tai Chi, let it be any program we have, it is all there for 8 to 12 weeks. So the 8 to 12 weeks, how they have divided this 8 to 12 weeks, week 1 to 2, they have given only small group or 1-to-1. Then week 3 to 4, they have given advanced reach outs exercise. Then from a week 5 to 8, they have progresses to sit to stand, they have progresses to walking pattern. Then from week 9 to 12, they have given the reactive or the perturbation. All the exercise were given at different surfaces at different perturbation level. Next. So, dual task and multitask activities, what all you can include, I have listed some, like moving arm from here and there, buttoning and unbuttoning shirt, or cognitive counting from back to forward to backward, backward to forward. These are some dual tasking and for the reactive and anticipatory. Next. Home program exercises are very, very important. So in home program exercise, do not only teach the patient attendant. You have to give a pamphlet to them that these all things will be done. Because ultimately your geriatric population or your patient had to perform those exercises, not the attendant. It's good to teach the attendant, but you have to give a pamphlet where the exercise should be clearly define what we have to do. So there are some exercise which the sitting and the standing I have put. You make a pamphlet like this. You make the patient perform these exercises on your clinic. Make the pamphlet and give. Next. Next slide. Thank you. I'm done.
Thank you, ma'am. Thank you for the wonderful speech. It is my pleasure to introduce our next speaker, Dr. P. Punitha ma'am, Associate Professor at Savitha College of Occupational Therapy, with an immersively 24 years of clinical and teaching experience. Dr. Punitha is a highly accomplished professional holding advanced degree in occupational therapy, neuroscience, and counseling psychology. She was contributed significantly to the field with over 23 publications, is reputable journal indexed in UGC, Web of Science and Scopus, and currently pursuing her PhD. Her expertise lies at the intersection of neuroscience and mental well-being, making her expeditionally qualified to speak on today's topic. Please join me in giving a warm welcome to Dr. Punitha ma'am as she presents the Enhancing Cognitive Skill for Healthy Aging. Welcome, ma'am. Hello.
Thanks, dear. Good afternoon, everyone. Anivarakum vanakkam. Hope you all had a sumptuous food. Feeling sleepy also. I'll try to finish it fast, as principal already told me, given me only 15 minutes for my presentation. And first of all, I would like to thank the organizing team, Dr. Pradap and his team, for giving me this best opportunity. And moving to my topic, slides please. Moving to enhancing cognitive skills for healthy aging. The next slide. So usually I'm very good in neuroanatomy, but I'm not going to say about any neuroanatomy today, as because the time is running up. So I'll be telling about what is cognition and what are the domains of cognition and what are the structures involved in cognition and what are the brain changes with aging and cognitive challenges which they face, and what are the screening assessment can be done, and the cognitive rehabilitation for any pathological conditions, and how to enhance the cognitive skills with aging. Next slide. So I'm not going to read the definition, please read it, as because of a time concern. So cognition is nothing but how do you perceive information from the environment and storing it in your brain and retrieving it when it is needed. That is as cognition. And it is a definition given by APA. Next slide. So these are the subdomains which are given by the DSM-5. I'll tell you with the each. So there are 6 subdomains. Next slide. So this is a complex attention. That is the definition, you read it. It is nothing but the ability to focus on multiple things at once. Okay. What to ignore and what to attend. Okay. Now the next. So these are the subdomains of the complex attention. Before going to deal with the sustained attention, I'll tell you what is a simple attention. Okay. So can you please excuse me? The green color saree, can you please look at me? There is no green color saree there. Okay. How many of you looked at me and the way I showed the direction? Not looked at me? So then you have a poor attention. So the attention is nothing but attending to any stimuli. It can be visual stimuli or auditory stimuli. Okay, that is a simple attention. So, and attention given on an over period of time, it is called a sustained attention, otherwise called as a concentration. Okay, and the next is a selective attention. So attention in the presence of distractions. Now, so many people are talking, only few students are looking at me, even though the friends are talking and chatting with a phone and with the next person. So, okay, the only few students have a sustained attention and also a selective attention here. The previous slide. See, now you can see the one female is talking with the phone, the child is playing with the musical toy, and the whistling cooker is whistling, and the TV is playing in front of him. Even then, the person is doing an artwork. So this is called as a selective attention. Next slide. Then divided attention. Ma'am was telling that the walkie-talking. So walking and talking at the same time and listening and writing at the same time, it is called as a divided attention. Only few people are doing it now. Nobody is writing, I can able to make it. And the next is a processing speed. So the time taken to complete the task is called as a processing speed. Next. Then executive functions. The executive functions are how the ability the person has to plan and execute an action. That is called as executive functions. Now I can take it. The next slide, please. Now I can take the example of conducting this conference itself. Dr. Pradap and his team would have planned this conference in 3 months or 2 months prior itself and prioritize what could be the theme should be taken for this conference and whom to call like that. So that is the planning and prioritizing. And then they would have come into the decision making that this is a theme and these are the person we should contact. And the working memory, they should not have any flaw in between. That is called as a working memory. And the next is the responding to feedback and problem solving. So they'll be responding to some feedbacks from the other persons. So that could be nice or this will make a problem. So responding to that feedback and do the problem solving. And the next is the inhibition. They would have inhibited some unwanted things like having culturals because it will take time. So avoiding the certain, patterns which are not needed for this particular conference. And the mental flexibility, you should always have a mental flexibility like plan A and plan B. See now also, today also they had a plan B because they have, had a lunch before the presenter, one presenter. And the next is, next slide. And we have a third domains, learning and memory. Here we have immediate memory, recent memory, and very long-term memory. Immediate memory is immediately the person has to recall the numbers or the letters. Okay. In our day-to-day life also, we are daily using it. Can you please tell me one example for an immediate memory? So I'll tell you. The ATM, the OTP number, ATM number. The OTP number, you have to enter it. By seeing the message, you have to enter it immediately. Memorizing it and entering it. So that is the immediate memory. And recent memory is free recall. Without giving any clues, the person has to recollect the information which has happened 2 or 3 days before on the day from the morning. And the cued recall is, when you give a clue only, the person can able to recollect the information. That is a cued recall. ஒரு படத்தில் கூட ரோபோ சங்கர் அண்ட் விஷ்ணு விஷால் சொல்லியிருப்பாங்க ஃபஸ்ட்டு டே ஆரம்பிச்சதுலேருந்து காலையில் இப்படி வந்தா அப்படி வந்தான்னு சொல்லிகிட்டே இருப்பாங்க பட் த பர்சன் cannot able to recollect the information which is needed for that particular time. When Vishnu Vishal gives one clue, then the person could able to recollect the information. So that is a cued recall. And recognition memory, the otherwise called as orientation, the recognition towards a person, place and time. That is a recognition memory. And very long-term memory, again you have a 3 semantic memory, that is memories of tact. When you say which direction sun arises, we usually say it is a fact that it is on east, like that. So autobiographical memory, that is episodic memory, that is the remembering the events, date and timings. I think the women are good in remembering all this autobiographical memory than men. Then implicit learning is a procedural learning. that is unconscious learning of skills. And just think that the 10 years of Dr. Arun Kumar sir would have been using a car for 10 years, more than 10 years without using a bike. When you suddenly give him a bike to ride, could he able to do that? Ride the bicycle after 10 years without using it? Can anybody answer it? Yes, because it is a procedural memory. So we could able to ride it even after 10 years without touching the bike. So that is called as implicit learning. Next. So the fourth domain is the language. You have receptive language and expressive language. Receptive language is understanding the words which is given to us. And the expressive language is how you pronounce it without any grammar and syntax mistakes. The next. Then you have a perceptual motor function. You have three by using a vision, proprioception and the perception. Okay. So it is first visual perception is how you perceive. That is from the PPT how you perceive it. That is called as a visual perception. And visual construction is just copying it or doing a block designs. And the next is a perceptual motor coordination, that is integrating perception. Usually we do while donning of our dresses, inner garments and dresses like that. So this is an example. The next slide please. Then social cognition. Always we have a social cognition that we have to understand the other person's emotions. Okay, and also what he is having in his mind. Maybe he is laughing at us, but back of it, you would have, having some negative thoughts about you. Okay, so that is the theory of mind. And then next is the insight. That is, you should aware about yourself, your strengths and weakness. Okay, so with these kind of three domains, the person could be able to interact with the other persons nicely. Okay, the next is, next slide. Okay, now this is a neurophysiology cognition. So I'm not going to in detail about it. As I told you earlier, auditory, visual processing and language processing are very important. The basic skills for a cognition. Okay, next. Next we'll see what are the auditory processing area. I just name it because I don't have time now. So first we receive it in primary auditory cortex, and next it goes to the secondary auditory cortex to the Venix area for understanding, then goes around and goes to the Broca's area and we'll be speaking out. Okay, the next. This is a visual processing. So the stimuli from retina goes to the occipital lobe, the main, the 17, 18 and 19. Then it connect with the temporal lobe and parietal lobe for the processing areas. Okay, the next. Language processing, I already told you with auditory processing. Next. So this is attention processing. The stimuli from all the senses, I already told you, especially from the visual and auditory. Okay. So those stimuluses goes to the parietal lobe and influence with the limbic system. Then it goes to the frontal lobe to determine what is that stimuli. Next. This is a memory processing. For memory, hippocampus is the main area which is stores all your memories. Okay, so it along with the limbic system, it has inferior temporal lobes and parietal lobes parts also playing a major role for a memory. Next. Then executive functions. For the executive function, prefrontal cortex are the main area which are responsible for the prefrontal cortex. For the executive functions. Next. Then what will happen is this slide is already displayed by our surgical doctor, and there will be changes. So I'm not going to explain it. So there will be a shrinking of your neurons with the aging. So you'll have a problem with the gray matter and also with the white matter. So there will be a decrease in the volume, and as well as especially in the area of prefrontal cortex and also in the hippocampus. I already told you prefrontal cortex, they will lack of a what is that? Prefrontal cortex, executive functions. Okay, so they will have a lack in executive functions and they'll have a problem with the memory. It is because of, I already told you, explained by the doctor, especially there is accumulation of protein beta amyloid, and also there will be decrease in neuronal signs and synaptic density. Next. As already mentioned by the doctor, there will be white matter changes in the brain. This causes a memory decline. Next. So, what are the main changes with aging? So, with the evidence, I could make it out that there will be a decline in attention, reasoning, memory, and information processing. But in some study, they said that vocabulary is sustained or improved by aging. Next. So this is a graph which is grabbed by one article saying that with aging there will be a decline in cognitive, but some few persons they could able to make with the good cognition and physical abilities. Those are called as a super aging. Okay, next. So because of this cognitive decline, they could able to have a decline in their activities of daily living, mainly the basic activities of daily living and instrumental activities of daily living, and also with the driving and communication. Okay, first this is a basic ideal. Definitely while doing a bathing, they would have forgot about the soaping and toweling, and toileting also the same problem, and getting dressed, they couldn't able to button the dress, they would have forgot the buttoning, and walking also they'll stuck where to go and what to do. And the next is eating meals. இப்போ ஒரு புதுசா படம் பார்த்திருக்கோம், tourist family, that also that son would have fed him with the food, but the mother used to ask, இப்பதான் சாப்பிட்டோமாப்பா சாப்பிடலையாப்பா அப்படின்னு கேட்பாங்க. So that is a thing, they'll forget about the eating meals also. And the next is the personal hygiene. Definitely they'll have a flaw in the personal hygiene as because of these reasons. Next. So of course they have more problems with the instrumental activities of daily living. Same problem with the laundry and paying bills. Paying bills, one movie again, I want to show and give an example like Vadivelu would have forgot the ATM number. When he goes to that ATM machine only, he could able to remember the number. Okay, so like that. So paying bills and the preparing meals. நம்ம உப்பு போட்டோமா இல்லையா, இப்போ எதுக்கு போனோம், அந்த எதுக்கு நம்ம ஃப்ரிட்ஜு கிட்ட பக்கத்தில் போனோம், எதை எடுக்க போனோம், they would have forget. Okay, so that is a preparing meals. And shopping for groceries, the wife would have given the list, but the husband will go to the shop and forget about the list what should be bought. And the next is managing chores and cleaning. As like same problem, they would have a problem with the cleaning. Next. So next is the community mobility. As because of all the basic challenges, the person also have a problem with the community mobility. Next. So if this cognitive decline worsens, what will be the problem? So the major three problems arises with the aging. That is, one is mild cognitive impairment, we always say MCI, and also they have Alzheimer's disease and dementia, it's already told in the morning. Next. So what will be the causes? This is also told by the doctor, but I'll list it down. And the first is a neural, non-neural, and the mental health lifestyle factors. Neural have a lack of blood supply and damage to networks, circuits, neurotransmitters, and also because of pathological changes. And non-neural it is a temporary memory loss because of infections, metabolic and endocrine issues, and because of a lifestyle changes, they might have a cognitive issues. Next. So these are the tests to screen the mental ability, the cognitive abilities of a person. Usually we start with the MMSE and MOCA and LODCA, and those are the assessment tools especially for the specific cognitive skill decline. Next. So these are the main approaches as an occupational therapist we use. That first one is the remedial, then next is a compensatory approach. The remedial approach is when we think that the person could be able to regain the cognitive abilities, we use a remedial approaches, especially with computer-based programs, paper and pencils, and brain gyms. Okay, but it should be adapted to that particular person. One movie in the Vivek padam paathiruppinga, but adula vandu he wanted to test with the vision of a person. Okay, so idu therida potrupparu theridan ketrupparu, that person therila therilan solluvan, but appadan theriyum he is illiterate, that he doesn't know the word of So please select, we have to select the activity which is relevant to that person. Okay, so when the person is illiterate, we cannot give the numbers as a test or a activity. So we have to select the activity which should be appropriate for the persons with this contextual variations. And the next is a compensatory. Compensatory, we usually give alarms, calendars, and the diaries for remembering the things. Especially, I wanted to remember, I don't know, you see the Rajini films. One film, he has a memory problem. He was a lecturer in that movie. He used to go to the college without wearing the vesti. Okay, so அப்போ என்ன ஆகும்? அதுக்கு என்ன பண்ணலாம்? நீங்கள் ஏதாவது சொல்லுங்கள் பார்க்கலாம். Compensatory approach. Only he goes to the inner garment without wearing a vesti. So what could be done? So either you have to put a chart on the washroom with all the diagrams, with a sequence of programs, and otherwise you could have attached the dhoti with the inner garments. So this is a compensatory method we could make it. So some person will be combining with the both approaches. Next. So this is I already explained. Next. So in these rehabilitations, we have 3 phases. One is acquisition, application, and adaptations. Acquisition is just giving the awareness about his stents and what are the strategies we are going to use. The next is application. With that strategy, we have to select an activity and grade the activity from simple to complex and apply it. And adaptation is we have to implicate or transfer that strategy into their functional activity. Okay, next. So this is the main part, enhancing the cognitive skills with aging. So next. So this is a physical activity already would have been told you from the since morning. So walking, jogging, yoga, aerobic activities, dancing, gardening can be done to improve the neural plasticity. Next. Healthy diet. It is also taken by a lecturer. Next. And adequate sleep, they should have adequate sleep. Even next day will be very confused and tired. So you should have adequate sleep. Next, you have a stress man. There are a lot of relaxation exercises are there, but doing a meditation is the best stress management. Next, social engagement. I just wanted to give you only one activity. Can you please all close your eyes? Just think of your school days with the funny moments or any events which you enjoyed. Okay. Next. Again, close your eyes. Imagine yourself in 60s or 70s. You are in 60s or 70s and sitting next to your same age persons or with your grandchildren. Okay. Just imagine it. Okay. Now, சத்தமா சொல்லுங்க அந்த காலத்துல ப்ளீஸ் நாங்களாம் எப்படி இருந்தோம் ஸ்கூல் டேஸில் தேங்க்யூ ஸோ ஜஸ்ட் இஸ் இட் அ ரெஃப்ரெஷிங் ஒன் யூ ஹவ் ரெஃப்ரெஷ்ட் யுவர் மைண்ட் ரைட் ஸோ திஸ் இஸ் த ஒன் தே வாண்ட் ப்ளீஸ் ஆஸ்க் them to sit with the grandchildren and with the age mates to share their thoughts. Okay, it will refresh. See, in one study, they said that if you do the tongue movements like this, it will improve the cognitive abilities. But I'll tell you, along with the tongue movements, if you do along with the emotions, then it will give a better cognitive abilities. Okay, so the social engagement is very important. The next. So these are the mental stimulating activities. That is learning a new skills. Now recently I heard that the 3 members have passed NEET exam in their 60s. Okay, so this will enhance their cognitive skills. So those are called as super aging. Okay, that is learning new skills and playing a Sudoku, chess or crosswords or practice with the flashcards and quizzes. Okay, next. So can you please, any one of you give me the answer for this? Quick, fast. You are running out of time. Any one of you? What is the answer for this? P, right? Very good. So this is a P because in between A, B, they have given letters M, N, O, the next is a P, right? So this is a reasoning. You have to involve your brain. Okay, this will enhance the rerouting of your axons and neurons. Okay, so this is the, these are the plays you can play with your elder people. The next is, these are the example for the mental games. I already told you, especially Adipuli Atam and Pallanguli, along with this, chess and cards. Okay, next. So this is already taught by the other lecturers that Health management is very, very important. You have to regularly have a checkup with the doctors to have a very good healthy. Next, protect the brain from injury. Already now only the madam has taught you how to protect you from falling. Next. So almost all, I would like to tell you one thing, that one is more than important than these slides. What is it? This is love and care, right? So give them love and care, which they have given to you, given to us when we born and grown. Please give them back. Thank you so much for your patience for listening. Thank you.
Thank you, ma'am, for your insights. We now move to a topic at a very frontier of rehabilitation technology and its potential to transform elder care. It is my distinct honor to introduce our next speaker, Dr. Kumaresan Abatsagayam Sir, Professor and Head of College of Physiotherapy at St. John's National Academy of Health Sciences in Bangalore. A dedicated educator with over 17 years of experience, Dr. Kumaresan Sir is a renowned leader in neurorehabilitation and community physiotherapy. His profound impact is evident through his mentorship, having successfully guided 6 PhD scholars and over 150 postgraduate dissertations. And prolific researcher, he has an impressive 209 publications, including 64 in Scopus Index journals, and holds 3 patents. His work is widely recognized, earning him numerous awards, including the Best Academician Award and Outstanding Researcher of the Year. A passionate advocate for integrating innovation into practice, he is a sought-after resource person on cutting-edge topics like AI in healthcare. Please join me in giving a warm welcome to Dr. Kumaresan Sir, who will now present on AI and advanced rehabilitation for older adults. Thank you.
Hello, hello.
Hello. Am I audible? Very good afternoon, one and all. Am I audible? Can you please respond? Am I audible? It's very proud moment for me to stand in front of my Guru Dr. Pratap sir. Even I have received graduation from my postgraduate and PhD graduation from this stage. Thank you for these opportunities, Sniper. Thank you for this opportunity, organizing team, this conference. Today I am going to talk about AI and advanced technology about geriatric rehabilitation. The aging population is almost increased in the worldwide and India. Because of that, the people will get frailty and chronic diseases, cognitive decline, and mobility limitations. See, in worldwide, according to WHO, October 2024, the article released 1 billion in 2020 and is projected to reach 2.1 billion by 2050. In India, 149 million people are currently around 60 age, are older, and it is predicted to grow around 28% increase to 347 million by 2050. These are the areas AI play a major role. Movement analysis and biomechanics we can use for assessing the patient, and predictive analytics, rehabilitation and exercise planning, telehealth, remote monitoring, intelligent assisted chatbots. We can see furthermore slides in this. See, first of all, the fall prediction. Fall is the major problem for older age people. Fall prediction wearables are there. Smartwatch and smart insole smart waist belt. Okay, with this we can easily analyze and we can identify fall prediction fall prediction rate. Collecting the movement data, wearable sensors like these three record how older adults are walking and stand and turn. See, for example, if pivot turn is very difficult, we can analyze and we can give as a physiotherapist, we can give the treatment techniques for pivot turning alone or gait training or stair climbing, whatever it may be. Next is balance training. With use of the waist belt, sensor track how steady a person is while standing and moving. It can be easily, you can find out with the use of the waist belt. AI-enabled floor mat, which is used for many smart homes. AI-enabled floor mat, which is used for to find out the gait training, how many steps they can use, and walking pattern analysis, gait speed, stride length, step length, everything we can use with use of the AI-enabled floor mat. Predictive fall probability. All AI calculates the chances of falling in the next few weeks or month. Okay, this will be used with the use of the computational neurology. Some quantification is quantification. With use of the quantification, we can easily assess the prediction rate, whether they can predict predictable, they can fall in next few months, or how they are used, abnormal gait patterns, everything we can assess with use of the predictable fall probability of AI. These are the wearable sensors we can use: smart glasses, smart watch, smart shirt, and Bluetooth key tracker, smart shoes, smart socks. Everything is AI-enabled equipments. Once the patient can wear, or geriatric people can wear, the patient is called as sensor-enabled human being. Okay, with this, we can assess, see, for example, the range of motion. Sensor-enabled assessment we can do for range of motion measurement for cervical region. The person is doing a flexion extension, the measurement automatically, it was deducted in the table. The side flexion and same side, opposite side flexion also we can easily measure with use of the AI tools. Predictive analytics. See, you know everyone, the major problem is osteoarthritis of knee, geriatric people. Osteoarthritis of knee, in the X-ray, we can easily predict how much joint space is there, what is the subchondral bone strength, and what it will be used as a quantification. Okay, this is what we can easily assess: joint space narrowing, osteophyte formation, and subchondral bone changes. See, now the predictive analysis means now at present and this today, how was the X-ray, and even after 5 years or after 10 years, how was the joint space reduction is there, how much predictable space is reduced, how much osteophyte formation is occurs, everything we can easily identify with use of the AI tool. Even pain assessment we can do with use of AI. AI can analyze patient-reported pain data such as a pain. Even we can identify how much intensity is there instead of pain algometer, location of the pain, and duration of the pain to assess impact of individual pain experience. All the pain experience should be stored already in the machine learning stored data. With use of that, we can compare the patient area. See, this is pain assessment, one digital model. See, patient is lying, the geriatric patient is lying. So many cameras is surrounding in the patient area. See, for example, in old age home or some medical hospitals and all, we can fix it this one. Front facial camera, side facial camera, thermal camera, and body camera microphones. This should be attached surrounding the patient. From this, the camera is captured. Signal acquisition, whether it should be a psychological pain or physiological pain, it should be differentiated, and even paralinguistic activity, it should be recorded, and video facial expressions, gesture also should be recorded. Other signals also should be recorded. This should be processed with use of the AI or machine learning. the output patient experience, pain of severity level and other whatever the pain experience, intensity, location, everything should be tracked in the AI. Okay, this is how we can quantification occurs with use of the AI about the pain assessment. Next is gait analysis. AI enabled human body. We can use biomechanical modeling. We can assess joint kinematics, joint movements, ground reaction force, joint reaction force and muscle forces, muscle activation with use of the EMG. Each muscle having a different, we can give different color codes, whether it should be working on concentric or eccentric, how much muscle compound action potential will be happen each muscle group, easily we can assess. Along with that, stride length, symmetry of the gait, joint angles, velocity, cadence, ground reaction force, range of motion, acceleration also we can assess. See, these are the things we can, whatever we have seen with use of AI, we can assess easily. Next is rehabilitation part. You already know, everybody aware of that virtual reality is one of the major treatment technique recently emerged. See, patient is sitting with Oculus Quest in front of the monitor. The patient is walking. We can give gait training along with upper limb reaching activity, the catching activity with use of the virtual reality. It should be a realistic scenario for the life, whatever. It should be mimic and realistic the scenarios. Immersive technologies provide patients with engaging, interactive environments that mimic real-life scenarios. Stimulate multiple sensory input. That means vision, proprioception, and cortical reorganization also occurs because of the virtual reality, reinforcing brain activities, synaptogenesis, and dendrite sprouting, many things. All the neuroplasticity activity will be happen because of the virtual reality training. Next. See, this is upper limb activity of virtual reality training. With use of this, it should be a, see, for example, if old lady, 50 years or 53 years old lady having a upper limb dysfunction, we can ask the patient whatever the household activity, we'll ask the patient to serve the food. Like that and all, we can have a real life mimic scenarios we can use with use of the virtual reality. Next, it should be a immersive rehabilitation environment. Whatever the environment we are day to day facing activities, ADL activities, we can fix it, we can use for virtual reality. Balance and coordination training also we can give. Next. Pain and, see, in virtual reality training, it should be pain. If it is there, it should be distracted and the patient can feel very relaxed position. Easily they can engage with the activities. Motor, which is used for motor rehabilitation and functional training also. Next. Next is brain-computer interface. Brain-computer interface, I think neurosurgeon also deep brain stimulation, that and all morning they have spoken about the brain-computer interface. Is a technology that allows a person to interact with a computer by using brain signals rather than body's peripheral nerves and muscles. Instead of peripheral nerve and muscles, the brain signals, it can activate and interact to the computer. With the use of the exoskeleton, the end organ will be activated. This is what brain-computer interface. BCI translate brain activity with use of the electroencephalogram, electrocardiography, and FNRI, functional near infrared spectroscopy, into external commands for feedback or control of the devices. See, for example, patient thinks about, I want to write hello. It will be transferred to the AI. AI can give, with use of the exoskeleton, automatically the dysfunctioned arm or dysfunctioned hand should be writing hello. This is what brain-computer interface work. In future, maybe next 10 years, these all together maybe it will come. Okay, AI plus BCI and VR and robotics, artificial intelligence, brain-computer interface, and virtual reality, robotics, all together. If you are treating easily, the patient can, neuroplasticity also will be increased, easily the patient can recover. See, with Oculus Quest, exoskeleton is there, AI and brain. These all together, it will be working. We can easily rehabilitate the geriatric patient. Virtual reality, it create a multisensory stimulation. Ecosystem, accelerate the brain rewiring. Immersive, gamified environment it creates. And robotic, execute the action of the end organ or extremities. These all will be worked with use of the closed loop system. Closed loop system, the closed feedback system. When the sensory demand is creates, with the use of the sensory demand, we have to do the motor activity. The same thing here also it's happened. When the brain thinks, automatically the AI, it gives the commands to exoskeleton. Exoskeleton is activated to the activity, the execution program. This is what in next 10 years, this is what will happen in the rehabilitation phase, advanced technology. AI robotics, see, recently I have watched one Japan news. In that, because of the healthcare professional demand, they discovered robotics. Okay. See, robotics is turning the patient, because it can be used in the hospital also, because to prevent secondary complication, bedridden patient, if any bed sores are there, to prevent secondary complication, we can use these robots. Maybe another next 10 years in India, it was there in the Japan. Even ADL activities also can do. The person is, next video, the person is wearing the socks. Next. The person is wearing the socks with use of the robotics. These are the ADL activities. The robotics which is used for the rehabilitation instead of healthcare workers. Exoskeletons. See, this is a lower limb exoskeleton. Exoskeleton with have a wearable sensors. Sensors is there. If you want to activate the lower limb activity, if you are touching that sensors, automatically, if you want knee flexion or knee flexion, ankle dorsiflexion, hip flexion, everything should be, you will bring back with use of the sensors. Exoskeletons are wearable robotics, which is used for frailty in geriatrics or the dysfunction of that particular extremity. Can provide mechanical support at the hip, knee and ankle joint, improves walking pattern, weight, shifting and balance, which is used for upper extremity also. If any problem is there in upper extremity hand function, with the use of the exoskeleton, we can rehabilitate the patient easily. Next is telehealth remote monitoring. See, telehealth remote monitoring, AI-powered telehealth platform enabled physiotherapy to remotely monitoring the patient progress, and we can give guidance through the tele-rehabilitation. The real-time data we can get, and movement, even vitals also we can check, muscle activity, provide immediate feedback, patient allowing for continuous care and reducing the need for the in-person visit. Next. Next. See, in this video, the range of motion is measured. Even in tele-rehabilitation also we can measure with use of the camera. Tele-rehabilitation also we can measure the range of motion. Next. Range of motion, and if you want to teach some exercises, you can teach easily. Next. Tele-rehabilitation, even if you want to teach through tele-rehabilitation home exercise also we can teach. Data analysis for remote monitoring, predictive analytics, X-ray, how we have read in X-ray, ONE X-ray, like that we can use for tele-rehabilitation with use of the captured camera. Intelligent assisted chatbots, AI-driven Chatbots, virtual assistants can provide patient information, guidance, and support through the rehabilitation journey. Next. These tools can answer frequently asked questions, provide exercise, demonstration. The patient home itself, they can find out and they can do the exercises. Next. Next. Chatbots, it can give the information about the condition and about the treatment, about the education, about the condition and the treatment easily. Exercise demonstration, it will be there. The instruction also we can download and you can see. Reminders and reminders for the taking the medications and medical appointments, compliance monitoring. It should be a emotional support like Alexa and Google TV, Google Home devices, emotional support, and it should be a motivated one for the geriatric patient. Next. This is gamification and motivation. See, gamification, the person is having, if you want to give lower limb training, see, ask the patient to hit on the ball towards the goal. Okay, this is patient can enjoy it easily and the motivation also will be increased. Even patient engaged in this system according to the difficulties of the level, we can choose the game. Next. By tapping into brain reward system, gamified rehab promotes the dopamine release. Dopamine, which is used for learning purpose, long-term learning, the patient brain also should be activated. Gamification used game-like elements, the points will be there and levels will be there, challenges is there, it can give the feedback and rewards also. So patient easily motivated and patient can easily rehabilitate. This is one example. Benefits of gamification, learning will be there for geriatric patient, user engagement, motivation also is there, achievement because of the level and challenges, some scores they can achieve, rewards also they will get, and challenges. One level if they finish, the next level they will go. These are the challenges they can face. Next. Mechanism, I already told, dopamine mediated learning. Because of the dopamine, the attention is increased, working memory also increased. The cells, neurons are getting long-term potentiation, so neuroplasticity also will be maintained and increased. Emotional enhancement learning, positive emotional associated with this progress, norepinephrine and serotonin release, strengthening of the memory and consolidation, and synaptogenesis is happen. Between two new synapses connection also will be happen because of the gamification. Sustained practice effect, motivation is increased adherence to the therapy or training. Next. Smart homes, AI sensors, this is very helpful for the geriatric patients. Next. See, wearable sensors with the patient and activity detection also we can use of the camera. And next is sleep monitoring, environmental monitoring, home security system, energy management, home automation, remote service platforms. These are the advanced technique will be there in the geriatric home setup. Next. Smart homes with AI enabled, it prevents the fall mainly. It prevents the fall. If any dangerous condition, automatically the alarm also will be there. So emergency alarm we can set and it will reach us to the caregiver or any NGOs or health services, other public services or relatives. They can easily monitor smart homes. Here in the detection is there, detector is there, pressure mat, food detector, temperature detector, climate also they can check. Next. Key features of smart homes. Safety and fall prevention is very important. Fall detection sensors is there. Motion sensors also will be there. So we can check whether the patient is moving, how many times they went for bathroom, and whether they can be able to walk or not. These are the things we can assess. Automatic alerts it should be given to the caregiver, medical services. Emergency buttons also there. Health monitoring, vitals also we can check with use of the detectors. Next. Next. Already told, even smart kitchen is there. Shut off of the stove and oven automatically. If the person can stand with use of the sensors, automatically it will on, automatically it will off. Okay, promotes independence. Smart homes promotes independence, safety, chronic disease management, hospital admissions, and peace of mind for the family members. If smart homes, the geriatric people are staying in the smart homes. Next. AI-enabled assistive devices. AI-enabled assistive devices, it can support mobility, communication, cognition, and independence. AI-enabled, next. AI-enabled assistive devices, which is used for they can use a wheelchair, cane, rollator, walker. Okay, these are the things we can use. Next. This is wheelchair, AI-enabled wheelchair. Next. Smart walkers. Smart rollators or smart walkers we can use. Next. See, this is what the final message from this presentation. AI doesn't consider feelings or empathy, and that's its strength. Okay, the human being, they feel the empathy and other things, but AI won't. That is what its strength. It means no bias, no forgetfulness, and no inconsistency. Okay, if a person is there, the therapist is tired, okay, healthcare workers is tired, the mind will be changed. We cannot give so much of proper treatment. Okay, the patient is tired, we can show the empathy of the patient. So this won't be there in the AI. For seniors who need dependable care, AI offers round-the-clock assistance that never wavers, delivering safety and comfort with mission-like accuracy. Next. Next. Thank you for your attention. Thank you for opportunity, the Sniper team, organizing team, my Gurunadhar, Dr. Pratap sir. Thank you so much, sir. Any doubts? Any clarifications? Because of short time, I have finished very fast. I have taken, otherwise it will take some time.
Thank you, sir. Thank you for your valuable insight.
So with that, I would like to thank
Ladies and gentlemen, we now arrive at a crucial segment of our conference, the panel discussion, on our central theme, Interprofessional Approach of Healthy Aging. This discussion aims to weave together the diverse threads of knowledge we have gathered today, highlighting how collaboration across healthcare discipline is essential to promoting holistic well-being in aging populations. We are truly privileged to be joined by an esteemed panel of experts, each bringing invaluable insights from their respective fields. Allow me to introduce them. Representing physiotherapy, we have Dr. V. Balachandra sir, Principal of Jaya College of Physiotherapy, a seasoned academic and clinical reader with over 25 years of experience. Dr. Balachandra sir, Principal and Faculty Member of Graduate Studies BPT and Postgraduate from College of Physiotherapy, Jaya College of Paramedical Sciences. He is nominated as a member of PhD Screening Committee of the TN Dr. MGR Medical University. He is nominated as a member of Persual Committee for Grant of Affiliation to Physiotherapy Colleges under Dr. MGR Medical University. He is the member of Board of Faculty in Dr. MGR Medical University since 2013, member in Board of Studies at Satyabama University since 2023, and a member in Panel of Research Grant Approval Committee. He is also a member in Board of Studies under the Dr. MGR Medical University, Pondicherry University, SWIMS University, and NTR University of Health Sciences since 2008. He is a member in Inspection Committee for granting affiliation to physiotherapy education. He is a member of Expert Committee, International Center for Collaborative Research at Omayal Archi College of Nursing, Chennai. We welcome you, sir. Also representing physiotherapy with a focus on developmental care, we have Dr. M. Rajeshwari Ma'am, Associate Professor at SRIHER, whose work is early intervention for high-risk infants and children extends importantly into lifelong wellness. Dr. M. Rajeshwari Ma'am, currently working as Associate Professor in Faculty of Physiotherapy, Sri Ramachandra Institute, joined as clinical physiotherapist in 1997 after completing her undergraduate degree from Government Institute of Rehabilitation, Chennai. Completed her master's degree in neurosciences from SRIHER in 2007 and completed PhD in 2024. She has been working in Vidya Sudha Center for Children with Special Needs from 2004 and Karthikeyan Child Development Unit from 2010. Area of interest is early stimulation and early intervention of high-risk infants and working on motor skills in children with special needs.
We are honored to welcome Professor Dr. R. Vijayalakshmi Ma'am, Principal of Savitha College of Nursing. She holds a PhD in Nursing from the Tamil Nadu Dr. MGR Medical University, along with a Master's Nursing from Apollo College of Nursing and a Bachelor degree from MA Chidambaram College of Nursing. With extensive clinical teaching and a leadership experience in both India and abroad, she has served as principal in several esteemed institutions and contributed widely to the nursing education and research. She has published enormous scientific articles, guided funded projects in the community health, and is a certified professional in NABH, nursing standards and palliative care. A sought-after speaker at the national and international conference, she continued to inspire through her academic excellence and leadership with a privilege to have with you, ma'am. And we are pleased to welcome Professor Dr. Arun Kumar, Principal of Savitha College of Occupational Therapy. He completed his BOT and MOT from Tamil Nadu Dr. MGR Medical University and is currently pursuing his PhD in Rehabilitation Science. With over 16 years of experience in teaching, clinical practice and research in the occupational therapy, he has contributed widely through national and international presentations, publication in reputed journal and article in Religion magazine. He also serves as an executive committee member of All Indian Occupational Therapists Association and has organized enormous workshops, seminars and hands-on training program for professional development, and we are honored to have you with you, sir. We are honored to welcome Dr. Lavanya Pratap Ma'am, Professor of Anatomy and Principal, Simats College of Allied Health Science. She completed her BPT from the Tamil Nadu Dr. MGR Medical University and her post-graduation and PhD in Medical Anatomy from Savitha University. With over 16 years of teaching experience in national and international university, she has also completed certification from Australia and the USA, lifestyle medicine and health professional education. Her research focuses on cancer prevention strategy, and to her credits, she has over 170 indexed publications, 5 patents, and has been invited speakers various national and international conferences. She currently also serves as chairperson of Institution Animal Ethics Committee at BRULEC. We are privileged to have you with us, ma'am.
Now, I kindly request our Honorable Principal Sir, Professor Dr. Pratap Suganidhi Babu Sir, to felicitate Dr. Balachandra Sir. Now, I request our Principal Sir to felicitate Dr. M. Rajeshwari Ma'am.
Guiding this distinguished panel is our moderator, Professor Dr. Pratap Sugandra Babu Sir, Principal of Simats College of Physiotherapy. Let us give them all a very warm round of applause as we begin this important conversation on building bridges across the profession of healthy aging.
A warm good afternoon to all the audience for patient waiting, and on behalf of the panel members and all the faculty members here, I take the privilege to welcome two of the external expert members, or the members like Dr. Balachandra sir and Dr. Rajeshwari madam from Ramchandra University, Rajeshwari madam, and Dr. MJR University from Jaya College, Balachandra sir. We welcome you, both of you. From all the principals, I am just taking this opportunity to welcome you. And other principals here doesn't require introduction, all of you know. And just to get into the session, today's session theme is, panel theme is like, as you all know, that interprofessional approach towards healthy aging. And may I request first Balachandra sir to initiate that discussion on healthy aging. I mean, today geriatric population, today morning we had a lot of sessions, and afternoon also followed by a lot of sessions where various experts from various fields on health sciences shared their extensive knowledge on how to overcome aging, how to be healthy even during an aging journey. So I hope you would have carried some inputs out of all those sessions to finally summarize and also to finally discuss on the key factors and key facts of the healthy aging. Particularly geriatric population faces a lot of challenges nowadays, and not only challenge to the individual and also the multidisciplinary team as such. We require a lot of evidence-based approaches to help the mankind. So I hope this panel discussion will bring out some fruitful knowledge to be shared. May I request Balachandra sir to please initiate the discussion.
Good evening all, am I audible? It is wonderful really this evening to be present with so much number of audience, because we are towards a graying population, but we find so many black-headed fellows around us sitting to watch about this interprofessional beat on geriatric healthy aging. How are we going to face all these challenges and to learn much about it? I take this special opportunity first of all to thank Pratap for having organized such an event, and this theme also. This theme is again the theme what the World Confederation of Physiotherapists has also chosen for this year. So it's great being here with all of you. It's like how to age gracefully. that is being how healthy even when you are getting aged is the theme. And we find the total population of India, because of advancements of medicine, this graying population is far more in number among all the census. That is the reason in every 5-year plan of our country, lot of economic resources are being fixed for the aging population. Unless and otherwise, if you are updated with the community approach of what the state government and central government are doing towards aging, it's a great opportunity for all of you to have a scope on this particular area. As such, as physiotherapists, today with all these advancements of what the speakers have said, you would have seen this for healthy aging, physiotherapy has got a very great role to play. Despite so much of literature evidence available, we find a lacunae in this field of professionals, particularly physiotherapists who are selectively interested to attend geriatrics. That is one among the reasons we are getting up a branch elective also on geriatrics in our PG courses. So the specialty of geriatrics is fast emerging, and each one of the physiotherapists has to have a knack of handling all these cases, be it in terms of this evidence-based practice on problems commonly evolving, either musculoskeletal, neurological, or the mental health, which are the determinants of a healthy aging population. Why do we need to grow healthy in aging too? The reason is we need not to be dependent upon any of these people who are around us. So how to become independent? The only source available is that to maintain a good health. So as physiotherapists, we have got this plan of action in each and every role we play in preventive and promotive aspects. On today's sessions, whatever you have seen, you would have seen on frailty, cognitive impairments, or all these, the geriatric population which mainly they face. And beyond all that, we also saw how advents of or adjuncts coming up through physiotherapy can be employed to avoid all these risks in this healthy aging, to be attained in a happy manner, to lead happy long years of life. So the theme goes with this, and we all need to undermine the importance of physiotherapy in that, and how fellow professionals can be roped in, because we saw without adequate and ideal nutrition, so many elderly do have health issues related to nutrition and diet. So we need to support of a worker with healthy knowledge upon diet. So we need a dietitian to support us. Also we need fellow occupational therapists who can plan for architectural-free barriers, not only at home but also in public places. So our team will require many such professionals, and particularly nursing care for all those who are in need with aging, who are not able to have their own, maintaining their daily ADL is becoming a crucial problem for all this. So for all this teamwork of network of professionals is mandatory, and we need to know for which issues we need the support of these people and when to call upon them. For this, a physiotherapist has to be updated with this day-to-day activities of the elderly, how to manage their daily problems. So your assessment will be quite pretty long to sit beside them, to learn from them, and for this you need to equip yourself to face all these issues in the oncoming days. So I request each and everyone to do your level best to understand this problem with this aging, and how to manage people with elderly people, and how to cope up with their issues, and how to plan for their management. I request, like, if anyone has got any doubts or clarification regarding these topics on health issues, what we discussed today, you can come up with your questions.
May I request Vijayalakshmi Madam to throw a few insights into nursing care into geriatrics.
Thank you, sir. Good evening to all. Thank you for the opportunity. So we know that nursing profession is having a major role in promoting the health and preventing health for the aging people. And gerontological nursing is gerontology, it's from the Greek word, it's old age people. So it is facing on person alone. It is not only a person, one who is aged. We will be thinking about the caregiver and also the community people, one who is working towards, and also the family members, one who is supporting the things. So the nurses has to take care of the person, the old age person, and the community, and the caregiver role, and also along with the family members, we have to give the education and adopt to the situations. That is the one thing I want to tell you that. It's a second one, the fall prevention, and so many people are talking about from the morning. So it is the immobility and also the age. The respect of the people is now it is not coming into the concept. That's an emotional and psychological respect, it's very important. So because they will be more talkative and they want the attention seeking, because it is like a tantrum and all those things at the child age people, they will go back. So we have to respect those people's feeling, and you should not lock them in one door. So separate room is given to them. So it is no one should disturb the old age people. These are the concepts are coming nowadays. And also now it is everyone is moving around the old age homes. All the people rich people are going into the old age home, they are living in separate along with their family. They are leaving the family, they are going to those people's old age people. So that is nowadays is coming common. One who is having a money, they can go. But one who is in poor people are neglected in the community level. We are seeing that they are abused. They were not taking care of them, and they were not deprived of nutrition. Not even meeting their basic needs. These are the things in community as a nurse we have met. We used to go door to door steps. The people are not addressed at all. The people will be lying down in the corridor or in the outside of the house, where there is a shelter is not available. So that people is nowadays, so many volunteers, the youngsters are doing a more care, and they are coming and admitting the people. So in the hospital setup, it is not only the care has to be provided, the community setup, it has to be given care, and the physiotherapy people and the occupation therapy, it's are routinely visiting the community part of old age people has to be addressed in future. That is a one thing. And physiological needs are met very nicely by the everything, adopted by the old age people, but the emotional needs has to be met, and responsive care we have to give, respect to the people we have to give. And the health system, we have to make a safety environment, as I said earlier. The safety environment, it's from not only from the floor and other things, but the one who is surrounded by the people. So that has to be enhanced. Meet their basic needs, tell them to be independent, and incontinence and other things and all is more common. Skin care is more important for them, and food is everyone will be giving, but the healthy food is very important for them. Which one has to reduce, which one has to be given more concentration, because the calcium will be more it's needed, and fat will be reduced, oil food will be avoided, and indigestions will be more common, and health issues and all we have to take care in that. Anything else I can contribute in future?
Yeah, madam. Thank you, madam. We can have a discussion later. And may I request Dr. Lavanya to share a few words on lifestyle habits, since her specialty is also, one of her theme is also lifestyle modifications. She is the expert in that. Please throw some insights.
Yeah. Good afternoon all, and good afternoon to the panel members also. Nice to meet you here. See, healthy aging. Aging is a process which we should accept and embrace it happily. It is not something, a stigma or a process that we have to worry. Just embrace it happily, which is going to begin as we grow. See, from the time of birth, from birth, 0 age to by the age of 30, we grow. Okay, so most of us from the, as I told, from age 1 to age 25, we feel happy as we grow. Is it not? I am growing, I am into my 10 years old, I am 15 years old, I am 20 years old. You mature both physically and mentally, but you will be under supervision of your superiors. Is it not? But as we reach between 25 to 30, we are becoming semi-independent and independent. There will be a slow transition. So till the age of 30, I am talking about not only the physical, mental, but also the cells. Okay, just shift your mind to the cellular level also. It starts, aging starts from a single nucleotide. What do you mean by nucleotide? What is present within the cell, which has the nuclear component? What is present in the nuclear component? The DNA. What DNA is made up of? Genes. Okay, what a gene is made up of? Nucleotides. Can you name the nucleotides? Only just 4. ATGC. Okay, so only 4 ATGC, but the different combinations of ATGC are sitting here. No, each and every one is different, but it's only 4 letters. Okay, but the probability and the frequency and the variations it shows, we get different people are here. Different personalities are here. So we need to take care of each letters. We need to take care of each these nucleotides for a healthy aging. So think from that level. So nucleotide, changes in the gene, changes in a cellular level, then moving to the tissue level, organ system level. Right? This has, all these processes are influenced both by the physical environment what we are facing, or the mental or emotional environment what we are facing, and the physical well-being as such. No? The structural component, anatomical component, each and every muscle, tissue, blood vessel, each things you have to take care. The every breath what we take, just to make sure 99% of us, and most of the time we just do shallow breathing. Is it not? When you take a deep breath, just think it has to reach every cells, each and individual cells. In that way, your breathing pattern should be. If that is going to be a breathing pattern, then your aging will be healthy. But due to our lifestyle habits, due to our environmental stress, our lifetime commitments, we most often we end up in doing shallow breathing. We give a separate time for exercise. We give a separate time to do breathing patterns to maintain it. At least that way we have to cope up with that. So I like to share 5 keys that we have to maintain for a healthy. I'm just focusing on preventing. See, as I told, till 30 years of age, our cells will grow. After 30 years, the proportion of the cell growth and the cell death changes. Okay, if there is a damage in one cell, the process of growth of new cell is more till 30 years of age. Okay, cell growth is more than the cell death. But after the age of 30, cell death and cell growth are equal. After the age of 50s and 60s, it depending upon our lifestyle habits again, the cell death will be more when we proportion it with the cell growth. So this is how the aging process occurs. Aging in the sense, it doesn't mean only the physical changes. Okay. As I was telling about the cells and the tissues, it matters for our mental well-being too. So it is the biological age, chronological age. In addition to this, we have mental age also. It is the mental maturity that we have. Only if these 3 come in alignment, we will have a healthy aging. So we should make sure our mental well-being is good, our physical well-being is good, and our mental maturity level is good. So for this to happen, we have to maintain 5 key factors, which I like to highlight, and you should never forget this till your lifetime. You can share it to your family members, friends, neighbors, and relatives. So first thing is your physical activity. Keep yourself active always. Right? Keeping ourselves active in the sense, avoiding sedentary lifestyle. Okay, avoiding sedentary lifestyle. So people will tell, I just don't use lift, I used staircase. So this shows that you are active. In addition to that, we need to concentrate on a moderate physical activity. From today, in the morning, till now we were coming across so many sessions, experts were giving talk for exercises. So they have given many dosages too. So just to maintain a normal healthy aging, we need to do 20 to 30 minutes of moderate physical activity, minimum 5 days a day. 5 days a week. If this is going to happen, irrespective of age, I'm telling, if this is going to happen, the intensity of the exercise may vary, but it is wise enough to have a moderate intensity exercise. If this is going to happen, it is going to have its impact in the genetic and epigenetic level, as I told you. So keeping us active doesn't make epigenetic changes. Epigenetic in the sense, it is the one which is going to control our genetic mechanism as such. Okay, epigenetic changes is going to regulate your life, entire life. So for this change to happen, we need to have a consistent, continuous 20 minutes of exercise. Okay, this is one. The next is the food pattern, the nutrition, the balanced diet what you take. So it has been classified as vegan, vegetarian, semi-vegetarian, pesco-vegetarian and non-vegetarian. Vegan is avoiding dairy foods and egg. Vegetarian who will be taking egg alone. Sorry, dairy products. Okay, they take dairy products and vegetarian food. Semi-vegetarians are those who take egg, dairy and the vegetarian foods. Pesco are the one who take fish as a main source of food. And the non-vegetarians who take the non-vegetarian. Either it can be a frequency of 1 week or in a regular basis. So in accordance to this, the risk level increases and the process of healthy aging is also in proportionate to it. It is going to have its negative impact. So this is with respect to the food. Next, coming to sleep pattern. It is mandate to have 8 hours of sleep. At any cost, it is mandate. Maybe once in a while, that's fine. But consistently reducing the sleeping hours is going to have a vicious impact. Vicious cycle will be there. The next is stress management. Everyone are, even the school-going children nowadays, they are reporting, yes, I'm stressed. Are you having stress? It has become a common term to discuss. So we have 2 types of stress. Eustress, have you heard? Positive and the negative, which is going to have a negative impact to us. And the other one is eustress. So we will have a continuous activity which can have an impact. People will ask, you look stressed. But if you are going to do any work from our heart, with complete dedication and commitment, it is going to be your eustress. It is not stress. You read, you are preparing for your exams. If you feel like this is a burden for me, it is going to be a stress for you. But if you love it and do it, it is going to be eustress. For us to have a balanced life for this healthy aging, you should have both in proportion. We will be exposed to some sort of stress where we have to learn how to manage it. You have to expose to eustress, which is going to help in mental well-being of you. Okay, this is with respect to stress. Then is the environment. When it comes to environment, both the physical environment like the radiations, the sun exposure or the pollution what we expose, it has its effect. On the other hand, it is the emotional or the emotional environment. The people, more keep yourself around with the positive minded people. We should have a good vibration around us. You be a positive role model to be that. Okay, you should keep yourself in a good vibe to have a positive note for the others also. Okay, so these are the factors which we have to keep it in mind to progress with a healthy aging.
Yeah, madam. We started with the discussion, it ended with the lecture. And thank you. We will come up with the discussion again. And I like to hear from Dr. Arun Kumar on occupational therapist perspective, the challenges of an occupational therapist and also challenges faced by the patient for either an architectural barrier or a modification or on his role as a cognitive decline, how they can support on those factors. I like to share some words.
Good evening to one and all. Thank you for the opportunity. Regarding the occupational aspect, we can say from morning to evening, we are in the lecture, we see in the physical and cognitive aspect, other things and all. The main thing, as ma'am said, the psychological aspect. Mostly they are abused by verbal abuse and physical abuse, and financially they are abused. So they are abandoned by from the family, the NGOs, and the mostly the older people, though they are very active in the earlier, and due to some physical and financial burden, they are alone into the any trust or NGOs. The NGOs and the trusts are taking care for the things. So they not able to receive the love and affection from the family members and their grandchildren. Recently, we took a survey in nearby 28 old age homes in and around Kanchipuram and Tiruvallur and Chennai. Nearly 750 old people, we are found that mostly they are psychologically, they are very, very depressed. They have the psychotic symptoms like hallucination, schizophrenia-related symptoms, and they need a more financial security and also the love and affections. So this is the main reason. And in occupational therapy aspect, we are engaging for the more architectural barriers and managing the environment with a very safety manner. So arranging the home environmental and the society environment with a very friendly and very user-friendly manner, and also the most psychological support. I can give you a 5-star chocolate, those who are giving the correct answer. Do you know how much of old age population percentage in India? Anyone can answer for that? How much percentage old age population, senior citizen living in the Indian country as per the 2025? Anyone can answer for this? How many percentage? 50. 50 means is nearly, now you have 120 plus crores population. 60 crores old population is living in India. Anyone? 10. Yeah, exactly, it's 12%. 12% of old population, senior citizen living in India. And most of the time, they need a financial support and medical treatment. So you can actually, the good part in Tamil Nadu, in India, first and only one geriatric specialized hospital available only in Chennai only. We are all medical professional. You definitely know about the things because you are there, warriors, you are spreading the message. In Gindi, we have the Kalanjar hospital. It's only for geriatric people, free of cost. All the department, all the physical, mental, all the medical treatment will be taken by the government. And also, the central government have the scheme, they have the old age function, adult pension. It's given by the overall India to improve the financial burden or reduce the financial burden and improve the financial well-being of the old age people. And in the government of Tamil Nadu, they have the Chief Minister Comprehensive Health Insurance Scheme. It's nearly 5 lakhs. That is now Ayushman Bharat. And we need the account and all. So the occupational therapist, the physiotherapist, the nursing professional and the healthcare professional, allied healthcare professional, you have to educate the people and those who are in the community level, those who are in the home level, they have this much of the treatment facility, old care facility and counseling. Even also legal aspect, they have the peculiar law. Those who are abandoned for the parents, they have taken the legal suit. So comfort the occupational therapy part, we are facing not only the physical aspect, the cognitive aspect. Earlier the ma'am, Punita ma'am explained clearly about the cognitive part. They have the memory issues, they have the attention issues, they have the planning and all the things and all. So we have the need of passion and understanding the problem and very politely or very diplomatically handle the things. So still we need our nation need, our grandparents need more artificial barrier support, mainly emotional, psychological support and financial support, and finally love and affections.
Thank you, sir. And may I request Dr. Rajeshri Madam, who is a neurophysiotherapist, to share a few knowledge on.
Good evening all. At the outset, I would like to thank Dr. Pratap sir for giving me this opportunity. I'm very happy to speak about the interprofessional approach, right? Like right now, when we speak about interprofessional approach, it means that within our profession, we are doing goodness to the geriatric population. Right now, we have to mix and match and find out what best can be done for a geriatric population. But are we right now practicing? That's a real question mark. As of a physiotherapist, if you ask me, am I doing a goodness for a geriatric population? Yes. I would list on what and all I am doing for that people, right, and based on my assessment. I address on the strength, I address on their mobility, I address on their balance, and you know what are the ways and whatever you would have learned right from the morning. But whether my program as a therapist is effective is a very big question mark when I don't look into what other professionals are doing. That's very important. As we saw Madam speaking about the cognitive rehabilitation, when I am working with the geriatric population in terms of strength, in terms of a balance exercises, and if I am not very what is the level of cognitive rehabilitation the patient or the older person is getting, I don't think I am really investing a good time with the person. I really need to know what sort of the cognitive status the old man is having, so that I can work along with an OT to know how to plan my strategies based on their cognitive levels. That's very important. If I'm not going to do that, rather if a person is going to have a cognitive problem, which can be remediated, where I can revert it completely, but I'm not doing that, or that is not being addressed, probably whatever the amount of movement rehabilitation I give, the next day when I come, I have to work from the scratch. Probably I'm not very aware that the person is having a memory issue. I have to work from the scratch, and I would be doing the same thing for days together, rather progressing from it. So it's high time that I work with the interprofessional approach. Way back, if you see, geriatrics, the rehabilitation, it all started somewhere in 1977. And you know, we should all be very proud, and it was in Chennai and in our government hospital only it started. Dr. V.S. Natarajan, if you all must be knowing, he was a geriatrician. He started this a separate geriatrics department. He felt the need for a geriatric patient, and he was the one who started a separate department in MMC. And from the government side, he insisted, and every government hospital should have a geriatric department. Not only a geriatric department, but also all the professionals working on it in terms of OT, PT, a special nurse, and so on, a social worker, and so on. And that's how it started. Good that is still functioning, and right now we have come to the level of interprofessional approach. Yes, interprofessional approach is very important, but it needs a long time for us to sit, plan with professionals, and go on how to work and improve the quality of life. That's very important. Ultimately, that should be the outcome what I think of. For that, simply speaking about the interprofessional approach is not going to be really useful. Rather, we need to go in for certain programs, certain standard programs which insist and which says this is how an interprofessional approach need to be planned. That's very important. Right now, as of in our country, we don't have any specific programs or standardized protocols. but there are certain protocols which are present abroad which we need to actually transform according to our needs. There's one evidence-based protocol which is saying that as impact program, right? It is nothing but interprofessional approach which is going to have a practice with complex problems for a geriatric patient. So we need to adapt according to our needs, where you can see all the professionals related to a geriatric population in terms of a geriatrician who's going to head the show, followed by a PT, ST, OT, and you have your pharmacist, a dietitian, a special nurse, social worker, all working. You might ask, why a pharmacist, right? And you know, right from the morning you've been hearing about polypharmacy. So that's a very important component that needs to be identified and dealt, right? So whenever you see a geriatric population with the n number of drugs getting into, and that could also be one of the reasons why his quality of life is decreased. And they say that need to be revisited, that need to be, re-prescribed to reduce the number as per whatever is really inevitable. So that's how every protocol says. Probably I cannot really go in for an expanded version, but please think about, and you people have to start adapting that program here. And that's where our interprofessional approach is really going to be a success, and not just working on a compartmental basis. And we have to go in for a comprehensive evaluation, sitting together, overlapping our assessment as well as our treatment, so that we are not forgetting anything, right? So that's how I try, or I have to think about working with all the other professionals.
Thank you, madam. And as madam was mentioning about Dr. V.S. Nadarajan, pioneer in the field of geriatrics, which started in Chennai in around 1970s, late 1970s. I don't know whether it's a coincidence or not. Today we had a MOU with Dr. V.S. Nadarajan Hospital with Simats, and this happened today with our Savitha Medical College Hospital, and I am very happy to share that information today. And we'll be specializing into geriatric care also. Already there is a geriatric unit, now it will be more functional. And with this association, V.S. Nadarajan Geriatric Specialist Association, it will go further. And we had a multidisciplinary meeting today where our faculty also attended. They were requesting physios, occupational therapists, and nurses for their association to be part of this. So it was a coincidence, or it was a wish, God's wish, I don't know. Anyway, it happened today, madam. Nice to say to you in this auditorium. And also, out of all these expert discussions, and I hope you would have taken some messages. As a part of discussion, I would like to have a few more questions and a few more things to be shared. In a nursing perspective, to look into the geriatric population, palliative care is a very much challenging task, because a lot of complications, life-going situations where a nurse has to go across, not only nurse and also all the health professionals. There need to be a lot of determination and a lot of empathy towards those patients. Not only the patients, and also all you have your grandparents at home. And we need a lot of, as Vice Chancellor was telling today, how they were taking care about their father for last 25 years with a stroke. So he is very good in health. So that commitment as a healthcare professional we need to do. And I request Nursing Principal Vijayalakshmi Madam to share some thoughts on how empathetically to approach geriatric population.
Thank you, sir. It was a very nice one. So I can tell my own experience. I'm having a grandma, the age of 101.
Oh.
Her age is 101. We celebrated the last year 100th birthday, and we have a Anna Abhishekam and other golden and other things and all as per our rituals. You won't even believe, we are having a 24 grandsons from over the country, all over the country. We had shared their, only the few people are joined. Out of 24, 14 people are joined, 10 were from over the countries. All are came into the phone, mobile phone, they were connected. She can recognize each and everyone's name. You cannot even believe that empathy was given to them, given to my grandma. And she was telling, இது யாருடைய குழந்தை, இது யாருடைய son, and யாருடைய parent. That like that she is telling 3 generations. So how you are, we will be meeting her every week. We are having a 7, அவங்களுக்கு பிறந்தது 7 children. So she is having a 7 children, in that 2 are died and only 5 people are alive. They all are 80s. My father died and my one more Periappa is there and he is a 74, and my atta is alive, my auntie is alive, she is 82 years at present. And all are having the wife and other things and all. She will be telling that it is not only a care what we are giving, it is only the share of love what we are sharing to her. That is making her. But the time punctuality, she will be maintaining. It's 1 o'clock. For me, I have to take kanji. She will tell that with the timing. She know good vision she is having. And also we will tell this is the morning. Because she will be in the 4 walls, she cannot walk, but she will be having a wheelchair to move around inside the house. And the empathetical things, what we will tell, we will say good morning in the morning, potty, good morning. All will say good morning in the morning, because only 2 people are around the house. And also morning we will tell that now it has become 12 o'clock, afternoon it is, Amma, it's become 12 o'clock. So good afternoon, the worker will tell that, and good evening we will tell that with the clock. So all those things and all will be symbolized inside the house. There is no call bell or nothing will be there, and she knows what to do it at what time. So the care and the love and the meeting the people and greeting the people, it is more important, and making them to be mobile and making them to be alive in the mentally. Not only in physical aliveness we will be talking about, the empathetical care what we are providing to them, it's making her to be alive. So that is very important. As a nurses, we have to make a role in that.
Thank you.
With my personal experience I am talking about.
Very, very nice to hear, madam, about your family, 101 years. And
still she is alive, yeah, by God's grace.
Okay, madam, thank you. And to Sir Arun sir, as an occupational therapist, I have a few doubt, like as an occupational therapy perspective, if it is a middle-aged person, we give some occupational recommendations, we give some, we'll find out what is their occupation. In that sense, we do some rehabilitation. If it is an old-age person, how will, what will be the theme or part of your rehabilitation procedure or formula? What way you will approach the patient?
Cognition aspect. So the occupational therapists first deal with the cognition aspect, and mostly they need the social interactions and care for the self and the grandchildren, like that. So most family members and the social gathering, they based on the rituals, they based on the cultural, they routinely they want to go for the temple, they go for the family functions, like that. Once they cognitively or physically, mentally they decline, the gathering is affected. As ma'am said, the people are regularly, weekly once they gathering, they engaging, they improving the quality of life. Same, if they have the any difficulty, the social interactions, mostly not in a physical or other things, only for the social interaction, human interactions and social gathering and the functions and the temples, like that. That way we have to engage the person. The making the, we say no, the terminal ills, mostly the happy dying. Same, the happy aging. Making the happy aging socially, it's a very, very important part for the occupational therapy. Through this, we are engaging and make very active.
Thank you, sir. and to Dr. Lavanya, and she was telling on to the 5 key principles of healthy aging, and even youngsters, when we ask them to do yoga and meditation, they find it difficult to flex their body, to do some physical activity. How we can give some knowledge or tips on how to make our patients, older patients, to do yoga or lifestyle activities without hesitation, or without functional limitation. Maybe they will have a lot of functional limitations which would be affecting them to do the physical activity. How can we overcome that?
Yeah, one thing with regard to functional limitation, it has to be designed in a more personalized way. The same lifestyle habitations or the physical activity, whatever is going to be prescribed, will be in a more personalized way for that particular patient. And no counseling session or a therapy which we are giving or advising a single patient is going to match with the other one. It is not a common, or it is not generalized. More customized for each and every, even whether it is a normal or a patient with some pathology or any functional limitation, it is going to be in a more personalized way. And with regard to the first question, to motivate, to improve the motivation of the young minds, it's not only young minds, even the grown-up minds. First, they should initiate it with a supervision, with a positive-minded people or who are already in practice. Now I think more awareness has come with regard to this. The only way to make this consistent is they should feel the difference. You would have seen many YouTube videos nowadays, right? First, you should feel the difference. When you practice it consistently for that 21 days, you will feel the difference. When you continue it for 3 months consistently, 5 days a week, as I told you, others will identify a change in you. And if this is going to continue for 6 months or more than 6 months, you can see a very visible physical difference. Not only in the physical appearance, even in the way you behave, the body and the posture, the attitude, the way you spend with your friends, the way you become successful in whatever work you do. Everything changes. Doing exercise doesn't only change your physique, because you have the neurotransmitters releasing, which is going to impact it in a genetic level. That is what we told about the consistent 20 minutes of exercise, 5 days in a week, which is going to have its impact in the epigenetic control mechanism. This epigenetics can be shifted even in a day or in a week itself. So I was doing exercise, I just left it. Whether I can continue, will I get the same effect like before? Yes, we can do. Nothing is late, even any time. Right now, we can start it. Whatever we have lost or missed, we can get it back again. Thank you.
Thank you. Thank you. And this side, we three physiotherapists, we three all are neuro physios. And as a neurological physiotherapist perspective, we face a lot of challenges in rehabilitating a patient with older age, with functional limitation, mobility, balance, gait impairments, all other complications, the late life complications, all those things. Just to put into short and make it fast, I request Balachandar sir to just add few insights into neuro rehab on elderly patient. How a neurophysio can support a balance and mobility.
Most often we find most of the geriatrics in an Indian population or a scenario, there is no chance, as you say, that they don't have privacy of space at the home, wherever we provide them a community care. And most often, as you all have heard, most of them have community lab, they have falls, commonly strokes are more common, and post that they need to have a rehabilitation setup, they need to come and go. And in Chennai or in India, we find that the caretakers or the relatives, they don't have time to attend upon them. The only thing is that they call upon the fellow professionals around who can attend them at home care or domiciliary care. Most often a physiotherapist is called for. whatever physiotherapy is going to be delivered within the four walls is not sufficient enough for a rehabilitation program of a geriatric to come back to his normal lifestyle. The reasons are the limitations within the professional. The professional delivering the physiotherapy care, what I find ethically, they don't do to the level best possible from their side, nor they undermine the evaluative part of it. They just deliver what they have learned, be it a passive movement or a stretching for a stroke. Will that it not be enough? And there is no therapist to share and spend time with the patient to assess properly, to find what their problem lists are and what to attend. The reasons could be the therapist himself is very busy on the first part, or lack of financial support from the patient side. They feel that the therapist who is delivering most often, for this amount of fees what we give, this is enough. And this will be in this way only. A stroke patient will have the same kind of lifestyle. This is not the end point of it. The reason is on the other part, when your assessments are really good and you have a listed problems to attend, and when you are empathetic towards your patient, this assessment will provide you a long run of time. And believe me, whatever service you extend to them, like as they said, for some other grandparent or someone, be it someday your parent or you may also need such kind of assistance. So have that in mind and deliver your therapy program, whichever it is, in a planned and ethical way to meet their needs. Because beyond all the professional support, whatever we give, we need to be humans first to deliver a humane care for this aging population. Today we are almost black. The next day, as madam said, cell proliferation occurs. The next day or the other day, you are going to go gray. So understand that and give respect to the people who are expecting your support and provide the best of the care which is possible from our side. Because we are qualified not only to deliver only the professional support, even the psychological, mental support is part of our professional training. So try to impart that in your everyday's program. This is what to be a take-home message, because healthy aging is not only for one person or the persons on this side of the dais, it's for everyone. So learn to give respect and give at much support to these people for their healthy aging. This will be a great support to everyone. Thank you.
Thank you, sir. May I request Dr. Rajeshri madam to give final conclusion on interprofessional approach in this concept.
As sir was saying, not every member in the geriatric population is getting the privilege of a rehabilitation or a program or being addressed for all their problems, right? But when you compare 10 years back and now, yes, the rehabilitation has improved and we are working in compartments, right? That is for sure. We don't have an established interprofessional approach as of now. Probably here and there we might, but it is not happening everywhere. We are working in compartments. I am doing good for my population as of PT. But then whether it is 100% success, whether the outcomes are good, whether I have really addressed the quality of life, whether I have improved, it's a very big question mark. Probably if at all, I work in an interprofessional approach, probably whatever the outcome that I expect would be 100%. But when I work in compartment, it is just going to be somewhere on 50%. I keep working, putting a lot of effort, but the outcome is not good. So as younger generations, you people have to really think about this. Is a very important field which need to be addressed as equivalent to the other fields or other areas that we work as therapists. So we have to really establish, as I was saying, lot of protocols, lot of programs that has to include all the professionals. Every single component or the problems faced by a geriatric population need to be addressed by specific professionals. I cannot do justice in all areas. So I need professionals who can work on all the areas. We need to sit at regular intervals, speak about that person and find out how good I can help. Only then I can improve their quality of life, right? So we have to stress upon this interprofessional approach and keep thinking how to go about in the next few generations.
Thank you, madam. Thanks. I thank each and every one of the panel members for sharing their insights into various dimensions of healthcare and multidisciplinary approach towards healthy aging. And all these the questions or discussions happened, everything were candid, and there was no any preliminary discussions. All happened as such in this stage only, and it's the discussions or the insights which were given from all the members were purely out of their experience. So it is very very insightful process what they felt in their service or as their professional approach. They shared their experience, and on behalf of all the students here and also the organizing team, I take this opportunity to thank each and every one of you from the bottom of my heart for sharing your knowledge to our delegates, those who are registered here. Thank you once again.
Thank you.
And please you can. And we have one more session. Almost auditorium is going to be empty, and there is one international speaker session which is planned, and also tea and refreshment is also available. That is a recorded video which will be played to you, and it will be a quick session, and after that we can have a leave. Meanwhile, refreshments is also served. Those who want, you can just have and come back quickly. Thank you. May I have the representative? I think representatives of the colleges are available, at least one representative from the colleges. We'll be listing down the college names so that one representative from the colleges, participating institutions. Many colleges participated online. Probably the people those who are present here, we are listing those only, and so you can come and collect your certificates and mementos.
Now I request Professor Dr. Pratap Sugandra Babu sir to present memento for Jaya College of Physiotherapy in recognition of their active participants and valuable support in the Sniper 2025. And I request to collect the memento for Vagdevi College of Physiotherapy. I request Mr. Vishal to come and collect the memento on behalf of UCO College of Physiotherapy. Next, I request Mr. Vishal to come and collect the memento on behalf of UCO College of Physiotherapy. And I request Dr. Kavita to collect the memento in behalf of SBV College of Physiotherapy. It's my immense privilege to introduce Dr. Mugilan Balaji sir, CEO of Physiometronics, an enthusiastic personality with a deep interest in the field of physiotherapy. With his active involvement, he has graciously supported this event. We will sincerely thank him for his valuable contribution for his sponsorship. It's none other than Dr. Mugilan Balaji sir, CEO of Physiometronics, to join us on the stage. Thank you, sir. We invite St. Joseph College of Physiotherapy Principal Dr. Kumaresan sir. As we continue to explore the multifaceted nature of aging well, we now turn to the presentation that promises to tie many of these elements together. We are honored to welcome our next speaker, Dr. Raj Kumar Krishnan Vasanti, Head of the Physiotherapy Program at INTI International University in Malaysia. With over 20 years of leadership in the physiotherapy education and neurorehabilitation, Dr. Rajkumar brings a truly global perspective. He is not only an accomplished academic and researcher with over 70 Scopec Index publications, but also an innovative leader who has structured significant research grants and contributed to the international healthcare dialogues. A dedicated advocate for the holistic and digital interventions in the rehabilitation. His work spanned clinical practice, education, and community service, making him exponentially qualified to speak on the topics today. Please join me giving a very warm welcome to Dr. Rajkumar Krishnan Vasanti as he was presenting on holistic approach to healthy aging.
Today I will be sharing about healthy aging from a physiotherapy perspective, which comprises the holistic approach on how to have a healthy aging when we are in our baby boomers life. especially in an Indian context with our growing elderly population. This is the timely manner and essential discussions. So once again, I would like to thank Savita University for inviting me for this event to share my knowledge in this platform. So when we look into this healthy aging is not just about living longer. It's all about how we live better during this time. Okay, so the World Health Organization defines the healthy aging as maintaining the functional ability. So that's the key word. Maintaining what? Maintaining the functional ability that enables the well-being in elderly age. Okay, so if you want to be an healthy aging, so we have to make sure that the elderly people are maintaining the functional ability. Functional ability means being independent. Okay, being independent in different aspects, because we are speaking all about the holistic aspect of healthy aging, right? So we have to make sure that elderly people or the baby boomers maintain the functional ability in terms of physical, in terms of social, I mean in relationship or with the society, with the community. Mentally they are fit enough, and also spiritually they are functionally able. Okay, so this is what in overall we call it as an holistic healthy aging is all about. Okay, before we go into the different holistic aspect of healthy aging, I like to shed some knowledge to everyone that what statistics is speaking all about this aging worldwide, and also what's happening in India. We have to know. So there's a demographic trends on this aging. Okay. So when we look into this demographic trend currently, if you look into this elderly population projection in India, India will have over 300 million elderly people by 2050, by the year 2050. With the longevity comes an increase in chronic diseases, mobility challenges, and the need of structured healthcare and support system. So you can see this graph over here. Okay, so this graphs you can see over here. So by 2050 we are expecting about 347 millions of people will be under this elderly category. Okay, which is comprises about 20.8% share in the whole population. Okay, so you can see this is the latest statistics from India Aging Report 2023. Okay, they said that the share of the senior citizen will nearly double from 10.7% this year, which is 2023, to 20.8% in 2050. So by the end of the century, senior citizens will constitute over 36% of Indian population. Okay, so with this we are expecting issues related to elderly, like we may expecting chronic diseases, we may expecting mobility related challenges among this elderly people. So what we as a physiotherapist or what we as a healthcare professional need to incorporate or need to be ready with, we need to be ready with a structured healthcare and support system. And if you look into this population, if you see in our Indian demographic profile, so most southern states are have a high elderly population when compared to northern states. This is a trend we are expected to be continued. Okay, so by 2020, by 2021 versus 2020, 2036. So this sensex, you can see over here what has been projected among Indian states. So why I'm insisting on this aspect is because we can see which area, which state. So according to state policies, central policies has to be stipulated, and we have to be ready with the healthcare infrastructure. Not only healthcare infrastructures, environmental structures, everything has to be in place at least by 2036, so that we are able to cater for our elderly people to be independent and live the holistic life, I mean better life during the elderly or during the healthy aging. When we look into the global perspective of this elderly population projections, you can see over here 22% of the population by 2050, they are expecting will be elderly population. Okay, so currently we have about 7.8 billion world population. So among in this, so we can see the age group. If you look into this red color over here or orange color, which is like 65 years and above, 10% of the people will be elderly. So worldwide elderly population will be about 1.5 billion people. When compared to 2019, we see only 700 million people. But when you go into 2050, the estimated number is 1.5 billion. In this, even India is not still under this category, but we are also growing towards elderly populated or elderly people nation, I mean near future. Okay, like what I said in my previous slide, the demographic wise. So currently if you look into Europe and North America, so where we have 20 million of people will be expected, and 261 million people from East and Southeast Asia are expected to be the highest elderly populated region as of 2019, and this numbers will be exponentially increasing by 2050. So again, why we need to know the statistics? So we need to be ready to cater this people, okay, to be independent, like WHO say, functionally abled person. When we look into this holistic aspect of healthy aging, between physiotherapy and healthy aging, physiotherapy addresses the key concerns of aging, okay, in terms of mobility, in terms of balance, in terms of reducing pain, in terms of making them independent, okay, or functionally able. So this allows, or it allows the elderly individual to stay active, and they can socially engaged, and also they can be functionally abled, okay, and functionally abled in the environment. Okay, so as physiotherapists, our role is to prevent, maintain, and also to rehabilitate. Okay, so to rehabilitate the people who are in the healthy aging, or to be a part of this healthy aging community, we have to focus more on the mobility, independence, and quality of life. So as a physiotherapist, that's our primary role, okay, in this holistic aspect of healthy aging. And also we have to make sure that elderly people are integrating with the community and also the family-based care, because this two, community and the family-based care, will give the moral support psychologically, or we can say as a mental support. Okay, so we encourage the baby boomers or the elderly people to be actively participate in the community activities, and also the family has to engage the elderly people in all the day-to-day activities, so that this will help them to be functionally abled during the healthy aging, or to be part of healthy aging. So as I discussed earlier, that A true or a truly holistic approach must consider physical, psychological, and social, and also very important spiritual dimension. Okay, why I'm saying the spiritual dimension? Because in India, culture and family support plays an vital role or an additional role, or we can say as an additional central role, which is a pillar, okay, to be a part of this holistic framework for aging population. So like I said just before, physical well-being, psychological well-being, social engagement, and spirituality will comprise in this holistic care or holistic aspect of healthy aging or aging. So now let's dive into a more deeper aspect, like what's meant by this physical well-being, or what's meant by the psychological well-being, what's meant by social or spiritual well-being, how we are as a physiotherapist going to incorporate this holistic aspect into our daily practice. Okay, so when you look into the physical well-being, which is number one, okay, so what this physical well-being speaks all about is like, it speaks about strength, balance, flexibility, and we can say as endurance training are the foundation of physiotherapy in aging, because we know that elderly people will have issues on all these aspects. Okay, physical fitness kind of aspect, of being physically active kind of aspects, like strength, balance, flexibility, and endurance. So as a physiotherapy, this is the foundation for us to train the elderly people or the aging population. So this eventually will help us to prevent many things in elderly populated people. Okay, falls, which we know already are the leading cause of disability, or sometimes it's a leading cause of activity limitation, and also it's going to be the leading cause for prevention is critical. Okay, leading cause of disability, and also prevention of this fall is very critical. Okay, when we look into this physical well-being, so how we can incorporate this? So like I said already, it's very simple. We have to have our exercise protocols, and we can use our modalities to benefit the aging populations, like benefits of regular exercise or benefits of being physically active among the aging population is very important, because it's going to help us to improve the cardiovascular health, respiratory health as well, and it helps us in strengthen the muscles, enhances the flexibility, boosts the mood, and promotes better sleep, contributing to a higher quality of life. Okay, safe exercise practice is also very important for the older adults, because implementing the safe exercise practice, such as starting with the low impact activities and seeking guidance, can help the older adults to maintain the mobility while minimizing the risk. And moving into next, which is very important, also under this physical well-being, which is nutrition and diet. Sometimes this can be a separate aspect, but I put it under the physical well-being itself. Okay, because nutrition and diet is very important. Okay, so we must have proper balanced nutrition, because a balanced diet is crucial for maintaining the overall health of the older adults, as it provides what essential nutrients, right? We need nutrients, so that's going to support our immune system of our body or immune function, and also it helps us to reduce the risk of many chronic, or we can say as a many chronic diseases, or we can say as many non-communicable diseases. Okay, so not only that, in terms of nutrition and diet, we also have to look on the hydration of health. Okay, hydration of health is very important when we are becoming older. Okay, proper hydration is vital for various bodily functions, including temperature regulation, joint lubrications, and to eliminate the waste from our body. So this is going to influence the overall physical performance of the body, and also this is going to contribute your mental performance, so which can impact your psychological well-being also. Okay, so for that, the impact and the importance of nutrition and diet is crucial, which we really need to look into it, and to have a proper balance and a proper hydration has to be vital for our various bodily functions. Number 2, which is psychological well-being. Okay, so what we can do in this psychological well-being? Movement is not just physical, right? We all know movement is not just physical, it influences the mind. Okay, relaxation techniques like yoga, breathing exercise, and activity based therapies, okay, help to reduce many psychological issues, or we can say mental issues like anxiety, depression among or in the elderly or older adults. Okay, so we have to make sure the mental health awareness among this older adults. Okay, so the common mental health issue in aging, we have to address that. Okay, like depression, anxiety, cognitive decline. Okay, so often exacerbated by life transition, loss of loved ones, or chronic illness. Why we get all these psychological issues? Like I said, life transitions, loss of loved ones, or chronic illness. Okay, so our mental illness strategies for mental illness has to be properly and effectively be promoted, okay, for mental wellness. How? Like, for example, social engagement, physical activity, mindfulness practices. This mindfulness practices is quite more popular nowadays, and seeking professional help to address mental health challenges. We can see a counselor, we can see a psychologist, we can see a psychiatrist, okay, to overcome or to make some strategies to improve our mental wellness when we are in older adult, or when we are as an older adult. Number 2, cognitive engagement. Cognitive engagement is very important. Like I said just now, cognitive performance or cognitive ability will be start declining when we start becoming older. So it's important for us to lifelong learn things, new things. So when we start learning new things, this lifelong learning will foster cognitive resilience and encourages curiosity and helps maintain the mental sharpness, and proving essential for a fulfilling and active aging process. So that's very important. And also activities or physical activities, exercise, which is going to boost the cognitive functions. We can include like kind of activities like puzzles, reading, learning new skills, and participating in group discussions, so we can debate and argue, and we can stimulate our brain, and improve the memory. So this boosting our mental ability will lead to improve our cognitive functions and reduce the declining in cognitive function as well. Okay, so this we have to really engage the older adults or older people to follow the necessary when they are in the healthy aging, or when they want to be have a proper healthy age. And number 3, which is very important, which is social engagement and spirituality. Okay, group of physiotherapy session foster, I mean group or not a group of physiotherapy, I'm sorry, it's a group physiotherapy sessions because it's like a group activities or group exercise. Okay, physiotherapy session will help or will foster the peer support and socialization. So when we start having this peer supports, we start mingling with them, we start speaking, we let go our stress, we mingle with them, we talk to them. Okay, so this can reduce the loneliness and keep the elders motivated to stay active. Okay, so that's very important. So in India, spirituality is deeply integrated into the life, so we all have to accept that. So say for example, yoga, meditation, and family rituals give the elders a sense of purpose, enhancing the overall well-being. So we have to incorporate, we have to invite the elderly people to be part of this activities or this events, which is very important. So like as I said just before, like building social connections, like group discussions, group therapies, okay, importance of community and relationship. Establishing a strong community ties can foster the sense of belongingness and enhances the emotional support. It also contribute the overall well-being, particularly maintaining the mental health. And also like the elderly can volunteer and being a part of the social activities, participating in volunteering or various social activities that offers opportunity for the individuals to connect, share experience and contribute positively to the society, which can immensely fulfilling and make them motivated. Okay, and in terms of spiritual and cultural dimension, like I said, we have to explore the personal belief and values and engage them. Number two, cultural activities. Like I just now said, these cultural activities will be or will provide a platform for the senior citizens to be creative and maintain the cognitive functions and promote uh, their quality of life and promoting the social interactions within their communities. So we have to incorporate this spiritual and cultural dimension into their day-to-day activities or day-to-day life. So as physiotherapists, we offers diverse modalities or diverse techniques to make the older people to be physically active or be functionally able. Okay, so we can start with an aerobic training for the heart health, I mean to cardiovascular fitness, resistance for muscle preservation, yoga, tai chi, or something kind of like even we have square stepping exercise for balance. And we also can use certain electrotherapy modalities to relieve any pain related issues or problems. Okay, so we can incorporate this kind of exercise into their day-to-day activities to make them physically and functionally abled. From an Indian context, we have to look into the fall preventions because fall prevention is one of the most common cause to make them disabled or to make them activity limitation. So the risk assessment has to be done properly in terms of home environment or comorbidities. Balance training, gait training or re-education has to be trained. From an Indian context, use of household modification and community awareness has to be trained or imparted to the patient and also to the caregivers. That's very important. In caregiver, in the sense, it can be a separate caregiver or it can be even a family members. So we have to make sure this has been performed to prevent the fall prevention among the elderly citizens. So when we look into in Indian aspect, we know already community-based models plays one of the very important role because of so many rural areas are in India. Okay, so the National Program for Healthcare Elderly provides a framework, okay, which is where the NGO and also the local health workers are the vital in reaching the rural communities, okay, where physiotherapy access is limited, because in rural area the physiotherapy access is very limited sometimes. So we have to make sure that the NGOs or the local health workers playing a vital role in bridging this rural and urban differences in physiotherapy delivery. Okay, so we can incorporate with many advanced things in current stages or current trends which is happening. Okay, so one among that is the role of technologies. Okay, so why I'm saying over here is because role of technology is opening new doors in many aspects. Okay, so say for example tele-rehabilitation, digital physiotherapy apps, or we can say like wearable devices for active monitoring. So this is going to connect the therapist with the rural patients, and the wearable tracks the activity, tracks the daily activity. Okay, but the digital literacy remains a barrier in our country. So what we can do, so we have to build, or we have to educate the elderly population how to be more digital literacy. Okay, so digital literacy is very important nowadays. So we have to engage them in many aspects of digital related tools so that we can engage them remotely, even though we are very far away in urban areas, but we can remotely monitor them through tele-rehabilitation or digital apps. So, but they have to be digitally literated so that they can use it and benefited from this role of technologies, because nowadays internet penetrated everywhere. Okay, so we have even a statistic saying like internet is all over the world. Okay, so we have to incorporate this role of technologies into the elderly people, whether wherever they are, whether they are in the rural or they are in the urban, because sometimes this role of technology, or in WHO they call it as digital interventions, where it can surpass the healthcare delivery challenges. Sometimes adherence of exercise, patient won't adhere sometimes after we prescribe certain things, but we can remotely monitor whether they are adhere or not. Sometimes distance, like rural and urban area, where the challenges, they can't travel financially, they may not be fit enough to travel or to afford for the treatment as a face-to-face session in the tertiary hospital. So we can use this digital technologies which can reduce the time for even for the therapist, or it can reduce the time for the patient itself. Okay, so these challenges all can be overcome by using this role of technologies. So we can incorporate this role of technologies into this elderly people to have a healthy aging. So when we look into the overall recommendations from what we have learned all this few minutes in terms of holistic care or holistic aspect, so we have to promote the active aging through physiotherapy based community programs, policy support for physiotherapy services in geriatric care, empowering families and caregivers with knowledge and skills is very important. So I would like to conclude by saying that healthy aging, again, it's not just maintaining a function, but it's maintaining the function, being independent, and with dignity. Okay, so physiotherapy plays as a central pillar in this holistic elderly care. We are the central pillar of this elderly care. Okay, so we have to be prepared for it. and India's culture and community the support, strengthens and support the successful implementation. So we have to be ready for adding life to the years, not just years to the life. With that, I would like to thank everyone for listening to listening to my session. And also I would like to thank Simats, Savita University, Savita College of Physiotherapy for giving me this wonderful opportunity to share my knowledge to everyone. Thank you again for the wonderful opportunity. Have a great day.